هذا كيف ضغط.
حضرتك حضرت الزملاء الباقي نزلوها؟
لا، قالوا أميرة تكون ما عندها USB بترسلها على
طيب
الجيميل. بس أبو عبد العزيز أنا عندي البريزي أخاف أنحس كذا برزنتيشن يكون جاهز وكذا بس.
اي ممتاز. ليش لا؟ بس خلينا شو اسمه نسوي له شير من عندك.
دقيقة.
ابو عز
إيه بس نفس البرزنتيشن حق الزملاء نجمعها هنا أحسن. والله واحد بس اللي أعطاني، باقيين يقولون بيرسلونها إيميل، ما عندهم USB. ما USB زيادة. إيه بس في هنا USB حق USB. بس أقصد من اللي
خلاص
أول
تبدا ترحب بالناس.
والمحاضرة الدكتور
إياد واللي
بس ترى
مديرية الدكتور حبيبي.
جاهز محاضرتك إياد.
أنا محاضرتي جاهزة.
بسم الله.
خليني جوي اللي برا.
طيب مو فين تمران خله
تبغى تحط الشاشة الرئيسية ولا؟
يبغى اسوي شير سكرين.
هي أعطيتها البيوغرافي. اي والله يا ليت كذي.
طيب
وكل اللي في السيشن هذا المفروض انه البرزنتيشن حقتهم جاهزه. انا اول واحد اللي بعدي اظنهم انترناشونال في حق ايجيبت.
ايوه ممتاز. وهو محاضرته موجوده مسجله. طيب خلاص.
يعني كل
موجود.
السيشن الاولى جاهزه.
الدكتور حربي يقدم لنا 3.
طيب ممتاز. ايه
والله ما ادري.
2
سام
عزيز 2 احمد عزيز.
سام.
اي يلا. طيب بسم الله.
Can we start اللي برا شباب؟ Let us start because people are waiting in the wait. Okay, we'll start 2:30. 2:30. أنا أحسب لها 2 أنا. إيه كويس.
الثاني ترى اعطيتك احنا نستخدم ذا صح؟
حاجه بس تصير ما جاب لك هاي ها
بس عادي نفصل ذا
ما ادري عن شو حقه شيء
ظاهر هذا نفس العادي في سلك
مو ضابط لا تحط السيارة
لأنه ما في إلا اثنين
مو ضابط لا مو ضابط
إلا اللي بيدخل عادي
لان هذا شو اسمه
أتوقع إنه يطلع إن شاء الله.
والله ما ادري يا عيال نقدر محاضرة
هذا المشكلة
انا قايل لك
يبينا نوصل اثنين
صعب نفس الكلام بالله
هذه الكاميرا البروجيكت
عادي نفسره ونرجع
ايش تبغى تفصل؟
عريض الطاقة ما بيدخل
طيب ما يدخل
لازم نوصل اثنين
عادي ما في مشكله.
أول شغل الموسيقية
وش
طيب
نبغى
نبغى
طلع طلع
هو تلقاه في الفولدر تحت فايندر شو الفايندر هنا أول واحد اللي في بعد ايوه الحين نكتب معه اسحب هل هنا
اساس بيجان برزنتيشن رتب حسب
احط اس بيجيك على طول هذا اساس بيجن
بي دي اف انت حاطه.
لا اساس بيجان برزنتيشن باوربوينت
ايوه
هذه
كان تسحبه اسحب على الديسكتوب وتلقى بيجيك اول شيء
طلع الاسم
انت الشيء خلاص
خلاص انا بدور ما مشكله بس طلع
الاشياء اللي
يو اس بي
هذه
طلع
وش يتاكد
بقفلها كلها ما عليك بقفلها كلها بس طلع اليو اس بي عادي
واضح. طيب بس اتاكد انها موجوده في
ابد شوف الديسكتوب راح ديسكتوب. اول واحده صح؟
لا انت سوها
سوي
ديت باي.
ديسكتوب عندي حاسه هذه هي اساس مكان، اسحب اللي فوق.
الحين خلاص ما في باقي حد. اي خلاص تحب بس
بس
تسوي
خلني
project.
اسوي ايجكت من هنا.
عشان كان مفتوح، عشان يصير مفتوح بنفس البرنامج ما يعطيك خروج عام.
خلاص
ممتاز.
خلاص بس عشان اضيق عليك. يلا
ركب
خلني بس خلني ارتب انا بحط إيميل.
ممتاز.
خلني ارتب الشاشه.
يرتب الشاشه. ثاني ندخل على اي صوت عندك. يوتيوب وش لا لا حط فوق الصوت اللي بعده. صوت يكون يصير.
انا عندي كيف تغير عربي؟
ما يصح تحرك المكان يا ظافر، المكان
ممكن كمان هذه، لكن الافضل ان نحط عشان نحط الصوت.
ما دخلنا اطلع.
بسم الله الرحمن الرحيم.
هذا من اللابتوب هذا ولا من
عارف
كويس؟ خلاص ممتاز. اجل خلني اشيل كل الاشياء اللي تسكتين عشان
نبدا ظاهر. المحاضرة وينها؟ طلعتها شورت كات ولا تو؟
محاضرتك بس حتى لا هذا التوعية يا دكتور رياض.
رياض، دكتور رياض، دكتور رياض الحديدي.
وينهم؟ ممكن تدخل الابل اي دي.
وانا دي يقول ما يمشي.
من كيس يعني.
ليه؟
لا صح، لاني كتبت واحد خطا.
انسخ في مكان
شوف كذا يقول
وتاكد
خطا.
الايميل.
الايميل صحيح، لازم من هذه ما تكفل.
ما تكفلت.
قلت شوف
لا 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 لكن
انت
كمل.
الباسورد بس.
بديت تشغيله.
ايه ايه كذا مش. طيب هذا وشو اللي هو باسورد؟ باسورد هذا فيس. نفسه. غريب.
كنت
خلها باك جراوند.
ممكن تطفي تشغل مرة ثانية أو تطفي.
يقدر اطفي ريستارت.
ريستارت سوي ما في أصلا.
بقدم مجال اجتماعي.
طيب
سيف.
اكتب لا لا ما يحتاج كنسل.
هذا وش؟
طيب نصير هكذا.
كورس
باوربوينت.
وين هي؟
ديسكتوب.
هذه
يعني تحط معاها يعني.
هذه
في
لا هذه
زوم. خلينا
اوكي.
سبشير.
خلي البرزنتيشن بعد 5 دقائق ما ها؟ بس برحب بهم وكلمهم. احسن ظاهر. ها؟ كيف؟ لازم.
عشان الناس تسمع. بسم الله.
كذا تبي.
خلاص.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. Welcome everybody today to our third international pediatric inflammatory bowel disease. On behalf of the board member of the SAS Began, I'd like to welcome everybody to our meeting. Just will highlight a little about SAS Began. This is your society, SAS Began, the Saudi Society of Pediatric Gastroenterology, Hepatology and Nutrition, established 2008 and have 4 terms now. The 5th term starts on the end of December 2020. Our umbrella is the Saudi Commission, الإدارة التنفيذية للجمعيات الصحية. Okay, there are many people who's working on behind all of these societies, more than 50 societies in Saudi Arabia. There are some regulations, يعني معايير أداء كفاءة الأداء. We have to apply those regulations, those standards for our working. Those basic regulations, basic requirements, and additional requirements. Initially, we start our term that our society was in lower, F, yani failed, and after that, we start to improve our work in the SAS Began. We have acute, like as we have patient in ICU, we have acute management and long-term plan. So we try to improve, our quality by applying all the basic requirements. Those like اللائحة الأساسية، استراتيجيات، all of these are requirements of Saudi Commission. هي السعودية عندها متطلبات والشغل شوية حقيقة يحتاج إدارة قوية، يحتاج infrastructure. فit will take time حقيقة، لكن الحمد لله we could manage many things الحمد لله. Then in first quarter we reach 18, in the second quarter we reach 11. If we stay between 10 and 20, this is okay as first year that we are building our society. Board achievement, new generation. What do we mean by that? We mean that alhamdulillah we have new people. Like this symposium, most of the speakers are new generation speakers, and also we communicate with others people. We communicate with different hospitals, military in Jeddah, universities, and different institutes. They are sharing in this activity, and also we try to be more professionalism. What we mean by that? There is different committees. كل لجنة كل شغل كل واحد بشغلته. لجنة الإعلامية، منتدى الإعلامي، عندنا السوشيال ميديا دكتور ظافر، منصة تطوع دكتور محمد التمران. ف each person or each member has his own work. الدكتورة من العاصمي نائبة الرئيس، دكتورة دلال الأمين المالي. This is the working And also, if you remember, on 10th of April, General Assembly في الجمعية العمومية was run by the new people. دكتور من العاصمي، دكتور ماهر الهطلاني، دكتور ظافر الشهري، دكتور محمد التمران. All are a new blood in the society because we are thinking to build the society for the future, not for ourselves, as a senior, Those who are board members, I would like to thank them for their great effort. حقيقة Dr. ظافر الشهري behind all of these technical support. حقيقة we are lucky in the society. Everybody, every member in SASBGAN should be proud to have such like Dr. ظافر الشهري. I'm sure everybody in this room, every member of SASBGAN had his effort, had his able to give something, to have mashallah power. It is your society. الجمعية جمعيتكم يا جماعة. الجمعية لكم ليست لأشخاص معينين. It is your society. زي ما اكتشفنا مواهب الدكتور ظافر، اكتشفنا مواهب الدكتور ماهر في الاستراتيجية، اكتشفنا مواهب الدكتور محمد التمران، اكتشفنا مواهب الآخرين. اوكي، فجميع كل واحد يقدر يدلي في هذه الجمعية. منصة تطوع very important. رؤية 2030 لازم نكون عندنا مليون متطوع by 2030. كلكم عندكم أولاد، كلكم تحتاجون تطوع. لما يخش الجامعة يحتاج ساعة تطوع. عندنا منصة تطوع مع الدكتور محمد التمران. سجلوا أولادكم في منصة تطوع، خلوهم يشاركوا، ياخذوا ساعة تطوع تنفعهم في التوظيف، تنفعهم في القبول في الجامعات. الآن في بيج كومبيتيشن زي ما أنتم عارفين على القبول وعلى الوظائف وعلى شيء. فالجمعية للجميع، الجميع. احنا نرسل ايميلات ما في ريسبونس، زين؟ كثير كلموني ما افتح الايميل، ما افتح الايميل بعد شهر او بعد اسبوع. يو هاف تو فولو صراحه. عندنا السوشيال ميديا، عندنا تويتر، دكتور ظافر جزاه الله خير، he is covering everything. It is for you. Most welcome everybody. Thanks everybody and special thank for Abvay company for supporting and contribute in this meeting. Really we are grateful for Abvay for their support. And حقيقة special thanks for Dr. Dhafar and Dr. Ali Hedel. They are conducting this meeting, organization, scientific. We have 5 international speakers, alhamdulillah, and we have our local speakers. Now, because short of time, I would like to take opportunity to introduce our senior member, one of the founder, Dr. Harbi Shawush, هو أحد مؤسسي هذه الجمعية. Dr. Harbi Shawush will be the moderator for the first session. Let us welcome Dr. Harbi Shawush.
السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. First, I would like to thank Dr. Mu'ad for his speech and nice introduction, and thank you very much for SASBGAN for organizing this event. And gonna start our the first speaker, Dr. Iyad Saud al-Hidayti. Dr. Saud, he got his fellowship in Pediatric, gastroenterology and hepatology in 2020, Dr. Saudi, he's a Saudi board of pediatric awarded in 2017. Currently, he's working as a consultant pediatric gastroenterologist in Khamis Mushat and maternity and children hospital. He's gonna talk about Saudi IBD, pediatric IBD in Saudi Arabia. And my co-chairman, Dr. Abdulaziz Al-Ahmari, is going to introduce the third speaker and will receive your questions. And so any question can be left to the end of the, after the third presentations. I'd like first to ask Dr. Iyad to start his presentations.
شغله وطفى اسكتب معي طيب أو نكتب في السيرش. طيب شغله أول شيء ما هذا والله يدخل نكتب إيش رأيك؟ كيف أسوي له شيء؟ لا خلاص ما احتاج ما في مكان لا لا
Okay, Bismillah ar-Rahman ar-Rahim. I would like to thank Dr. Muad, chairman of SASPIG, and the organizing committee headed by Dr. Ali al-Mahedib, and for giving us the chance to present and giving the new faces a chance to present for the committee. My topic is about epidemiology of pediatric IBD. Epidemiology of pediatric IBD. And to start talking about epidemiology, before talking about national data, we have to review what has been published and historical review of IBD around the world. So IBD has become a global disease. Actually, there has been a report published in Lancet 2017 by Sue Wing and Gil Kaplan, who's a famous and pioneer IBD epidemiologist. They published this global map of IBD reviewing the incidence and prevalence around the world. And you can see the highlighted red color is the country with highest prevalence around the world, like what we can see in North America, part of Europe, Australia, and New Zealand. And with this high prevalence, you can see in the developing country and newly industrialized country, there is still rising incidence rates because of the development and shifting. And this gives us a hint about where do you live and where do you stay really has an association with developing pediatric or IBD in general. Also, this work for ulcerative colitis as well. To talk about IBD, we have to review the historical timeline. So Kaplan, in this figure, he framed the timeline of the IBD since it discovered. So we can see Sir Wilkes, which was an English physician, he reported the first case of IBD back in 1875. Then as the time progressed, we can see there is still rising in incidence and prevalence of IBD until the early era of 20th century. You can see that ulcerative colitis and Crohn's disease become more evident. By the end of the 20th century, you can see that ulcerative colitis has stabilized, but Crohn's disease is still rising. By the end of the 20th century, you can see that IBD has become a global disease. Yes, thank you. IBD has become a global disease by the starting of the 21st century, and there is still rising in incidence in the developing country with stable prevalence in developed countries. I cannot move forward. This is again, the figure summarize the incidence and prevalence as historical frame. Since the start of the first reported published case by Sir Wilkes, the incidence and prevalence start to grow more and more in the Western world and the developed country, while in the blue color, as you see, the newly industrialized country and developing country, now you can see since the starting of the 21st century, it starts to become more evident and reported more and more. So to talk about epidemiology of IBD, we have to know the stages of IBD as reported by Dr. Gil Kaplan. So we have to know the current map, what is the determinant of IBD or interplay that play a role in increasing or decreasing IBD incidence and prevalence, and stages of IBD epidemiology. So the current map, this has been published recently in 2021. They divided the map into 3 areas. The area in the green color, which is the emergence case, yellow color, acceleration in incidence, and the orange color is the compounding in prevalence. The green color, as you can notice, this is the area where the cases are started to emerge and to be more evident and reported as sporadic cases, like what we see now in Africa and some parts of Asia. The yellow area is the area where there is accelerated development and there is more and more reported incidence rate and increase in incidence and prevalence. But as you see, even though there is increase in incidence in those yellow area, but the prevalence is still low. The orange area, the area with the highest prevalence, they talk about an important term which is compounding prevalence. I will talk about it in the next slide. So to know the interplay or what is the determinant of IBD, we have to know that we have incidence, prevalence, and mortality. What drives the incidence or increase the incidence is it is driven by environmental and economic factor. Environmental, some are well known in the environment, and the economic factor because of the easy accessibility now to the healthcare system and the availability of more endoscopy, it will unmask more and more IBD cases. This thus will increase the incidence rate, which is denoted here as the water from the tap, and it will fill more and more the prevalence, which is the water in the sink. With time, if there is mortality, it will decrease the prevalence rate. This is again the important term: emergence, acceleration in incidence, compounding prevalence, and prevalence equilibrium. We can see that now there is emergence case in Africa or some part of Asia, starting in the 21st century. But this was in the early 19th century in Europe. But now Europe has reached the compounding prevalence. Acceleration in incidence, this is in developing country, like the yellow area, what we saw in the map. And the compounding prevalence, this, although the incidence rate is plateau or sometimes decrease, but the prevalence is building up and piling because, as you know, the IBD is a disease of low mortality, and if they live more and more, they will the prevalence will grow more and more. They suggest or speculate that by the time of 2050, the mid of the 21st century, when there is balance between the mortality rate and the number of new cases, the prevalence will plateau. So now, after we reviewed some important terminology and we know what has been published, let's see what is the world incidence and prevalence of pediatric IBD before going to the national data. This is a recent study published by Quizzing in 2021 March. It showed that there is area which reach highest incidence and incidence like North America and some parts of Europe. And there is area with low incidence rates, as we see in the light blue, like Saudi Arabia and some parts of Asia. And this figure combine all the continents around the world, and you will see that North America is still the one with the highest incident rate, and the other part of the world still, they are growing more and more in incidence, but the prevalence is still low. So let's talk about IBD in Saudi Arabia after reviewing the important thing internationally. So epidemiology in pediatric IBD in Saudi Arabia, it has been developed, and we start to see it more and more ever since the discovery of oil and changing the lifestyle and more urbanization and westernization of our society. The data has been published ever since 1993. When you review the literature, I found like more than 90 results of pediatric IBD in Saudi Arabia. It's ranging in different topic, interesting in incidence and prevalence, etiology, burden of the disease, treatment safety and response, outcome and cost, mimicker of pediatric IBD, and patient care. It's hard actually to review all of these topics, but I will focus on the incidence and prevalence, and I will highlight some topics. So the incidence and prevalence of pediatric IBD, as I said, the first emerging case of pediatric IBD was published back in 1993 by Dr. Tahir Tunisi in King Abdulaziz University, as he reported a 17-child with Crohn's disease seen in King Abdulaziz University Hospital, who was diagnosed by endoscopy and histopathology and with good satisfactory response to steroid therapy. After they went into remission, he reported that a lot of recurrence has occurred back then. And he suggested that there is more and more cases of pediatric IBD start to appear in Saudi Arabia. This is one of the important study which was done at a national level by Dr. Al-Mozan and a group of senior doctors at multiple centers around Saudi Arabia. It was published back in 2014. Actually, the importance of this study, it was the first study at a national level to study the incidence rates of pediatric IBD in Saudi Arabia. And back then, it was the first in a developing country. So this study was run between 2003 and 2012. It includes 340 Saudi child from the age of 0 to 14. The incidence rate per 100,000 individual was 0.2, 0.27, and 0.47 for ulcerative colitis, Crohn, and IBD respectively. So to see the important table at this study, conversion of ulcerative colitis and Crohn disease in relation to age, they noticed that ulcerative colitis was more evident in those who's less than 10 years of age with significant p-value. And Crohn disease was more evident in those older than 10 years of age with significant p-value. In term of gender, there was no there was more of male predominant, but statistically it was not significant. This to see that there is increase in incidence and prevalence of pediatric IBD in Saudi Arabia with peak of reported cases in 2009. And as I mentioned, the incidence rate for ulcerative colitis was 0.20, and for Crohn disease was 0.27, and IBD overall was 0.47. At that time, when they compared the study with different study around the world, actually this study was 5 times lower than those in the United States and Denmark. But interestingly, there is a Danish study which was done 15 years before this study, and it reported the same incident rate of pediatric IBD there, which was 0.2. So are we heading to the same incident rates? Because of the time's sake, I will only mention that there is also important other topics which mentioned in our literature and contributed by Saudi doctor in the literature in incidence and prevalence of IBD. There is a study published by Dr. Al-Husseini and other center for the early onset IBD. It was a multi-center national study run between 2003 and 2012 to mention the clinical pattern of pediatric very early onset IBD. It included 350 IBD patients, 76 children, which represent 21.6% younger than 6 years of age, was diagnosed with IBD. And of note, what is important in this study, that infantile or toddler onset Crohn disease showed more frequent isolated colonic involvement than the later onset Crohn disease. With positive family history was seen more common in ulcerative colitis patients with significant p-value. To compare ulcerative colitis and Crohn disease, they noticed that ulcerative colitis is more common in early onset IBD, while Crohn disease is more evident in late onset IBD. And to describe the phenotype of ulcerative colitis and Crohn disease, as you can see in figure A, the left side, they noticed that according to Paris classification, the ulcerative colitis was interestingly pancolitis compared to the later onset ulcerative colitis, which is isolated to the proctitis, which is E1. For the Crohn disease, they noticed that it involved the colon. In terms of etiology and trigger, the literature, the Saudi researchers have contributed in the literature by studying all the aspects of the triggers of pediatric IBD. There is study about the genetic part, the dysbiosis, the immune response, and environmental trigger. Just to take an example, this is a study of Mendelian form of Crohn disease in Saudi Arabia, which reveals there is a two new mutation, which was run in 2 families. The first mutation was LACC1. They presented with very early onset IBD and arthropathy. And the other one was GAL3ST2. This is the environmental factor, and this is an example of a study which showed environmental factor as pre-illness diet as risk factor for pediatric IBD. And this is a two study which study the fungal the dysbiosis overall. And this is a study as an example for a trial of management in the immunity parts and how to as the disease is autoimmune disease. Also, the Saudi study have interested in the burden of disease, for example, impact on linear growth, as this study, which study the impact of pediatric IBD on linear growth, published by Dr. Al-Mawzan and colleague. Because of the time's sake, this is an example only of important studies about burden of the disease. Also to mention, our study is updated, and also in the pandemic, there is a study to study the pediatric IBD and COVID-19. Another example of the topic in our literature about IBD. Also, there is studies about pediatric IBD outcome. Also, the mimical of IBD. As you can see today, there is some presentation about mimicals. Also, the patient care and how to transition the surface, and some advices about other diseases. So this is the effort and work of the Saudi literature in pediatric IBD, and how we see more and more cases and how we contribute in different aspects of IBD. And courtesy to Dr. Al-Mawzan, he established the IBD registry with the senior consultants from all over the kingdom for better documentation and registration of cases. And I hope one day we will have and follow the example of the Improve Care Now, ICN, which is the United States IBD registry. They success to lower the steroid dependent by 97%, 82% are in remission, 95% have growth satisfactory, and 57 patients have sustained remission for at least 1 year, and 91 show satisfactory nutrition. It includes 97 pediatric gastroenterologists, and they are taking care of more than 30,000 kids with IBD. So I hope one day we will contribute more, and we will have our own registry, which will help both the patient, the physician, and the society. This is my presentation. Thank you.
Thank you, Dr. Iyad, for elaborating of epidemiology of IBD in Saudi Arabia. And our next speaker, Dr. Muhammad Azz Rijal. Dr. Muhammad is a head of pediatric gastroenterology and hepatology unit, and he's a professor of pediatric faculty of medicine in Mansoura University Children's Hospital, Mansoura University in Egypt. And he's going to talk about pediatric IBD in Egypt. So it's yours, Professor Muhammad. You have 25 minutes, please, to finish your presentation, Dr. Muhammad, please.
السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بحضراتكم. I would like to thank the SISPICAN for the kind invitation to be with you today. Special thanks to Dr. Ali El-Mehedeb, Dr. Muaz El-Tariki. It's a great honor to be with you today and to join you again. Today I will talk about IBD in Egypt. My agenda today will be case scenarios, differential diagnosis, and the challenges we face here in Egypt in diagnosis and management of cases of IBD. First case will be very early onset IBD presented with perianal fistula. The first case is male infant aged 7 months. At the age of 3 months, the patient started to have bloody diarrhea with low-grade fever, and the mother observed a mass protruding through the anus during defecation. The mother asked medical advice. She received multiple courses of antibiotic and metronidazole, and it changed the milk formulas from LF formula up to the amino acid formula. However, the patient does not show any improvement. The mother asked surgical advice, and the surgical consultation go for surgical repair of the rectal prolapse. Actually, this scenario, I saw it 3 times. That's the patient with very early onset IBD, seen first by the surgery, and the surgery took the decision to correct fistula or correct rectal prolapse. The patient continued to have the bloody diarrhea and failed to gain weight. At the age of 6 months, he was referred to our hospital after developed a perianal fistula. The patient has positive family history of IBD. His sister has Crohn's disease, diagnosed at the age of 5 years. This is a picture of perianal area. When the patient was referred to us, it shows multiple fistulas at the perianal area. The lab for this patient shows anemia. His hemoglobin was 7 grams per deciliter, and his calprotectin was very high. The albumin was low. The patient received bagged RBCs and albumin transfusion, and he was prepared for colonoscopy. Actually, we did a limited colonoscopy. The aim is to just take biopsy to confirm diagnosis of IBD. And we don't go for band colonoscopy or ileoscopy. We take a biopsy from these lesions. The endoscopy shows multiple deep ulcers involving the rectum and the sigmoid. And the histopathology confirms the diagnosis of IBD in the form of dense mixed inflammatory cells infiltrations with evidence of cryptitis and presence of crypt abscess. Unfortunately, the patient passed away just 1 month after the diagnosis from sepsis. We don't have the chance to start the treatment of very early onset IBD. The second case is very early onset IBD associated with Hirsch-Sparring disease. This patient was 11 years old. He has constipation shortly after birth. At the age of 6 months, he was diagnosed as a Hirsch-Sparring disease, confirmed with rectal biopsy. The patient undergo the surgery for Hirsch-Sparring, and the patient after the surgery have recurrent attack of enterocolitis with failure to thrive. At the age of 1.5 years, the patient has a severe attack of enterocolitis and toxic colon, and the patient undergo subtotal colectomy. And the pediatric surgeon sent the colon for histopathology, and the surprise that the colon shows evidence of inflammatory bowel disease. The patient was admitted to the pediatric ICU for more than 2 months, and he has a very bad course. He was maintained on IV steroids and received Imuran and Bintasa. After 2 months, he was discharged from the ICU and maintained on oral steroid, Imuran and Bintasa also. However, this patient was difficult to close the colostomy and even developed abdominal fistula. The patient was maintained on Remicade for more than 5 years. However, he was not able to maintain a continuous courses because Remicade was not available all over the time. 2 years ago, he was shifted to Humira, and again, the fistula failed completely to heal. Since about 1 year, the patient died from sepsis. This is picture shows the fistula in the anterior abdominal wall and the ileostomy. As you can see, there is a big fistula in the anterior abdominal wall, and there was augmentation of the intestinal lobes, and the patient passing the stool and the urine from the opening in the front of the abdomen. His histopathology shows epithelioid granuloma, which is suggesting the diagnosis of Crohn's disease more than ulcerative colitis. Actually, I searched for the association between Hirschsprung disease and IBD. We have two categories. The first category is Hirschsprung disease with very early onset IBD, and this is very rare presentation. It's just case reports. And the other scenario is a patient who has his Hirschsprung disease, and with time he developed IBD. This is a case report published in ACG Case Report Journal, Volume 7, about very early onset IBD in patient with long segment Hirschsprung disease. There is a nice paper published in Journal of Pediatrics 2 months ago about the increased incidence of inflammatory bowel disease after Hirschsprung disease, a population-based cohort study. It was 2 studies. In the first study, from 716 children diagnosed as Hirschsprung, 18 developed IBD. And the percentage was more in males than females. The males was 77.8%. And the incidence rate ratio was 11.9. In the second study, the OR of having Hirschsprung disease before the diagnosis of IBD compared to the control was 74.9 in Alberta and 23.8 in Manitoba. And they conclude that Crohn's disease was more common after Hirschsprung disease than ulcerative colitis. And they concluded that IBD can emerge in more than 2% of patients with Hirschsprung disease, and it is more common in males than females, as Hirschsprung also we know it is more common in males than females. And IBD is much more common after diagnosis of Hirschsprung disease than in general population. The third case was very early onset IBD presented with deep perianal fissure. Actually, this patient was 6 years old. He was presented with severe deep perianal fissure extended from the scrotum to the sucker area. And the patient was seen first by general pediatrician and by dermatologist. He received multiple courses of topical measures to treat this deep perianal fissure, and the stool was containing blood and mucus, and they will think this blood and mucus come from this deep perianal fissure rather than from the colon. At the end, they refer the patient to our unit for second opinion. Actually, when we do the blood workup for this patient, we found that his calprotectin was very high, and the patient prepared for colonoscopy, and it shows the patient has Crohn's disease. This is the picture of the deep perianal fissures, which was extended from the sucker area to the scrotum. The histopathology shows severe ulceration of the mucosa of the ileum, and there is fissure ulcers in the histopathology. And this confirms the diagnosis of possibility of Crohn's disease. The third case is very interesting case. It is very early onset IBD with Alagille syndrome. Our first case is Mazen. He is 3.5 years old. This patient is a known case of neonatal cholestasis. He was diagnosed as Alagille syndrome. The patient has neonatal cholestasis shortly after birth. He was referred for evaluation of the cholestasis. X-ray shows butterfly vertebra, ultrasound shows small hypoplastic kidney, echo shows left peripheral pulmonary artery stenosis, and liver biopsy was done when he was 45 days. It shows bile duct posty, so the diagnosis was Alagille syndrome. Later on, the patient did gene study and it confirms the diagnosis. This is the butterfly vertebra, and this is the ultrasound report, which shows a mild enlarged liver and shows a small hypoplastic kidney. And this is the echo, shows peripheral pulmonary artery stenosis. And this is the liver biopsy, which shows paucity of intrahepatic bile duct for differential diagnosis, and the criteria was fulfilled to diagnose Alagille syndrome. This is a picture of Mazen when he was 9 months. It shows triangular face, depressed nasal bridge, deep-seated eyes, pointed chin, and protruded ears. This picture taken with permission from the family. And this is a gene study which was positive for GAG1, which is specific for Alagille syndrome. However, the patient at the age of 2 years started to have bloody diarrhea on and off. He was diagnosed as a dysentery, received multiple courses of antibiotics and metronidazole, which is the normal practice here. However, the patient was not respond. CBC shows anemia, thrombocytosis, calprotectin was very high, ESR was very high, and the plan is to go for colonoscopy. And the colonoscopy confirms the diagnosis of early onset IBD. It was done at September 2019. The patient started on steroid, prednisolone 2 mg per kg, azathioprine 1 mg per kg, and pentasa 50 mg per kg. The patient has bad courses. Actually, he has frequent relapses on steroid, so the plan to shift to Humira, and the patient started for 3 months on Humira. It started with the dose of 40 first, then shifted to 20 every 2 weeks. However, after 3 months of starting Humira, he has a severe attack of colitis, and he needs to be admitted to the ICU. On admission, the patient received treatment for acute active colitis in the form of solmedrol 1.5 mg per kg for 5 days. The attack was controlled, and he was prepared for another endoscopy because the patient developed the complication of cushingoid, and the decision was to think again to start Humira for another trial. This is a colonoscopy of this patient. It shows multiple pseudopolyps formations with deep ulcers and the loss of the normal vascular pattern of the colon. There is deep serpiginous ulcers, and this may explain how the colonoscopy is difficult in this age group, because these patients are very highly susceptible for even spontaneous perforation with use of air insufflation. For this patient, we did whole exon sequencing testing, and besides the JAG1 gene for Alagille syndrome, we find another gene for familial adenomatous polyposis. I don't know whether this is significant or not, but they type it as a class 1 pathogenic. The current situation for Mazen now, he has failure to thrive. His weight and height is less than 5th centile, and this is expected for Alagille syndrome. But he has developed the complication of steroid. He has cushingoid manifestation. The patient received Humira 6 doses till now, plus steroid. He is maintained on 1 mg per kg, plus azathioprine and pentasa. but actually he is uncontrolled. He still have bloody diarrhea in any attempt to stop the steroid. He getting worse. Actually, I am stuck in this patient in the current situation now. The second part of the presentation will be the differential diagnosis of infant presented with bloody stool. Actually, we are now in the era of overdiagnosis of allergic colitis and cow milk allergy, and this patient may be presented with bloody stool. The problem is cases of very early onset IBD may be diagnosed as allergic colitis and may be managed as cow milk allergy, and this make a late referral of such case. Actually, the histopathology is pathognomonic in allergic colitis in presence of extensive eosinophils in aggregate, even presence of eosinophil abscess as a collection of eosinophils. The second thing is infectious colitis, and it is very easy to differentiate by presence of regular crypts and the infiltration usually neutrophils, not chronic inflammatory cells infiltrations. The third is bilharzia colitis. It shows crypt irregularity, which is one of the findings in IBD, eosinophilic infiltration, which is one of the allergic manifestations, but the hallmark is presence of bilharzial ova. Actually, we don't see a lot of cases nowadays, but every now and then we may see one case. What are the challenges we see here in Egypt for diagnosis and management of IBD? What are the challenges of IBD in Egypt? We have 4 types of challenges. Number 1, there is no national registry, rate referral, challenges in diagnosis, and challenges in the treatment. No national registry, we all face this problem in our countries, that we don't have a national registry that we can follow up the patient and tracking them, especially if they are moving from one center to another center. Actually, rate referral is a common problem in our practice, as the first one who saw a patient with early onset IBD is usually the GP. He is usually not oriented with this category of the disease. He is more oriented with allergic colitis and cow milk allergy, so usually he diagnoses it as a cow milk allergy, and this make the referral late. To solve this issue, we put this topic of very early onset IBD in the curriculum of Master, MED, and board degree, and we try to make presentation about the very early onset IBD in the general pediatrics conferences, so increase the awareness of the general pediatrician about this disease. We have a challenge in diagnosis. Number 1, the colonoscopy. There is a limited number of endoscopists who can do endoscopy for children less than 2 years because it is very tricky. Usually the colon easy to be perforated and it needs special skills. So this may make the diagnosis late. Actually, in Egypt, we have about 5 centers who are able to deal with patients with very early onset IBD at Cairo University, Ain Shams University, Mansoura, Alex, and Zagazig University. Also, we have a problem with competent pathologists who can identify this entity of the disease and differentiate it from other causes of bloody diarrhea. Also, competent immunologists, as we know, about 25% of very early onset IBD is treated with immune deficiency. So usually we will be more than happy if we have a competent immunologist with us in the team. As regards the lab workup, the immunological workup is available in Egypt. It is easy to be done. However, the gene study is not available, and we needed to send it outside or did it through a private lab, which usually is very costly. We did a collaboration with Boston Children's Hospital, Harvard, and we were able to send our samples there, and we were lucky enough to have some result. This is abstract which was published in European Society for Immune Deficiency about a novel homozygous mutation in interleukin 10 receptor causing a severe form of infantile IBD. Challenge in the management. Number one, there is poor compliance of the patient for the treatment. It is a long-term disease, and especially if it need to give a biological therapy. The availability of the biological therapy, it is now easy in Egypt because it is covered with the insurance, so we have no problem in this issue. However, we don't have a clear guidelines for management of early onset IBD, for how long, and adjusting the dosing. This may be a problem. Thanks for your attention. This is Mansour University Children's Hospital, and this is the pediatric GI team. I am very proud to work with such a great team. Thank you very much.
Thank you, Dr. Mohammed Az, for the interesting presentation and the challenging case that went through. And now I would like to welcome Dr. Ma'moon Al-Awad. He's the Chief of Pediatric Gastroenterology, Hepatology, and Nutrition, and Director of Inflammatory Bowel Disease at Sidra Medical and Research Center, as well as Associate Professor at Weill Cornell Medicine in Qatar.
Thank you, Mr. Speaker. I would like to thank my colleagues in the Saudi Society of Pediatric Gastroenterology for the invitation, specifically Dr. Ali Al-Muhaydib. And it's a great pleasure for me to be with my colleagues in Saudi Arabia, whom we had very strong relationship for quite a few years. And it's nice to see some of the colleagues around as well. My talk is about very early onset inflammatory bowel disease, and I'm glad that Dr. Mohammed Abbas has made a very nice foundation for my lecture with his very interesting cases of very early onset inflammatory bowel disease. I hope that you don't only see very early onset IBD, Mohammed Abbas in Egypt, because it's a very challenging and difficult condition to treat. First, this is our nice Sidra hospital in nice Qatar. Still a bit hot here in Qatar, about 40 degrees now, the temperature. But we are hopefully getting over the summer soon. My talk today would be focused on very early onset IBD, our understanding of very early onset IBD, and this would take us to the classification of IBD in pediatrics and in adult, and the diagnostic workup, which would help a lot of us to understand more about IBD and how to manage them. And I'll take you through the journey of very early onset IBD, which has been going on for a while, and I touch base on some of the very early onset conditions. And then we speak about options of treatment and the experience of the treatment so far and some challenges. So although IBD, as we heard earlier, has been available or around for almost 2 centuries now, and pediatrics IBD has been well known, very early onset has not been well established in the early ages until sometimes this century. So the classification of IBD, although I was there for a while, the first description of classifying inflammatory bowel disease came in the 70s, just talking about the site of the disease. And in the 80s, people spoke a bit more into behavior of the disease, whether penetrating, stricturing, or inflammatory. The First description of a good classification came from the Rome classification in the 90s, which combined both the anatomical and behavioral things, which was the previous studies. And the first description of the age into the equation of inflammatory bowel disease came at the Vienna classification, which talked about less than 40 and above 40, in addition to the location and behavior. But the bigger breakthrough was in the Montreal classification in 2005, where people dissect the IBD to less than 17, 17 to 40 and above 14. And there was again first description of upper GI as entity and perianal disease as separate entity. So the Montreal gave us a bit more of insight because it stratified the research projects and the treatment prognosis. So people start to look at the inflammatory bowel disease in a bit more objective way in relation to the site and the behavior of the disease and the need for surgery and so on. But the biggest breakthrough which we have describing the early onset IBD was in the Paris classification, where it talked about children less than 10 years from 0, which wasn't described at all before, and then the pediatric IBD, which is 10 to 17, and then the adult or the early adult, so 17 to 40 and above 40. The good thing about the Paris classification is dissect the distal disease or the proximal disease into 3 areas: above the ligament of teres and the distal part of the terminal ileum and beyond that. And the classification, important to mention that it's relied entirely on the ulceration. It didn't take into account any histological or radiological examination. You can see here just a description of the difference between the Montreal classification and the Paris classification for Crohn's disease and for ulcerative colitis as well, which gave a bit more of a structured way of doing any research or conducting research in a more objective way. The first use of the Paris classification came into this multi-center study in Europe, involving 582 patients, and gave us again a bit more depth into the classification of inflammatory bowel disease in children of pediatric age, and showing that the majority of cases actually for Crohn's disease are mainly alveocolonic disease with a bit more of some colonic, like a quarter of the patients, and the rest of them distributed into other places. Also, we learned that from the study that the granuloma present in about 43% of all inflammatory bowel disease in children, which wasn't clear in the past. The description of inflammatory bowel disease or very early onset inflammatory bowel disease came at the work of Levine in 2013, and subsequently with the work of Holm Olling in Oxford, showing that we now talk about very early onset IBD that's occur less than 6 years, and that's what we're talking about. There is an infantile type, like the cases that Dr. Mohammed Abbas mentioned. These are less than 2 years. And then there is a neonatal type, which is very early or extremely early in the first 28 days of life. So these are the way that we ended up with very early onset inflammatory bowel disease. Although in the past we talked a lot about the interaction between genetics and environmental factors and gut microbiota, from our understanding later on became much more evident and clear that we don't talk just about genetics. We talk about monogenic and polygenic inflammatory bowel disease. The monogenic is predominantly the younger children, the less than 6 years, which is a very early onset, and the polygenic is the standard IBD. And this helps us as well in terms of understanding the genetics by either for the monogenic, we do the whole genomic sequences and whole exome sequencing for the particular condition, so we target panels, while with the polygenic, we do a whole genome-wide association sequencing. It's clear that the genetic component of the disease is under the influence of either the genetic component of the disease itself, for either pure genetics or epigenetics, or related to the microRNA difficulties or abnormalities, while the inflammation of the gut and the immune system and autophagy specifically interact together to influence the genetic of the inflammatory bowel disease. There is a clear interaction between the gut microbiota and the environment in relation to the immune system, as you can see. It is clear from the work that done by Holm Olling that the genetic component seems to be, as you can see in the sketch in front of you, that on the left-hand side, we are talking about more genetic component of the inflammatory bowel disease, which give us the early onset IBD. And on the other extreme, you get the notion of the environmental factor, and in the middle, you have the ordinary or the common inflammatory bowel disease. All studies are working on the genetic of the very early onset inflammatory bowel disease. Talk about the onset in the first few or 6 months of life. And that's usually the disease is severe, as we heard earlier, pancolonic, and increase in complication with fistulizing disease, needing surgery. And the disease is really difficult to treat, as we heard from Dr. Abbas. And male predominance in most of the cases, because most of the diseases are X-linked. And there is a overlap at some point between these conditions and immune deficiency. Again, many studies came after that to show the predominance of the monogenic defect in the very early onset inflammatory bowel disease. There is a very clear indication of the level of the immune system affected in different conditions. You can see on the left-hand side of this screen, talking about the primary immune deficiency, which most of them present in a similar way with GI symptoms, while on the right-hand side, we can see still some of the pure GI conditions like IL-10 signaling defects and IPEX. They can present in a similar way with defects both of the innate immune system as well as the adaptive immune system. Many description has been made so far, more than 50 of the very early onset IBD monogenic diseases for different part of the immune system, either in the mucosal level or in the deeper level or in the lymphocytic or lymphoid aggregates level. This nice say here is just describing when to suspect very early onset IBD and what to do with it, and it's called young age matters most, and it just, as you can see there, it's a multiple family member might be involved, autoimmunity, failure to thrive, failing the conventional treatment, some endocrine involvement, recurrent infection, severe perennial disease, and activation of the HLH inflammation, as we see in the ZIAP, obstruction of atresia like the TTC7, and abnormality of dental and hair and other things like TT37A, and tumor or development of tumors. Again, here just more extensive way of trying to make sure that the people are vigilant and aware of it. The early surgery, the conventional treatment failure, and atypical findings in histology, typically the apoptosis, that's the very alarming signs, and again, the development of LHH and tumors. So how do we diagnose very early onset IBD? It's a very challenging thing, but The important thing that we do the common process, so where you take the good history, look at the family members, and you do your endoscopy and your inflammatory markers, and work through excluding any infections and excluding any other conditions, as mentioned earlier by Dr. Muhammad Abbas, like food allergy. Looking at the normal workup, we do the full blood count. This will just give you the initial assessment to look at primary immune deficiencies, if you have neutropenia, thrombocytopenia, for CGDs, and looking for immunoglobulins, and that will give you some idea about the primary immune deficiency, like hyper IgM and so on, and lymphocyte subsets, which will give you the clear picture of SCID. And then we look at the specific things for FOXP3 and ZIAP mutations and IL-10 mutation that will help you in this kind of categories. Looking into the next stage, which we go deeper into genetics to try to delineate those conditions with targeted panel sequencing or whole genome sequencing. And the next stage will be to do some more functional analysis, because as we know, when we do whole exome or whole genome sequencing, we get multiple genetic mutations, and you want to find out if these are really functional or non-functional mutations, and that will be done through the examination. This is just a busy slide, but it just delineates the process of looking at what to do with inflammatory bowel disease until you get or you reach the stage where you can make your mind about the genetics and the function of the genes and the effect of the mutations that you come across. Many studies came after people made that kind of clarity, and we reported this back a few years ago on targeted panel sequencing for those patients. So we developed a panel that target all the inflammatory bowel disease and tell you which one of them are picked up on the initial one before we go to exome sequencing or whole genome sequencing. The color study is a multi-center study that we are lucky to be part of it here in Doha with our colleagues in Oxford, in Cambridge, and in London, and in Edinburgh. And it's looking at early onset inflammatory bowel disease and patients with more than one family member of inflammatory bowel disease, and refractory treatment to inflammatory bowel disease that needing more than one biologic. Once we've done the genetics, obviously, as I said earlier, we go through the process of getting to the function to make sure that we are doing the right things, and it helps us as well when we target treatment therapy. Exactly the same here, which we delineate the different type of the inflammatory or functional monogenic examination. And again, this helps us greatly to show or demonstrate clearly the increasing incidence of picking up genetic defects in early onset or very early onset inflammatory bowel disease. And again, a bit more of details about what we really expect to see in those patients in terms of phenotype and outcome. And to put everything together, once you look at the clinical presentation, you look at genetics, you look at the functionality, and then you look at the way therapy can work and how it can be monitored. Again, to put it in a bit more clearer picture, we look at the multi-center or multi-system or multidisciplinary team that should be involved in the management of those cases. As you can see, we can't manage those patients by ourselves. We need our colleagues in immunology, we need our histopathologists, and we need a good collaboration with Center for Stem Cell Transplant. This is very clear that impaired mucosal defects can affect the inflammatory bowel process in very early onset IBD, and loss of tolerance and epithelial defects. And that again help us in the future to choose the right treatment, because some of these conditions might not respond well to the stem cell transplant, which is the option of treatment for those patients. Again, we have clear publication about the correlation between genotype and phenotype in very early onset inflammatory bowel disease for those presenting less than 2 years of age. And that helped us again to delineate the treatment and the investigation process. Let's go through the journey of very early onset inflammatory bowel disease, because obviously this was described a long time ago in the 80s in a Ferris family of 17 members of mainly boys who had severe inflammatory gut conditions over 3 generations, and 8 of them died. And this raised the first time the suspicion of the X-linked type of this condition because they were all boys. Subsequently, we found that there is some association with diabetes in an X-linked group, which I presume at that time this was IPEX. And then there was girls started to show evidence of very early onset IBD, and that was the likely explanation of those with IL-10 deficiency, where girls also can get the disease, and it's not only X-linked. Subsequently, Onsworth is the first one who described the autoimmune enteropathy at that time with those patients with no immune deficiency. And description of the autoimmunity as such came from McCarthy in the 80s as well, with severe partial villus atrophy and circulating autoantibodies to the gut enterocytes. So by that time, people were talking about 3 categories, either X-linked group or associated with eczema and endocrinopathies, and this like IPEX, isolated autoimmune disease with autoantibodies, but no other GI, non-GI involvement, and then the non-X-linked group, which is like the IL-10, which we mentioned. The role of the T regulatory cells was crucial in this, in the development of early onset inflammatory bowel disease. And it required the FOXP3, and the FOXP3 again needs the IL-10 to express more. So this is the interaction between all those things we're talking about. So we knew that the FOXP3, if it's non-functional, it'll give you hyperactivation of the T cells and autoimmunity to those conditions. And on the other hand, when it's become non-functional, that gives you primary immune deficiency. The autoimmunity with or without hearing loss that was described at some point with positive autoantibodies, but no evidence of primary immune deficiency. And the first description of a real very early onset inflammatory bowel disease came by describing the intractable ulcerative colitis of infancy. So there were so many publications from John Walker Smith's group in the Royal Free and from Great Ormond Street, Dr. Miller and Dr. Susan Hill at that time. But as I said, the first description of a real inflammatory bowel disease or early onset inflammatory bowel disease described by Ian Sanderson with a neonatal onset in those consanguineous family and severe mucosal disease and flask-like ulcer, which is very characteristic, like we saw earlier, and lack of response to immunosuppressive treatment. And there was no underlying immune defect. My colleague, Dr. Neil Shah, in the past described this more in detail, the typical ulcer and the tendency to develop lymphoproliferative disease with just simple immunosuppressive medications. And my other colleague, Nicole Thapa, published the first study to show that the bone marrow transplant or stem cell transplant is a curative for this condition before the people delineate the genetic of the intractable ulcerative colitis of infancy, which is now is known as IL-10 defect or IL-10 receptor defect. And although IL-10 was a classical knockout mouse for Crohn's disease in the lab, this was very well known for a long time. People only describe it in humans in 2009. And subsequently, we describe more of the IL-10 mutations and how does it contribute to the early onset inflammatory bowel disease. This is a typical flask-shaped ulcer. We see it, and Dr. Abbas showed very live demonstration of it. And when you look at it, it's called very effluent ulcers. Look like a cauliflower when you see the ulcer here. It's a very deep punch out ulcer like this. And that's a very typical, sometimes we make a diagnosis just by endoscopic assessment before we get the genetics. What does IL-10 do? Normally, the lipopolysaccharides come into contact with the mucosa and get taken by the toll-like receptor 4, and as a response, you get some inflammatory cytokines response. And in the presence of IL-10, this will be neutralized, and you get a negative mechanism of pro-inflammatory cytokines. The defect you can get in IL-10 is either for the IL-10 itself or IL-10 receptors, and that will stop the counter effect of the inflammatory process, and that's why those patients will end up with very severe inflammation. And this is a typical appearance again, and the demonstration of the IL-10 mutations. And this is remind me with the case of Dr. Abbas just mentioned now, with a very extensive ulcer or renal disease and very severe dense inflammation, as you can see on the lower end. And after stem cell transplant, this is curative for this condition. You can see it's completely healed, and you can see the mucosa recovered back to normal. If you look at the IPEX, as the name say, IPEX is immune dysregulation, polyendocrinopathy, enteropathy, and it's X-linked. The features, usually diarrhea in the first 6 months of life with associated diabetes and renal involvement, hematological abnormality, and other autoimmune disorders. Again, you can see here a very severe inflammatory process in affecting the hair, the skin, and the nails. The other condition, which is a ZIAP, which is XLP2, an X-linked condition, mutation lead to the ZIAP deficiency, and it lead to HLH, and it's overwhelming viral infection. People get splenomegaly, colitis with panenteric disease, and variable presentation. This is a picture on the ulcers, different from the IL-10 mutation. And to diagnose it, obviously, you need your genetics and you need your functional analysis. This is the functional analysis on both the XLP1 and XLP2. And here you can see this is the normal expression of the CD8 in a normal patient, a normal control. And these are the patients. On the right-hand side, you can see the ZIAP, and on the left side is XLP1. And here are the mothers of those X-linked. You can see the mothers are different from the normal population and different from the patients as well. The same description here as well for the expression of other markers as well for ZIAP. So where are we with treatment? The first description of the stem cell transplant, as I said, was from our group in London, in Great Ormond Street. And then that time we presented our data between 2000 and 2008, and looking at what did we do with stem cell transplant with those patients. There were 6 patients presented at that time with different type of either IPEX or intractable ulcerative colitis of infancy at that time, before we get the IL-10 and IL-10 receptor, and then other forms of inflammatory bowel disease as well. So all those patients who had stem cell transplant, they survived. They were well. Donor chimerism was good in 5 out of 6, and they were off TPN and symptom resolved. And as I said, it was curative for those type of patients. The only patient that we didn't show complete cure of his disease was had mixed chimera, so wasn't completely engrafted. He was having some TPN and biopsy showing some improvement. Subsequent to that, in 2009, we went to became a national center for stem cell transplant for inflammatory bowel disease. And at that time, we used the criteria of refractory gut disease, very early onset with associated immune dysregulation, but no immune deficiency, and poor quality of life. And usually the decision was taken by a multidisciplinary team. So that time, 22 patients entered, listed for transplant 10, and there were 4 waiting at that time. Again, you can see mixture of the conditions, IL-10, ZIAP, IPEX, and multiple other conditions. So genetic causes were well delineated in those patients because we did part of our normal workup was full genetic assessment. And the last description from Greta on the street was children with 15 children had stem cell transplant, and some of them before the NCG assessment, and some of them after the NCG assessment, and different variable diagnoses, as you can see. And those who had known genetic defects are usually minimal, and the majority had no genetic defect, as you can see, and as again you can see here. And after the transplant, at the time of this transplant, 75% were on TPN, and some of them needing support, and most of them were on immunosuppressive medication, as we've seen from the Dr. Abbas cases, and some of them were on biologic at that time. This is the type of the transplant they had, either matched sibling donor or matched family donor or matched unrelated donor or mismatched donor, and the type of the cord that we use, either cord blood or peripheral blood stem cell or bone marrow transplant. The outcome of the transplant, 6 remain alive and well. We lost 2 patients from that group. GVHD was a problem. None of them had ongoing GVHD. The cases that we lost was one of the IPEX patients died with unexplained pneumonitis, and the other one died who retrospectively was diagnosed to have ZIAP, was with overwhelming encephalitis, GSE encephalitis. You can see the survivor was for those who are treated initially, and this for the whole group together in the blue line. Morbidity for those patients, as I said, GVHD was there in 4 out of 10, and infections were common, and pancreatitis was seen in some patients. The nutritional group, 4 out of 6 had come off TPN, as we said earlier, and no deterioration of the inter-fed patients, and immunosuppressive treatment was successfully stopped with
دكتور مأمون الوقت.
So this is the first 2 patients, as I mentioned before, the intractable ulcerative colitis. They sent their wedding of one of them, Mike, and the other one. These are the 2 first patients we described in the literature with stem cell transplant, and they are, getting married now. These are the parents, as you can see on the right hand side. They are of Gypsy origin from Ireland. So other options of treatment is either we have to look for other options, because immunosuppressive treatment can lead to infections and LPD in those patients, and we know that they are not effective. There's a promising effect from infliximab in early onset inflammatory bowel disease, vedolizumab as well in inflammatory bowel disease. And the recent one, which is just about 2 months ago, came one of the JAK1/2 inhibitor. That seemed to be the most promising one because it's taken orally, and it's going to be a big breakthrough in the treatment of inflammatory bowel disease in those patients. The challenges for the futures, hopefully we might have some more of mesenchymal stem cell transplant and gene therapy. But the real challenge for us are more patients that we see without any genetic defect. And the group of the perennial disease are the biggest one that we are dealing with at the moment without much success. And hopefully some of them are responding to anti-TNF therapy. As Dr. Abbas was mentioned earlier, access to hematopoietic stem cell transplant is not there. And the role of biologic in very early onset IBD, as we mentioned, and more markers we need to see. Just to share with you that what we are doing now here in Sidra with our patients, we have an ongoing study running to delineate the microbiota in those inflammatory bowel disease, and looking at the cytokines as well in those patients. And most importantly, we're doing fancy work on the transcriptomic on those patients. So our patients are running this, and hopefully we'll share these results with you at a sooner stage. Thank you very much.
Thank you, Doctor, for the interesting presentation. And now we're going to proceed with the question and answer session. So let's start here from the audience here in the room. So can you just please.
Assalamu alaikum. Sahar Khurshid from Jeddah. Thank you for all our speakers. My question is to Dr. Azarjan. Sorry. My question for Dr. Azarjan, for the second, I think the third patient you presented. Mazen, did you consider doing colectomy? You hear my question? Or
Can I hear the question again, please?
بتعطيني other mic معلش.
did you consider?
Do you want to use my microphone?
Colectomy.
اوكي. اقفل عندك اياه. يلا تفضلي دكتورة. تفضلي جربي يا اخي. There's a question here regarding one of your patients, the one you presented, his name is Mazen. Did you consider colectomy?
Considered what? Colectomy?
Colectomy before developing all the complications for that patient.
Actually, I don't know whether it will help or not, but again, as I said, I am stuck with this patient. His general condition is not so good, so I don't know if we will tolerating the surgery or not. Again, because we have bad experience with surgery and IBD, I think we need to have a good coverage with biological therapy to have some sort of response or healing after the colectomy. But again, I don't know whether Dr. Mamoun can help in this point, whether bone marrow transplant will help in this patient. We were hoping to have some sort of monogenic or immune deficiency. But again, the genetic study shows nothing.
Thank you, Dr. Mohammed, for your question. I think, as you know, the initial treatment for intractable ulcerative colitis of infancy, which is most likely this patient is one of them, is that used to be a colectomy. But unfortunately, the condition is not only limited to the colon, it's called enterocolitis. So it affects different part of the bowel, and it does affect the small bowel. So by taking the colon out, you're not going to cure the patient. You might reduce the bulk of the inflammation, but you're not going to cure the patients completely. I think the best option for these patients would be obviously the stem cell transplant. If you find a good match donor for the patients, that will be the best option. In the past as well, one of the good things that we tend to try to avoid going on to a lot of immunosuppressive therapy, because those patients, as I mentioned earlier, they have high risk of developing tumor and lymphoproliferative disease without any transplant or anything. So their best option is treatment is getting them to stem cell transplant, even if you can have the experience of getting the genetics markup. But at the moment, as you said clearly, that we are stuck with these patients, and those are the type of patients we go for stem cell transplant, even if we don't have a classical genetic defect, and this will be curative for this child, hopefully.
The thing is that this patient is having FAB positive. You mentioned in your presentation, Dr. Azarjan, that he's positive for both JAK gene Alagille syndrome gene and also for FAP. So he's getting the risk of cancer in the future. So if the patient is still symptomatic and you are treating him with steroids, he's failing to thrive, he's already on immunological agents, and he's FAP positive. I think we should keep colectomy in mind. Thank you.
Okay, thank you. Thank you.
As long as we don't have questions through Zoom, so anyone else in the room, because still we have like 5 minutes remaining before the prayer time. Assalamu alaikum.
My question to Dr. Ayad, do you think the incidence in Saudi Arabia is underestimated a little bit because the biggest cases from the primary care, or do you suggest to have more mass screening? Because in our practice, we have seen new IBD on weekly basis. So what's your advice from your review on epidemiology?
Thank you, Dr. Jesus, for your question. I know we are heading now toward more unmasking more cases and cases. That's why it's better to follow the guideline, instructs the general pediatrician to refer the cases early to the pediatric gastroenterologist. As we unmask the cases, the incidence eventually will rise. And I'm expecting that we will, at some point, we will reach the sterilize and urbanize incident rates. So it's better to early to educate the healthcare worker and unmask the cases, to treat the cases early and unmask it early. But overall, it will rise at the end as we are heading and following and the example of the Western country. I hope I answered your question.
So any question from the audience? Okay, so Dr. Dhafir, we can proceed with the prayer. So we're gonna have the prayer time break, and then we'll come back around 4. Okay, so we'll come back around 4:30. Thank you, guys. Thank you all the speakers for the interesting presentations, and we'll come back soon. Okay, thank you.
Thank you.
Thank you. Thank you. So,
did you get mute?
دكتور اياد لانه بيعرض منها ان شاء الله. خلاص
في ايش؟
لا بنحط في قصدي عشان المشكله
النوتس
اذا حطيت
حقتك؟
في برينترفيو راح يبان هناك. ايوه الله يعين معلش.
ايه عندك انت فلاش ولا ايش؟
احنا لازم ننط كده.
تعالي من هناك احسن، في
من
درج.
جد في درج؟
ايوه.
في عندك ايش؟
فلاش ولا ايش؟
ايوه فلاش.
طيب دقيقة. ما شاء الله مسيطرين حقين تخصصي ها؟ اي واحد.
يا سي دفن اي بي دي.
طيب ديسكتوب عندي تلقاني هنا اي بي دي برزنتيشن.
طيب يعني لما يجي الديسكتوب فين اروح؟ كذا حتكون موجودة.
ايه هذا الديسكتوب.
اوكي
افتحي هنا البي اي بي دي برزنتيشن.
اوكي شور خلاص اخذ اليو اس بي. الله يعطيك العافية يا رب.
خليه بس ريجكت.
شور
خلاص
rejected.
فورس.
يلا اوكي فورس انجكشن. بس خلينا اذا نفتح هذه نتاكد انها موجوده لا يكون ما هي.
هي ايش باوربوينت ولا كينوت؟
باوربوينت. لا باوربوينت simple old باوربوينت.
هذه النوت حقتك بس انه
بس ما في برزنترز فيو صح؟ لانه شوف معلش حط بس
انترو.
هذا اسكيب. اوكي انترو. في البرزنترز فيو عشان اشيك. فيو وفي ما أنا عندي نوتس
اتوقع الشاشة هذه
أيوه.
نفسها تو بي شيرد هنا.
اوكي فخلاص ما في مشكلة.
كذا ولا كذا حيشوفوا.
ايوه اوكي لانه انا حقي اللابتوب احط برزنترز فيو يبان عندي بس اللي في العرض لا ما يبان.
حتى لو سويتي شير؟
حتى لو سويت شير
لا
ماني
شير
متأكدة.
لانه شاشتك نفسها.
ايه
عشان كذا.
ايه صح.
يلا الله يعينك.
يلا ان شاء الله باذن الله.
شكرا. جهزي. الله يعينك.
Hi, this is Jennifer DeBrune here.
Dr. Jennifer, how are you?
Good. How are you?
Fine, alhamdulillah. Thank you so much. We are glad to have you here.
Thank you very much for the invitation.
Thank you so much. So it's break time. We'll start in 2 minutes.
Okay.
Thank you so much.
Should I share my screen for the
Yeah,
slides?
please, yeah, you can share. فلاش فلاش اظنها مع اياد تاكد معلش ايه موجود يقول موجود me no the mic will be yeah because I'm talking to you.
When you play the presentation, close your mic.
Yeah, of course, yes. Yeah, she is ready. Yes. تسمعنا وتكلمنا. خلي بس.
من عندك ولا؟
Yes. وين؟ خلاص. Good morning. هذه تشوف. Dr. Jennifer, good morning.
Good morning. Can you hear me?
Yes, this is Ali Al-Mahedib, who sent you
Hi.
the first email.
Oh, very nice to meet you. Very, very nice to meet you.
Nice to meet you, and we are very honored to have you with us today.
Oh, I'm very glad to be there.
So it's
Are
now
you-
4:30 p.m. in Saudi Arabia. So
Yes. And are you meeting in person or some people are joining online as well?
yeah, just we will start in 1 or 2 minutes.
Okay. Okay. That's wonderful. That's wonderful.
Thank you very much. شباب حتى فين
May I ask, is the question and answer immediately after my presentation?
exactly.
Okay,
Exactly.
sounds good. Very good.
Yeah, it's fine.
How many people are attending?
Attending around 60, and there is 116 live.
Oh, awesome. Very nice.
Thank you. جاهز ريدي يا دكتورة؟ خلاص احنا المفترض نبدا بس الزملاء ما جاوا لسه. تبغى تبدين؟
لا ما يصلح من ذاك.
لا ممكن، لكن الحين نحدد مشبوك الحين يعني بعرض مثل قلت كذا
خلاص بعدين
اللي يريحك
قبل ما يجوا. السلام عليكم. هاي. Hello.
Hi.
Hello, Jen. How are you?
Good. Wonderful to see you.
Yeah, you can see my camera. You can see my face.
Yes,
How are
I can definitely see your face. Very good. How are you doing?
I'm good. How is things? How is Calgary?
Calgary's great. Calgary's
Did you
great.
start having is it start to cool down or still hot?
Starting to cool down, definitely, as you remember.
Okay. I just came from Hamilton.
Oh,
and
yes.
It was really hot, but it's raining. Yeah, there's lots of rain.
So what are you doing in Hamilton? Are one of your kids studying?
No, I am settled. I'm settled in Jeddah.
You're settled.
But I just went for, to visit my son in Hamilton.
Yes, that's what I was going to ask. He is studying in, because you were at the
he's in the second year in university. He's doing well.
Very good. Oh, that must have been nice to send him off.
So welcome. And I was hoping to see you in face, but okay.
Yes.
So I think we should start. Yeah, okay.
ايه ممكن بس افتح الكاميرا. خلاص ابدا يا دكتور.
Welcome to our
turn it on. Go on.
Hello. Yes. Welcome to our second session. Our first speaker, Dr. Jennifer Ducroy from University of Calgary. She's an associate professor in the Department of Pediatric Gastroenterology. Her main research is focusing on inflammatory bowel disease in children with immunization, in addition to the interest in ultrasound diagnosis in patients. It's a very interesting topic. Dr. Jennifer Ducroy is welcome to share it with us today. So welcome, Dr. Ducroy.
Thank you so much. Can you hear me okay?
Yes, everything is fine.
Okay, thank you so much for the opportunity to be here today virtually. And this morning I'm going to, morning here and afternoon for you, I'm going to speak on the role of bowel ultrasound in IBD. And this is a picture of our beautiful Alberta Children's Hospital here in Calgary. Now, I saw a picture of where you are located, and I looked at the beautiful photos of the Red Sea. And this is not what it is like right now in Calgary, but it is not uncommon for us to have a big storm in Calgary in the middle of September. So this was just 2 years ago where we had a 100-centimeter snowstorm, and we nicknamed it Snowtember. And so I was definitely envious of your warm weather right now. These are my disclosures. So over this next 30 minutes, our objectives are to 1, describe the physiology of ultrasound, as well as normal and IBD-related abnormal findings, to understand the role of bedside bowel ultrasound in IBD clinical practice, and lastly, to discuss the steps on how to implement bedside bowel ultrasound into clinical practice. So the history of ultrasound physics dates back as early as 1794, when a physicist first studied echolocation in bats, which is how bats use sound waves in order to determine the location of objects around them. In 1915, a physicist was commissioned to develop the first transducer, and this was inspired by the sinking of the Titanic. He built a device that was able to detect objects underwater by emitting sound waves. In the 1920s, ultrasound was used as a form of physical therapy, for example, in European football players to ease joint pain. And then into the 1940s, ultrasound was first attempted as a diagnostic tool. At that time, it was unsuccessfully looked at to detect brain tumors. So how an ultrasound works is that an electric current is sent through a probe that contains piezoelectric crystals. These crystals oscillate and distribute a sound wave. These sound waves will encounter an object. These sound waves can then be reflected back to the crystal, and which passes through to an electrical current and generates a grayscale. The velocity at which the sound waves return back to the probe and their intensity helps us determine an object's position as well as its brightness, and then that is reflected on the grayscale image. In the human body, we use ultrasound for many different areas of the body. And as we already know, the ultrasound can be useful for looking at soft tissue like the liver, for gallstones, for air, for blood. And amazingly, we can even use it in the bowel. Now, conventionally, ultrasound was not a widely accepted modality of evaluating the bowel wall, but we have now come to appreciate the incredible amount of detail that can be gathered regarding the bowel on ultrasound. Here on the left, I have the layers of the bowel wall that we would see on histology and how this translates into ultrasound. When we look, we see the muscularis propria, which is visualized as a black layer, the submucosa, which is white, and then the mucosa, which is black again. And this composes the anterior wall of the bowel that we see on ultrasound. We then can see the lumen, and then on the posterior surface, we see the posterior bowel wall. These examples of images are taken from the International Bowel Ultrasound Group. On the left is the photo from the ultrasound, and on the right is a pictorial depiction of it that just allows for more clarity. So what we see here is a bowel, a loop of bowel. And here we see the black, white, and black layers of the bowel wall, which symbolize the muscularis propria, the submucosa, and the mucosa. In the center, we see the lumen, which is filled with stool and air. That's what these little bright white spots are. And then we can see the posterior wall of the bowel there. This is an example of an image of the colon. And as we all know from scoping the colon, is that we can see these beautiful haustra. And in ultrasound, we also see these. And we can see again this black, white, black stratification of the bowel wall. And then this white part in here is the air and fluid filled colon. This is an example of the small intestine. And so in the small intestine, we also can see Kirkland folds, which are shown here. We can see the black, white, and black pattern, which is here. And then if we were to look at this in real time, we would see active peristalsis of the small bowel. Now, as I had mentioned earlier, ultrasound had not conventionally been used for evaluating the bowel. However, there are many advantages of ultrasound that make it an excellent modality for us as gastroenterologists to adopt. It is non-invasive. It does not require IV or oral contrast, sedation or general anesthesia, or ionizing radiation. It is well tolerated, and in our children in the clinic, I can scan children as young as 2. Thankfully, with an iPad or other device, they are appropriately distracted. It has a relatively short exam time, especially when you compare it to a full MRE. Its lower infrastructure and per exam costs are also an advantage, again, when you compare it to other modalities like CT or MRE. It is readily available, it is accurate and reproducible. And perhaps one of the greatest advantage of it is that it can be done right at the bedside with a parent and guardian present. We can communicate and demonstrate immediate results. And this allows us for real-time exam and real-time clinical decision-making. And so we can engage the child and parent and say that, you know, we are on the right course and we continue with our treatment course. Or if we see changes that require optimization or treatment modification, then we can modify the course as well. So when we scan the abdomen, we typically use two types of probes. One is a convex probe, which is a low frequency probe. And this allows a deeper view into the abdominal cavity, and it allows a more panoramic view. When we want to gain more detailed bowel visualization, we use a linear probe, which has a higher frequency and a higher resolution image. There are numerous intestinal ultrasound parameters that reflect inflammation. And here I'll show you the list, but we will also go through some of them in more detail. First off is bowel wall thickness. This is emerging as the most important parameter for assessing inflammation, as well as assessing response to treatment. Wall stratification, which is the layers of the bowel wall, echogenicity, so how bright the bowel appears, its blood flow, ulcers, which are depressions in the bowel wall, mesenteric fat, so this is the fat that is surrounding the bowel in the mesentery, lymph nodes, and then in ulcerative colitis, we can often see loss of colonic haustration, and then also loss of intestinal motility. The ultrasound is also excellent for evaluating complications such as stenosis, abscess, and fistula. So bowel wall thickness is performed by measuring those three layers of the bowel wall that I spoke about. On this image on the right, again, this is the black portion, which is the muscularis propria, the submucosa, and then the mucosa. And when we measure a bowel wall thickness, we measure from the outer surface of the muscularis propria, where it interfaces with the serosa, and then we measure until the inner surface of the mucosa, where it interfaces with the lumen. It is a relatively easy measurement to make. It's accurate, reliable, and reproducible. And we have some standards of normative values and severity. So normal would be less than 3 millimeters. And this always strikes me because when I think of the size of the biopsies that we take on our endoscopy, this is not going to be that far from a millimeter or two. Then we can have mild, which is 3 to 6 millimeters, moderate, which is 6 to 8 millimeters, and then severe, which is greater than 8 millimeters. Mural stratification or bowel wall stratification is also an important parameter of inflammation. And here on the left, we can see that nice black, white, black pattern of the bowel wall. This white here is the lumen. And then on the right, we see an area where the bowel wall looks thick compared to the other side. And we see that we've lost the bowel wall stratification pattern. This is an example of echogenicity. So here is a transverse loop of a bowel. So again, this is the anterior wall, this is the posterior wall, and we're looking at that black, white, black pattern, and this thin strip in the center is the lumen. And here we see that the submucosa here appears more bright. And so in inflammation, we can see a hyperechoic bowel wall. We can also see a hypoechoic or more dark bowel wall. And so this is an example of an area of an anterior bowel wall, which appears thick. We've lost the stratification pattern and it is darker than we would expect. Vascularity reflects the blood flow of the bowel wall. And there is a scoring system called the Limburg system that we can use. And how we measure vascularity is that we apply the Doppler and we can basically see specks of blue and red. So Limburg 1 is a thickened bowel wall, and we do not see any increased vascularity. In Limburg 2, here is the bowel wall here. Not only is it thickened, but we are now seeing short blood vessels inside the bowel wall. In Limburg 3, the blood vessels are now longer and they are still contained within the bowel wall. And then in Limburg 4, we begin to see blood vessels that are not only in the bowel wall, but also extend into the mesentery. Next is a mesenteric adipose tissue reaction, or this is the fat that is surrounding the bowel. And we often see this, especially in Crohn's disease. So this is an example of a bowel loop here. Again, to orient you, we have the black, white, and black pattern. This is the anterior bowel wall, and this is the lumen here, and this is the posterior bowel wall. What we see surrounding here is a brightness. And so this is the fat that is surrounding. And so it is a signal of inflammation when we see the echogenic or increased echogenic material around the bowel. This is an example of a mesenteric lymph node shown here. These are round-like structures. They are hypoechoic. And how we know that it is not a blood vessel is that when we apply the Doppler to it, it does not light up. And in IBD, we can see increased mesenteric lymph nodes. As I mentioned before, ultrasound can be useful for evaluating for complications of Crohn's disease. And so this is an example of stenosis. So in this segment of the bowel, this is a longitudinal segment. This is the anterior bowel wall. This is the posterior bowel wall. And this thin white line in the middle is the lumen. We see that this area looks thickened. It's hypoechoic. And if we were to evaluate it in real time, we would see an absence of peristalsis in this segment of bowel. What we see before it is that the pre-stenotic segment looks dilated. And in real time, it would show to and fro peristalsis where the bowel is trying unsuccessfully to propel the contents through this narrowed space. This is another example of a stenotic segment. And here we see the pre-stenotic dilation. We see that the lumen is narrowing. We see that these areas of bowel wall are thickened, and we are not able to appreciate much of a lumen in this area of the bowel wall where it is stenosed. So the last example I have for you is fistula with abscess. So to orient us, we have, I'm going to use this time the pictorial representation. So we have two bowel loops here, one on the right and one on the left here. On the one on the right, we can appreciate that there's these layers of the bowel wall, the muscularis propria, the submucosa, and then the thin black is the mucosa. And then in the center, the white is the intestinal lumen. We see immediately adjacent to it are these areas of hypoechoic regions projecting from it. And this is in fact an interenteric fistula that is eventually going to connect with this second loop of bowel here on the left, as well as this area here. In the center, we also see a irregularly defined hypoechoic region, which is the abscess. So as you can see, ultrasound can be useful for not only assessing inflammation, but also looking at some of our complications in Crohn's disease. So what exactly is the role of intestinal ultrasound in IBD? It can be used as part of our primary diagnosis when we suspect IBD. And there was a meta-analysis that showed that ultrasound can be useful for not only assessing disease activity and location. Among 5 trials, ultrasound had a pooled sensitivity of 85% and a pooled specificity of 98% for identifying inflammation. Among 8 trials, it showed a pooled sensitivity of 86% and a pooled specificity of 94% for specifying the location of this inflammation. And there were no significant differences between CT, MRE, and ultrasound. Now, there are some important limitations to recognize. The ultrasound can be challenging to evaluate the rectum. The rectum lies deep in the pelvis and can be challenging to visualize. In addition, it can be difficult to differentiate between jejunum and ileum, as the small bowel typically looks the same, is challenging to follow in continuity. And so it more often we're just localizing to which quadrant of small bowel we are evaluating. Lastly, mild disease can be difficult to identify. For example, in Mayo 1 ulcerative colitis, we may only see subtle changes. In Crohn's disease, where there can be scattered abscess ulcers with intervening normal mucosa, this can pose a challenge when we are attempting to identify disease on ultrasound. As I've shown, complications can be assessed using ultrasound, including stenosis, fistula, and abscess. Ultrasound can also be helpful for monitoring response to therapy. And this is the TRUST-CD trial, which was performed in Germany. It was a prospective multi-center trial in 47 IBD centers of 234 patients with active CD. They were evaluated with an ultrasound every 3 months for 1 year. And this was an observational study, so patients could be on anti-TNFs, corticosteroids, and or immunomodulators. The figure on this left shows the proportion of patients that had increased bowel wall thickness at various time points: baseline, 3 months, 6 months, and 12 months, and then in differing segments of the bowel: the terminal ileum, ascending colon, transverse colon, descending colon, and sigmoid colon. And what we can see is at baseline, over 70% of patients had increased bowel wall thickness in the terminal ileum. We see a lower proportion among other areas of the colon, ranging from 40 to 50%. What we also see is that at 3 months, there was already a substantial improvement in the proportion of patients who continue to have bowel wall thickening. And we see that these improvements continued on till 12 months. And when we compare 12 months to baseline, there was a statistically significant difference in all areas of the bowel for bowel wall thickness compared to baseline. So we know that ultrasound can be useful, especially for the terminal ileum, for assessing bowel wall thickness and responding to therapy. On the figure on the right, we have different types of parameters. We have loss of bowel wall stratification, Doppler signal, mesenteric proliferation, mesenteric lymph nodes, and strictures. And here we see that probably the 3 more useful features are loss of bowel wall stratification, Doppler signal, and the mesenteric fat proliferation. They are not as common as bowel wall thickness at the beginning, but they are still present in about 40 to 50%. And we again see these improvements at 3 months and ongoing improvements out to 12 years, or 12 months, sorry. Now, this was the TRUST and UC trial, and this was done again in Germany. And instead of looking at CD patients, it looked at UC patients. It was a prospective multi-center trial in 42 centers of 224 patients with active UC. And here, the parameters and the date and the time window are different. So they looked at baseline, 2 weeks, 6 weeks, and 12 weeks. And on this figure on the left, we see the proportion of patients who had increased bowel wall thickness in the sigmoid colon and in the descending colon. And here we can see that at baseline, almost 90% had increased bowel wall thickness at baseline. And so, in fact, bowel wall thickness is even better for use in ulcerative colitis patients. And here we see a improvement that occurs as early as 2 weeks and continues out to 12 weeks. When we look at those other parameters, the ones that emerge to be most useful are loss of haustration, as well as an amplified color Doppler signal, which were present at baseline in almost 60% of the patients, and again showed early improvements as early as 2 weeks and ongoing out to 12 weeks. And so it emerges that bowel wall thickness may be an excellent parameter for monitoring therapeutic response. The TRUST UC trial also showed that bowel wall thickness could in fact correlate with fecal calprotectin as well. So we have seen that ultrasound can be used to monitor disease activity in response to therapy. There are numerous ultrasound-based disease activity scoring systems which are being developed. Most of them are retrospective, but are undergoing prospective validation. We also have data that supports that ultrasound can be used to predict outcomes. And this includes mucosal healing, where ultrasound had an AUROC of 0.87 for identifying mucosal healing. And in fact, bowel wall thickness less than 3 millimeters emerged as a best predictor with 97% accuracy. Intestinal ultrasound can also be used to predict poor outcomes like surgery, hospitalization, and need for steroids. In a study among patients with Crohn's disease who were treated with anti-TNF, those who had an ultrasound response had a lower risk of poor outcomes. And lastly, ultrasound can be useful in identifying post-operative recurrence in Crohn's disease. In a meta-analysis, it showed a pooled sensitivity of 94% and specificity of 84%. And again, bowel wall thickness emerged as a very useful parameter, where a bowel wall thickness greater than 5.5 millimeters correlated with a Rutgers score greater or equal to 3, with a sensitivity of 84% and a specificity of 98%. So this challenges us that maybe a normal bowel wall thickness should be incorporated into our treat to target strategy. And in fact, the most recent version of STRIDE 2.0 discusses the adoption of ultrasound into our targets. Now, this algorithm is taken from a review article that was published in 2020 by Aloka et al., and it guides us on how we can use ultrasound as part of our clinical practice. So on the left, if we were to have asymptomatic IBD patients who were in a biomarker remission, we may use the ultrasound scheduled every 6 to 12 months to confirm that indeed the bowel looks well, and we can continue with follow-up. However, if we identify any pathology, we may reconsider what we need to do with our strategy. In the center, we have symptomatic IBD patients where we can use a point of care bowel ultrasound in order to determine if there is inflammation or not and help us guide our treatment strategy. And on the right, if we have patients who are starting treatment, we can use regular bowel ultrasounds in order to assess response to therapy and decide if we continue our current course or need to optimize or change our treatment strategy. So this table is also taken from that same article. And I'd just like to point out that it highlights how ultrasound can be used to help narrow our differential diagnosis, speed up our diagnosis, to improve allocation of resources, to allow us to begin early treatment, and to drive real-time clinical decision-making and early optimization of changing therapy. So perhaps point-of-care ultrasound is going to be like the stethoscope of the future. So these images are taken from an 11-year-old boy with ileal Crohn's disease. And here we can see that he had increased bowel wall thickness. The anterior wall is measuring 3.5 millimeters. This Doppler has many red and blue speckles, and it shows that the bowel wall was hyperemic. In this area, we can also see that there was mesenteric fat, and then there is also some loss of stratification. He underwent treatment with exclusive enteral nutrition for 6 weeks with Modulin, and already we can see improvement. Now his bowel wall thickness is normal. It's 1.68 millimeters. That mesenteric fat has resolved. I don't have a Doppler image here, but we also can see that now we can appreciate the bowel wall stratification pattern. So we are very fortunate that there is an international bowel ultrasound group, and this is its website. And IBIS is a group of international experts in bowel ultrasound, or IBD, who made it their objective to establish a continuing education program for interested gastroenterologists caring for IBD patients. And this is what I participated in order to gain the experience. And their training curriculum is composed of 3 modules. The first module is a 3-day workshop, and this is held at various places around the world several times per year. And it is an opportunity to learn the basics of ultrasound as well as get some preliminary hands-on experience. Module 2 is composed of going to one of their training centers and undergoing 4 weeks of hands-on training. And finally, module 3 is a half-day workshop that is usually done in time with the ECHO conference. So there remains to be challenges to uptake of bowel ultrasound by gastroenterologists. In North America, ultrasound is still primarily in the domain of radiologist expertise, but now numerous other specialists are gaining experience and expertise in it. There is the perception that ultrasound is operator dependent, and this continues to need to be overcome. And lastly, we also continue to require ongoing advocacy work in order to develop appropriate healthcare reimbursement for gastroenterologists when they are doing a bedside ultrasound as part of their clinic consultation. So we are perhaps now in the future. It wasn't that long ago. It was in the 1960s when the Star Trek show, I'm not sure how many of you have seen it, but they had this, it's a futuristic sci-fi show, and they had this small handheld device that was called a medical tricorder, where you could scan somebody and you could detect their vital organ functions. You could also detect their basic physiology and pathology. And perhaps now we are in this at this stage in time where we can have ultrasound as part of our armamentarium of tools. And here's an image of a probe that is hooked up to somebody's cellular phone, and it can be done perhaps even in more convenience. And so I hope that you have come to appreciate that the ultrasound is a safe and accurate tool, and that there are many applications for it in pediatric IBD. So I'd like to thank you again for the opportunity to present to you today. And I'm certainly passionate about bowel ultrasound and believe that it is a very important tool for us as gastroenterologists. This is my email address if you would like to contact me. And this is an image of what our Calgary looks like in September right now. So thank you very much.
Thank you, Dr. Duprin. Dr. Duprin is busy in her daily work, so we would appreciate if you have any questions. We are going to present it to her. Yes, Dr. Hassousa.
My question is, what's the explanation in Doppler or ultrasound in anorectal diseases, sigmoid, Crohn's will be difficult, not like in chronic? So what's the explanation? So is it any further studies to have struggles to identify the ultrasound finding a rectal Crohn's or sigmoid Crohn's?
Did you get the question, Dr. Duprin?
Can you repeat that?
Okay, so the role of ultrasound in rectal IBD and sigmoid diseases.
Okay, so the ultrasound is in fact good at evaluating the sigmoid. Like we can usually see the curve of the sigmoid decently well. So around where it is passing the iliac vessel. So in fact, we use the iliac vessels and the psoas muscle to help us localize that we are evaluating its sigmoid. So it is very good for there, but it is because when we use a probe that goes deeper, it does not have as good a resolution. So basically all those images that I showed you were done using a higher frequency probe, and a higher frequency probe measures more superficially, but allows very nice bowel wall detail. So that's why you can see those beautiful layers of the bowel wall. When we go, we have to make a trade-off. And so when you're going deeper into the rectum, you lose that degree of detail and things do appear a bit more blurry. So it's more difficult to see the very fine layers of that black-white pattern. You might be able to you can use the Doppler and you can see things that are lighting up, but you lose detail when you're trying to go into deeper into the rectum. And so, for example, in a young child, my probe depth is only at 3 centimeters when I use the linear probe. And at 3 centimeters, even sometimes less than that, I can see beautiful detailed images. My probe depth for when I have to go into the rectum is somewhere between 7 to 11 centimeters. So that's why. Now, I am not doing it, and I don't know of any pediatric gastroenterologists who are doing it, but in the adults, they do transrectal probes and transvaginal probes in order to be in much closer proximity to the rectum and to appreciate that. And obviously for multiple reasons, we don't do that in children. And then they will also do on the surface of the skin, trying to look, but you can't really see the rectum as well. That's more for looking for fistulas and abscesses in the perineal region. So perhaps when technology, it may be that we still are requiring ongoing advances in technology to help us gain that appreciation.
Yes, Dr. Shawush.
Our surgeon, they use the ultrasound scan for diagnosis of appendicitis. And most of the time, when people are technique, they technology that is most likely IBD. So do we think in the future the ultrasound and it will be an alternative for invasive procedure for doing endoscopy or evaluation?
The question is whether in the future the ultrasound and the fecal calprotectin is going to be a replacement for endoscopies for diagnosing of IBD.
Yeah, that's a very good question. I don't think that we are certainly not there at this stage, and I'm not sure if we will be either. I think that as I mentioned, there are some limitations, for example, to evaluating the rectal area, to localizing which area of the small bowel you may be in, as well as detection of mild disease. So I think that it is still going to remain to be a complement of tools that we will use, like how we use our fecal calprotectin, CRP, endoscopy, and then imaging. I think that one of the main challenges is that mild disease can be difficult to detect on ultrasound and can be missed. So that's why we still do require a thorough assessment of the bowel. Sometimes I will see something very subtle and I'll think, okay, this bowel wall is just very slightly thickened and it looks a bit more prominent. I'm not sure. And so they're not hard signs. But, even when I have a bowel wall thickness that seems to be within normal, but I've seen the rest of the bowel is much thinner, those things might emerge to be clues, but at this point in time, we still need endoscopy, and I anticipate that we still will.
Any more questions? Yes.
So you mentioned that you mentioned 5 and 8 trials. What do you mean by 5 and 8 trials? And as you know, and maybe it's operator dependent, and you know, if IBD worsening, it will make the patient worse. So should we only depend on the ultrasound? And if there is any data or any studies comparing this mild diseases with ultrasound, and could it be picked up by an expert like you? Thank you.
So if there are, you mentioned 5 or 8 trials. So you think whether they're
What you mean? What you mean by?
What do you mean by, you said 5 or 8 trials during your presentation. So what does it mean? And the other question is?
The other question is the expert like Dr. Jennifer with mild disease. Did she detect mild diseases detected by either scope or whatever?
And as you become more expertise in using ultrasound, do you think the chances of detecting the disease is going to be much more with milder early disease?
Certainly. So those 5 and 8 trials, so those were a meta-analysis of, one was 5 studies that looked at how ultrasound could detect inflammation compared to endoscopy. And then the 8 trials were all trials that were looking at ultrasound compared to endoscopy for identifying the location of the disease. So if you recall, when I gave you the numbers, the specificity for those, for both of those, in both detection of inflammation and its localization, was higher than sensitivity. So I think that this reflects that mild nature that we were talking about, and that your ultrasound is going to be able to pretty well detect moderate and severe disease. Like if you see it on ultrasound, you're going to see something on the endoscopy. But if you don't see anything on ultrasound, if you may still miss something on endoscopy. And so that's where I think that ultrasound is a part of our tools. So if our ultrasound was, if we were still having an elevated fecal calprotectin and other things as part of our diagnostic workup, then we would say, okay, you know what, we are still going to pursue with the endoscopy. Now, I do agree that as I've gained experience with it in time, I do see some more. I find that, as I've shown you, bowel wall thickness tends to be a very useful parameter. And in areas where it still is not very high, like it may be under 3, and it may be just at 2, so for example, at 2.5 millimeters, but I've imaged everywhere else in this child's colon, and it is, under 1.5 millimeters, the rest of the area, and I'm in the sigmoid, and it's just very subtle, like 2.5 millimeters, then those have become clues for me. So it's primarily in where I see bowel wall thickness that is higher than what I'm seeing in other areas in the child. That's the main clue. Sometimes, those other features like mesenteric fat and bowel wall like mesenteric fat, you need a bit more inflammation for that to be present. And then again, like bowel wall stratification, echogenicity, and Doppler, again, the bowel wall needs to be a little bit thick in order to appreciate these. So it is with bowel wall thickness where I can sometimes surmise that maybe I'm encountering mild disease.
Okay. Question from Dr. Mahedib: how frequent you will do ultrasound for your patients?
So I am evaluating them when they are starting treatment. I've been doing them as part of a study. So I will evaluate them at a 4 to 6 week mark after I start a new treatment, and then at 3 months to 6 month mark, and then at a year. But I think that the protocol, the algorithm that I showed you, that it talked about doing after a new treatment every 3 months, and then in follow-up every 6 to 12 months. I tend to do it earlier because, as we've seen in the data that I show you, even in ulcerative colitis, we can see improvements as early as 2 weeks. And then in Crohn's disease, I see changes as early as 4 weeks. So I try to do an early ultrasound to help affirm that I'm seeing improvement. And then thereafter, every 3 months or so, if they are on, recent new treatment, and then if they are stable and they're doing very well and have been doing so, then it may be every 6 to 12 months.
Yes, the question from Dr. Hiba.
Thank you, Dr. Jennifer, for your presentation. Last question about the contrast-enhanced ultrasound. Is it more specific than the routine ultrasound in detection of the complication?
Did you get the question?
The first part about contrast enhanced.
It's the role of contrast-enhanced ultrasound.
Contrast-enhanced ultrasound.
Yeah, more specific than ultrasound in detecting the complication in IBD patients, particularly in Crohn's disease.
The contrast-enhanced ultrasound, is it more specific than the just regular ultrasound in detecting disease and complications, severity and complication?
Yes, so that's an excellent question. So contrast enhanced ultrasound, we do not do it here routinely because the agent is not licensed in Canada for children, but we have an adult radiologist in our neighboring site who will do it, but then she carries the contrast and such. It is a bit more time intensive because we need to establish an IV and then inject the contrast and then have it timed so that it's in its appropriate perfusion phase. That being said, it is useful for looking at strictures and trying to gain some appreciation of the degree of fibrosis versus inflammation. I know, like, that's always our big question, is how much more do we push with treatment versus needing to resect it? So that the contrast enhanced ultrasound can be useful for the differentiation of inflammatory versus fibrotic strictures. That being said, there's often an overlap. So we will more so use it as a tool that if someone is having a stricture and I'm embarking on anti-inflammatory treatment and it's not improving, then I may use it, refer my patient to her to do it to determine how much further I should escalate or optimize therapy, or is it now time for surgery?
Thank you, Dr. Jennifer. Thank you for this nice talk. And Dr. Ala Bukhari will present our next speaker. Thank you.
Okay. Assalamu alaikum. Now we will start our second lecture in this session. It will be presented by Dr. Abdulaziz bin Aqil. Dr. Abdulaziz is a pediatric GI fellow in his second year fellowship program at King Faisal Specialist Hospital, Riyadh, and he will talk about the role of fecal calprotectin in IBD patient. تفضل دكتور.
Assalamu alaikum, everybody. My name is Abdulaziz bin Aqil, and I'll be presenting today a small talk about the role of fecal calprotectin in inflammatory bowel disease patients. So I will start my talk with three small mini cases that will raise some questions regarding the use of fecal calprotectin. And hopefully by the end of the presentation, we can answer all of these questions comfortably. So my first case, you're receiving a call from a concerned mother about her 7-month-old child. About a recent lab that was done at the private hospital. The lab showed a fecal calprotectin level of 153 microgram per gram. You know this family by following the other child who is suffering from inflammatory bowel disease, and currently he's in remission. And now she's asking you if her other child is having inflammatory bowel disease based on this result. So from this case, can we say that this patient is highly suspicious of inflammatory bowel disease? The second case is about an 8-year-old that was referred to your clinic with a high also fecal calprotectin, which was done and found out to be 101 microgram per gram. She is known to have juvenile idiopathic arthritis, and she was started recently on naproxen 5 milligram per kilogram 2 times a day. Otherwise, this child is doing excellent. She is thriving well, no abdominal pain, and no diarrhea, and have normal albumin level. What about this patient now? This patient is highly suspicious to have inflammatory bowel disease. The third case is about a 4-year-old child whose father is calling you as he was admitted at the local hospital as a case of acute gastroenteritis. He is, for some reason, the fecal calprotectin was sent at the local hospital, and he was found to have 187 microgram per gram. Now, this is another child with elevated fecal calprotectin, and are we suspecting or highly suspecting inflammatory bowel disease? And am I going to invest my resources in investigating these patients to rule out inflammatory bowel disease? So to answer these questions, I will start in the beginning to talk about fecal calprotectin. What can it help me with? How can it be so sometimes deceiving to some physicians? And how can it help me with, in diagnosing and following up inflammatory bowel disease patients? So first of all, fecal or calprotectin is a 36 kilodalton calcium and zinc binding heterocomplex protein. And what do I mean by heterocomplex protein? Is simply that protein made by multiple polypeptides, like two or more polypeptides. In the case of fecal calprotectin, it's made from 2 heavy chains and 1 light chain of proteins or polypeptides belonging to the S100 family, namely the S108 and S109. And these proteins actually work as a structural proteins to a lot of cells. And one of the most important cells in this case is neutrophils and monocytes. And these cells are found in tissues, and that is abundant with inflammatory cells. We can find them throughout all of our gastrointestinal tract. And what do they do? That during homeostasis, we can easily see, as the figure in the upper right, neutrophils can normally circulate through our gastrointestinal tract. And that's why we can find some fecal calprotectin even in normal, healthy people. However, during an inflammation, what happens is these cells migrate and become numerous in number at the site of inflammation. And when the inflammation is becoming more active, they release the fecal calprotectin. It will be attached to the stool, and because the fecal calprotectin is resistant to enzymatic degradation, it will be preserved in the stool to be a useful marker when we are testing these patients. And that's what makes calprotectin is a really useful test in assessing intestinal inflammation. So how do we measure fecal calprotectin? To answer this question, usually what we do is actually we tell the family we need a stool sample, and that's it. But a lot of families have questions that many of us can face in their clinical duties in everyday life. So how much stool should I provide? When should I give it to the lab? Can I wait for 1 or 2 days to deliver it to the lab? So actually, to answer this question, fecal calprotectin currently can be performed in 50 to 100 milligram samples of stool. And this was not the case when fecal calprotectin was early described back in late 1980s. And also in the beginning of testing of fecal calprotectin, there was a thought that it was that it should be taken and done as an early morning sample, as it will be most accurate at that time. However, as we became more familiar with the test and more statistical studies were done, it was found that it's statistically indifferent regarding the timing of collection of stool and the inflammatory component of fecal calprotectin concentration. However, what can affect my results is the stool consistency, as we found that more watery or more liquidy stool samples actually can artificially elevate my fecal calprotectin concentration. And this is especially true in evaluating smaller children who are still in diapers, because as we know that smaller children who are in diapers, usually some urine gets mixed with the stool, and this makes it more liquidy, and by this artificially elevating my calprotectin level. Answering the question of for how long can I keep the sample? Initially, it was thought that it can be stay at 3 to 7 days at room temperature. However, as we starting to know more of the test, we found out that after 24 to 48 hours, the fecal calprotectin concentration start to decrease in room air or in room temperature. And what's recommended now, if we are going to keep the sample for more than 48 hours, it should be stored in a fridge at the degree of 4 degrees Celsius, or for longer term duration, it should be kept frozen at minus 20 degrees Celsius. How do we measure it? When it was first described in late 1980s and early 1990s, what was done that we needed, like as I mentioned before, a bigger stool sample. So what we used to do is we will take a stool sample, mix it in a tube with a dissolving solution, and we take this homogenate liquid and assess the fecal protein concentration through ELISA, which is the enzymatic linked immunosorbent assay. So we'll try to detect some fecal calprotectin based on that level. And that's why you see a different unit in the measuring of fecal calprotectin in earlier papers that describe the test. It was reported the normal as 2 milligram per liter, and the positive test was 10 milligram per liter in adults. However, as we are technologically improving our ELISA and technology techniques in assessing these proteins, newer solutions that are used now with better dissociative solutions, we need now less stool, and we are describing the level in microgram per gram. And most of the newer paper and most of our centers are reporting the result as microgram per gram unit. And the new limit described for normal cutoff in adult is 50 microgram per gram. Now, after knowing that, what else can manipulate my fecal calprotectin result? Several factors, actually. Age and gender can affect calprotectin. Especially age is really important because our population is really different from adult in that perspective. Medication and even quality of life. So I'll start attacking these points one by one. So the effect of age and gender, because as I mentioned, our population is quite different from adult. We started to ask ourselves a question: can I use the normal healthy cutoff of an adult to assess a fecal calprotectin concentration in pediatric? And that's why multiple studies were done, and what was found is actually interesting. This meta-analysis is showing us multiple studies comparing normal or trying to assess a normal healthy fecal calprotectin cutoff in healthy children. I want to concentrate in this study, which studied around 288 subjects from the age of 1 month until the age of 1 year. And their results were really interesting. As you can see, the normal or the median fecal calprotectin level was around 375 microgram per gram. And this is markedly and significantly elevated in compared to our counterparts in the adults. And another thing that I want you to focus in this slide is, as you can see, as the child started growing in age through his first birthday, the fecal calprotectin will start to go gradually, but still it's way above, or actually double or maybe triple the cutoff of an healthy adult. The other interesting study in this meta-analysis is actually the biggest or the largest study was done by Davidson and Locke. They studied around 8,500 subjects, and what they found that after the third or fourth birthday, the results of fecal calprotectin normal cutoff started to approach an adult level. So what can we get from this graph is actually that fecal calprotectin values or concentration in pediatrics are normally higher than in adults. And fecal calprotectin, even gestational age, can also affect the fecal calprotectin. This was not mentioned in the table, but what they found is that really young children and extreme preterm children have lower fecal calprotectin level in comparison to late preterm and normal or full-term children up to 1 year of age. And because these children, as we mentioned, they have higher fecal calprotectin. And as the child reaches his fourth birthday, the cutoff of an adult 50 microgram per gram is becoming really close to those children. Although some papers still saying that some of children above 4 years of age, still they are having a higher fecal calprotectin concentration and compared to the adults. What other factors can affect the fecal calprotectin result is actually medications. And these are medications that we are using frequently in our practice. One of the most important medications is non-steroidal anti-inflammatory medications. And as I saw, or as I described in one of the scenarios, as the child who came with naproxen, they found there is a study that was done in 2017 in juvenile idiopathic arthritis patients or rheumatological patients. They found higher fecal calprotectin levels in these patients, and it was theorized that actually what's happening here is related to drug-related enteropathy at different sites of the GI tract. Another medication that we use quite commonly in our practice is proton pump inhibitors. And this is a study is actually done in UK in 2007, and it was done on adults. They found that patients who are in proton pump inhibitors, they are normally having higher fecal calprotectin level. There is no mechanism that was suggested in this study. However, what's interesting that upon discontinuation of these medications, the patient's calprotectin level dropped back to the normal cutoff for an healthy adult. Another study is assessing lifestyle, and this is also a study from the adults. And I actually like to look at the literature in adults because it will help me in two things. Number one, it will tell me about a subgroup of my population, which are adolescents. And in some areas in the world, adolescents are taken care by an adult physicians. And it will tell me like the future outcomes of my patients and how other areas in the world are treating these patients. What they found in an adult study or meta-analysis that that lifestyle of an adult actually affect the fecal calprotectin level in terms of BMI, fiber intake, and sedentary lifestyle. In general, a healthy adult is having a lower fecal calprotectin level in comparison to a less healthy adult in all of these criteria. So after discussing this, the big old question, and I think up until now, we answered all of the three questions or the three mini scenarios. Is it always IBD? And clearly the answer is no. Maybe it's gastroenteritis, exactly. Well, the first case was gastroenteritis. The second case is the medication. The first case is simply the young. But what can cause higher fecal calprotectin level, all of this were found to be associated with an elevation of fecal calprotectin. Any inflammatory condition, including inflammatory bowel disease, can cause a raise in fecal calprotectin. Other inflammatory conditions such as celiac disease is causing an elevation in inflammatory bowel disease. Infectious disease, such as infectious diarrhea, simply can cause an elevation fecal calprotectin. Neoplastic and iatrogenic medications and even young age all can cause inflammatory increase in fecal calprotectin. Okay, if it's not if calprotectin is really a vague marker, how can it help me in inflammatory bowel disease? And this is the title of this talk. So fecal calprotectin as a screening tool. Let's look at it as a screening tool for inflammatory bowel disease. Now, in the upper right image, you can see a meta-analysis comparing fecal calprotectin with other inflammatory markers, which are assessed in blood samples. And what they found out that fecal calprotectin levels is far more superior in when it comes to sensitivity and specificity than any other blood inflammatory marker to look for inflammatory bowel disease. But the other question now, what is the cutoff in pediatric patients that can tell me this is actually inflammatory bowel disease or a simple infection or a medication-related elevation? A thorough meta-analysis was done and found out that the optimal cutoff that will make me more suspicious in inflammatory bowel disease specifically is around 212 microgram per gram, with the sensitivity of 90% and specificity of 87%. There are another meta-analysis discussing a cutoff of 100. However, that's true, it may increase my sensitivity, but it will drop my specificity because children, again, they normally have higher fecal calprotectin. And until now, there is no data that give me an assessed cutoff for IBD in different age groups, especially below 4 years of age. And this is the challenging part. Maybe in the future, we have like a chart with a cutoff for each age group, and we can plot our result in this chart, giving us a higher result. What about disease location? Can fecal calprotectin help me in determining the disease location by depending on the level itself? Unfortunately, that's not true. There is no level will tell you if this is Crohn's disease or if this is colitis. And this was shown in 2 big studies. One of them was done by the Porto group, Porto IBD group as a part of ESPGHAN, and one done in Japan, Osaka. What they found is that the median calprotectin level did not differ between children with small bowel disease only and those who have colonic involvement. All of them during activity showed a similar increment in fecal calprotectin. And what they found is actually confirming what we discussed earlier, that calprotectin is much more superior than CRP and ESR when it comes to sensitivity and specificity. The Osaka study confirmed these findings. The increment in fecal calprotectin did not, they were very similar in the increment and did not show a difference between a colonic involvement and isolated small intestine involvement in case of inflammatory bowel disease or Crohn's disease. And even in disease severity, the elevation in both patients with Crohn's and celiac disease, it was really similar. in patients who are having mild disease endoscopically and histologically, and who are having moderate to and severe diseases. So just to summarize, I showed a lot of figures, and sometimes we get lost between these figures. As a screening tool, fecal calprotectin is far more superior than blood inflammatory markers. However, it has its own limitation. It cannot differentiate between IBD and non-IBD causes of inflammation in pediatric. It cannot differentiate from UC and Crohn's disease, and it will not differentiate from mild, moderate, and severe diseases in pediatrics. This is regarding it as a screening tool. Okay, I saw the patient, I suspected IBD, I scoped him, we diagnosed him his IBD, and we started management. After management, what's going to happen to the fecal calprotectin, and how does it respond to management? Actually, it responds quite well. With infliximab, patients who started on biologics, such as infliximab, as was seen in this study that was done in Finland 2011, it showed that fecal calprotectin dropped to its normal level within 2 weeks of starting of biologics. And when it's compared to the exclusive enteral nutrition, it dropped as well, but not after 2 weeks, and even not after 4 weeks. It took the enteral nutrition 6 to 8 weeks to show some improvement in regard to the fecal calprotectin level. So this can actually tell me, this reminded me about even the talk with Dr. De Bruyne just a second, regarding assessing the healing process with ultrasound. Fecal calprotectin also can give me an idea in this matter, and with a similar period, a range period, 2 weeks period. And does a specific drop tell me at what healing level are we going on now? So this is a multi-center study in 2018 assessing 151 child. And what was done in this study, that all patients underwent MRE and complete ileocolonoscopic evaluation, and fecal calprotectin levels and blood C-reactive protein were measured. They wanted to assess at what level represented mucosal healing, transmural healing, and deep healing. They define mucosal healing as a simple endoscopic severity index of Crohn's disease score below 3. Transmural was assessed through MRE, visual analog score of below 20 millimeter, and deep healing, a combination of both of these two definitions. And what they found out that after initiating treatment, if the level drop reached around 550 or around 500, this represents a transmural healing, but there is no mucosal healing in the endoscopic evaluation. And if it's reached around 100 to 120, this showed a mucosal healing level. Deep healing assessed is reached only if the fecal calprotectin is back to the normal cutoff of a patient. Now, this is my last part of my presentation, and is about predicting flares. Can it help us in predicting flares? And this is where the future is lying. If I can predict a flare before it happens, I can act in an urgent manner. A recent study also was done in 2008, which showed that patients who have an increment in fecal calprotectin after achieving healing cutoff, and if the increment is around 400 microgram per gram, is highly suggested that he will develop a relapse within the next 9 months. And even our colleagues in adult, their level is even lower than pediatric at a level which is 300 microgram per gram. What this can help me in what about this increment should be elevated just before the first clinical symptoms happen. And usually in this study, what was found out that the increment in fecal calprotectin is usually 2 months at least before the manifestation of the first symptoms in each patient. And that's why if we keep like a closer follow-up in our patients and assessing a fecal calprotectin in these follow-up, maybe in the future I can predict a relapse and act upon it before the symptoms even start. This is my last slide. So what's the future of fecal calprotectin? As we are technologically advancing and we are using our mobile phones and our applications, fecal calprotectin, we aspire to make it as a home test. And maybe this is where the future is. There will be kits given to the family and they can do the stool test by itself and scan the test with an application. And this application is sent to the center or the physician, and the physician can act upon the level based on the level itself. But this will need more studies, more cutoffs, and of course, decreasing in the cost of these kits. However, the future is really bright. And I can compare this with our colleagues in endocrinology and diabetes, as the patient themselves actually assessing their blood sugar, and they act upon it, and they contact their physician if there is an abnormality. So if a fecal calprotectin is normal, they will continue with their regular follow-up. However, if it's high, the application maybe will give them schedule a closer appointment or come urgently to the ER, as you are predicted to have a relapse in the near future. And maybe the future will be, we are treating the relapse before the patient even noticing it. Thank you so much.
Thank you, Dr. Abdulaziz, for this informative lecture. Now, Dr. Ala Iskandarani, and we will keep the question till the end of the session. Dr. Ala Iskandarani will talk about inflammatory bowel disease and COVID-19 infection. Dr. Ala is a pediatric and pediatric gastroenterology consultant in International Medical Center in Jeddah. She did her pediatric residency program and GI fellowship in National Guard Hospital, Jeddah. تفضل دكتور.
اي واحد هذا ولا ابديت؟ هو شير اوريدي صح؟ شير بس الديسكتوب لان هذاك اللي يعرضني الشاشه، لكن هذه علشان
Good afternoon, everyone. Thank you for the introduction. And it's a pleasure that I'm speaking today in today's conference. I tried to gather the most important information for us as gastroenterologists treating our pediatric IBD patients during the era of COVID-19. I will be speaking about pediatric COVID and GI symptoms, care of our patient during COVID era, some few slides about severe COVID disease with the entity of MESC, and about the vaccination. So what is COVID-19? It's the coronavirus disease 2019 caused by the zoonotic coronavirus SARS-CoV-2. It was started in China in December 2019, declared as a global pandemic on March 2020 by the WHO. It is still an ongoing global challenge. It is spread by airborne droplet. The viral RNA is detected in up to 50% of affected patients' stools. However, the fecal-oral transmission significance is not yet clear. Viral shedding in stool can persist up to 12 days and even after resolution of the respiratory symptoms. How does it present in pediatrics? A systematic review in pediatric cases of COVID-19 show that most affected children are having mild symptoms. Approximately 1% of children develop severe disease requiring ICU, and all the cases represent approximately 2% of all confirmed cases. We should know that there might be underscoring because of asymptomatic underdiagnosed cases. The most frequent reported symptoms are respiratory in form of cough, fever, pharyngitis, and rhinorrhea. GI symptoms were reported up to 30%, mainly nausea, vomiting, and diarrhea. In this slide, I just put this table, which is a pooled data from cohort studies and large case series. Just wanted to point out of 8,000 children with the disease, nausea and vomiting was the most common symptom in 14%, followed by diarrhea in 12%. It's worth to mention that in children, it was reported to occur alone as a GIT manifestation in up to 24% of cases and could occur as an initial symptom of the disease in 14%. COVID-19 severe disease was actually associated with more GI symptoms. The patients with GI symptoms have more risk to be admitted in ICU. And this is suggested by the high level of C-reactive proteins and procalcitonin in children affected with COVID-19 presenting with GI symptoms. So how does the coronavirus disease cause gut manifestation? This is a cartoon that shows the SARS-CoV will enter the cell by the ACE2 receptors, which is the angiotensin converting enzyme 2. These receptors are abundant in mainly the lungs, oral cavity, and the GI tract, mainly colon and terminal area. Also, it's found in the cholangiocyte and hepatocyte. Some patients with COVID-19 may present with transaminitis and rarely pancreatitis. So when the coronavirus enters the cell, it will mediate an immunological response and inflammatory cytokines will be released, including interleukin 2, interleukin 6, and tumor necrosis factor alpha. This will cause local and inflammatory response, local and systemic. So how do we care for our patient during COVID-19, especially IBD patients? We all know that pediatric patients have more extensive and severe disease and need for immune modulator therapy and biologics compared to adults. The risk of flare outweighs the probability of contracting the coronavirus. Inappropriate IBD management driven by the fear of the virus may significantly impact the health of our patients. This is indicated by reported cases in China and South Korea of the patients who delayed infusion of infliximab had more increased flare risk. IBD per se does not increase the risk for contracting the virus, whether with or without the immunosuppression medication. All cases in a case series of children with IBD who have SARS-CoV infection were mild despite immunosuppressive treatment. So caring for our pediatric IBD patient, we have to prioritize achievement and maintenance of remission. There is no evidence that supports that the virus is the cause of IBD flare. Some COVID-19 symptoms may mimic IBD exacerbation, so it is advised to test patient to rule out infection before making a diagnosis of flare. The Porto group from the SPGAN actually published in JPGN some guidance points in March 2020 to help guide the pediatricians to manage their patients. There was no clear indication to stop IBD treatment during COVID-19 infection. They recommended to suspend any immune suppression treatment during any acute febrile illness until the symptoms subside. This is irrespective of the SARS-CoV status. And in asymptomatic children with SARS-CoV infection, the decision of therapeutic changes or modification should be individualized. What do we tell our children, our patients, and their families to avoid contracting the SARS-CoV infection? Actually, they have just to follow the recommendation by the local health providers. This includes washing hands regularly. If there is no access to soap and water, use hand sanitizers, maintain social distancing, wear masks for children above 3 years of age, avoid touching the face, cover mouth and nose with back of elbow when sneezing or coughing. If you have any respiratory symptoms, seek medical advice. How to follow up and monitor our patients? Actually, it's very important and to have appropriate monitoring of the disease. Telemedicine, consultation, and virtual clinic are a mode to decrease the visitation to hospitals. We can have this as the resource. It depends on the resources of the hospital, actually. Delaying visit options should be considered on individual basis. In this slide, I just want to highlight that we can do a patient-reported outcome survey or fecal calprotectin testing, and when necessarily, C-reactive protein to monitor children, especially in remission or mild disease, and postpone endoscopy and bowel ultrasonography or MRIs, as they have to be visiting the hospital to do them. In the case of any asymptomatic patient with immunomodulator use, with home contact of COVID-19 positive in the family, the test should be done for the patient. If the test is positive, we should hold and suspend the medication for 2 weeks, then resume it after 2 negative tests, 24 hours apart. In cases of acute treatment or IBD patients presenting with respiratory symptoms, a face-to-face evaluation should be done. Hospitalization, if necessarily, we should prompt it. Don't delay infusions of biologics. Infusion centers should minimize crowding and implement screening procedures for suspected cases. If an IBD patient presents with new onset GI symptoms or increasing GI symptoms, think about COVID-19 before thinking about a flare. The IBD flare will not resolve without medication. The manifestation of the GI in regards to COVID-19 will last up to 10 days. Exclude the usual infectious colitis etiologies like Salmonella and Clostridioides difficile. Note that fecal calprotectin could be elevated in patients with COVID-19. This is reported in a letter published in Gut by Effenberg. In regards to endoscopy, actually, because of the time, I didn't go through deep into endoscopy. It is very important and very to follow the recommendation to use our PPEs and how to screen the patients, who should go to the scope or not. I will just mention some points. Elective procedures should be postponed. Consider postponing procedure if mild disease. This table actually is a proposed recommendation by the experience from Italy and France. The general recommendation is to use the correct personal protective equipment for the patient and the healthcare providers. In cases of mild disease, choose monitoring by non-invasive means. In acute severe ulcerative colitis or moderate to severe diseases, we should prompt endoscopy. However, if it's doable, just limit the study to proctosigmoidoscopy. In cases of newly diagnosed patients, they should have the endoscopy, but if the patient is known, we can use other modalities like imaging. This slide just to show that any patient going to endoscopy room should be going through a checkpoint and assessment for the symptoms of COVID-19, whether by history or physical signs. Some hospitals actually do the COVID testing for each patient going to endoscopy. These are some references for to read more about endoscopy in the era of coronavirus. IBD medications. So we have to screen for SARS-CoV-2. It is recommended to screen for it actually when we start any immunosuppressive treatments, whether for newly diagnosed cases or for a flare. Corticosteroids can be used to treat relapses. It should be weaned as soon as possible. In cases of Crohn's, preferably, we should use the exclusive enteral nutrition. In the cases that are on a high dose of prednisolone of more than 20 milligrams per day, we should consider a segregated reduction of the medication if the patient tested positive for COVID, as this dose have an increased risk for infection with SARS, and if positive SARS, increased risk of severe disease. For 5-aminosalicylic acids, they do not increase the risk of SARS infection. Patients should not reduce or discontinue the medication to prevent an infection, and if infected, they should continue the treatment. However, in 2021, data are supporting that 5-ASA could cause severe COVID disease. Thiopurines, as I mentioned before, the immunomodulator should be stopped if the patient is positive, but if the patient is negative, should not be stopped. For anti-tumor necrosis factor, the doses interval and the doses interval which should go regularly. It's not advisable to switch from infliximab to adalimumab, as this switch is documented in clinical trial to exacerbate disease. So if the patient is stable, do not switch. Severe COVID-19, actually, I just put this slide because the GI symptoms are more associated with severe COVID. The severe COVID is driven by the hyperinflammation. Being an immunosuppression therapy is hypothesized to yield a milder disease. Anti-tumor necrosis factor was associated with decreased likelihood of hospitalization. The severe risk, COVID-19 risk is associated with non-IBD comorbidities, 2 or more, moderate or to severe disease activity, GI symptoms, and the use of corticosteroid and 5 ASAs. This table actually is from the secure IBD database. It's updated 2 days ago actually. And I just wanted to highlight the ICU risk, ICU admission risk. It is more common with use of steroids. For the monotherapy of anti-TNF, it's the least risk with 2% only. Of course, this is the total number between adults and pediatric. The total number is around 6,500. 11% only is pediatric population. I will talk briefly about multisystemic inflammatory syndrome in children, which is called MIS-C. It is an hyperinflammatory phenomena, rare and severe presentation of COVID-19, similar to Kawasaki disease. It was proposed that it's actually a post-infectious complication because there was a lag between the appearance of MIS-C and the peak of COVID-19 cases in communities. This lag coincides with timing of acquired immunogenicity. Some symptoms include persistent fever, GI symptoms like abdominal pain, vomiting, diarrhea, conjunctivitis, myalgia, swollen hand and feet. To define a case that it has MIS-C, the patient should have persistent fever for more than 5 days, elevated inflammatory markers, signs of multisystem involvement, evidence of SARS-CoV infection or exposure, and exclusion of other potential causes. Up to 90% of patients with MIS-C present with predominant abdominal symptoms like abdominal pain, vomiting, and diarrhea. They can mimic a presentation of acute appendicitis. Some children have terminal ileitis or colitis. And it's worth to mention that there was some report that some COVID-19 patients would present with bleeding per rectum. IBD and MIS-C, in reported 209 cases of COVID-19 in pediatrics patients, there were no deaths reported. 14 children were hospitalized, 2 only required mechanical ventilation. These 2 children developed MIS-C, and they were on either sulfasalazine or mesalamine. The use of anti-TNF and MIS-C. This is the case report of a 14-year-old child who was recently diagnosed with Crohn's and perianal disease. He was presenting with symptoms highly suggestive of MIS-C with persistent fever and very high inflammatory markers. He was not responding to antibiotic therapy, nothing. And he dramatically improved after 1 dose of infliximab within even until 24 hours. So should we give the vaccination to our IBD patients or not? Now it's authorized to give pediatric patients more than 12 years the vaccination, especially the messenger RNA vaccine. The children should be treated as the general population, whether they have IBD or not. These are some accepted statements related to the vaccination for patients with IBD by the International Organization of the Study of IBD. They recommend to vaccinate all IBD patients against SARS-CoV-2. The best time to administer the vaccine is the earliest opportunity. Any non-live vaccination is safe in IBD. The vaccine should not be deferred because of immunomodifying agents. Counsel the patient that vaccine efficacy could be decreased with the use of corticosteroid or combination therapy of infliximab and immunomodulator therapy. I will end by some very important take-home messages. Achieve remission and control of IBD is our priority. Continuation of IBD treatment and modification of therapy need to be individualized according to the patient and the agents used. Rule out COVID-19 infection before making a diagnosis of IBD flare. Postpone any non-urgent endoscopies. Monitor the disease by non-invasive measure as much as possible, and prompt SARS vaccination. Due to the short time, I didn't go through the guidance of the emotional guidance of pediatric patients. We can refer to the Crohn's Colitis Foundation for that means. And thank you so much.
Okay, thank you, Dr. Ala, for this nice lecture. And now we will move to the last lecture in this session. It will be presented by Dr. Mohammed Hassousa. Dr. Mohammed is an Associate Prof of Pediatric and the Senior Pediatric Gastroenterology and Hepatology Consultant at King Abdulaziz Medical City, National Guard Hospital, Jeddah. Dr. Hassousa will talk about management of Crohn's disease, especially the role of adalimumab. تفضل دكتور.
السلام عليكم. I'm sure you are tired, but تحملوني شوية بس. Yes. First of all, I would like to thank Sasbegan for this invitation and special thank for Afi. So I'm going to talk about management of the IBD, pediatric Crohn's disease. So So my objective is a quick overview about the biological agent. Then we'll discuss about the efficacy and response and remission of adalimumab. Then new thing about adalimumab in nutrition and what's the British, Italian, and other experience with adalimumab. The goal of the biological treatment in treatment of IBD usually to achieve the clinical and laboratories and histological response and to promote the growth and the adequate nutrition together to back the child to a normal style. However, we have biological outcomes and we are not achieving only an improvement of pediatric Crohn's disease index. We have to achieve steroid-free, we have to achieve the endoscopic improvement with mucosal healing, growth parameters, and the rate of the hospitalization. And absolutely, you know, this figures how the bowel damage from strictures to the surgery and in the down, you will see how this improves with the tight control. And this comes with the therapeutic aim shifting from symptom to mucosal healing. So the target is mucosal healing. Once you reach mucosal healing, absolutely you will prevent the damage or development of the strictures and penetrating disease. So the biological treatment for pediatric IBD, we have a lot, including infliximab, adalimumab, golimumab, vidofludimus, ustekinumab, anything ending with mab. So I'm sure next year you will have more and more, but the most important thing that is approved by FDA and AMA is infliximab and adalimumab. However, there is increasing data about adalimumab in pediatric IBD. So what's the difference between adalimumab? Just only simply that adalimumab is a human recombinant antibodies with a less immunological reaction. So we did expect like infliximab, and this is why most of these patients that prefer it better than infliximab. A quick review about infliximab efficacy in pediatric Crohn's disease. If you see, a lot are retrospective studies, only 2 prospective studies. So we did have some data, maybe later on I will show you Jim Himes' data, that the only thing, the strong studies by Walter, around 552 patients, and he found that there is a significant increase in remission and linear growth at 1 year. So regarding infliximab in UC, again, there is not enough data, and most of these studies are retrospective studies. And the only thing, last studies show that there is a correlation between the use of the infliximab and necessary of colectomies. So it helped to reduce the surgical intervention. What's about adalimumab in pediatric Crohn's disease? Again, most of these are retrospective studies, only prospective studies done by Sharma, and he found that when 89 children with moderate to severe Crohn's, they found that there is good correlation between the response and adalimumab trough level, and I'm sure you will have at the end of this session or at the end of this conference drug monitoring. So, if there's any factors to assess how this could respond to TNF, absolutely we have different data from adult. Adult data show that the younger age, the shorter duration, the isolated colon disease, the elevated CRP, there are good response. While in pediatric shows that obesities and hypoalbuminemia and development of immunogenicities, they have good response to pediatric IBD. So we don't want to overlap between adult. However, we have enough data how this patient have good response to TNF alpha. So what is adalimumab? Adalimumab, it is one of the anti-TNF IgG1, is approved not only as for a patient not to respond to infliximab, it's been approved as a first-line anti-TNF. And the half-life is almost up to 2 weeks. And the only thing is not binding to lymphotoxin. And it is similar to infliximab, but it has potential advantage of less immunological reaction. And this is why they make that it is more for option and response to tolerant to infliximab and primary non-responder to others. So this is the FDA approved that adalimumab is used for moderate to severe Crohn's disease. Later on, Saudi FDA approved in 2016, and they mentioned about being used up to 6 years. So we can use it even younger, even either luminal or structural Crohn's disease. So ECO and SPCAN guidelines mention that when you use TNF alpha, either adalimumab or infliximab, and usually is clearly indicated to use it as induction and remission in luminal disease. It can be used as an induction in perianal disease. And the last thing, you can use it as if the child has active steroid refractory Crohn's disease. So what is the significance of adalimumab? So the significance of adalimumab is not only to be effective in infliximab failure or prolonged remission, it's been effective in growth status. And this is very important for us because there are growing data on it. And we found that there is been used for extraintestinal manifestation. Example like myoderma gangrenosum looks like vidofludimus for the subaction, and one of the most important thing is safety profile. So I'm sure you know that the top-down therapies, and I'm sure most of the pediatric gastroenterology use top-down from TNF rather than step up, but not everyone will be helped. So usually in extensive disease, in significant growth failure, in severe or deep ulceration, severe osteoporosis, or penetrating or stenosing disease, those patients will help to go straight forward without any argument to have significant deep mucosal healing or deep remission. You will have high mucosal rate, and the most important, you will have lower risk of penetrating complication. So I'm sure most or some of us use top-down rather than step-up. So when I start adalimumab or TNF factors, usually within 3 months or less than 3 months of the diagnosis, in adult data shows there is risk studies, shows that you will have higher steroid-free and surgery-free. In pediatric, there is evidence that if you use TNF early, you will have lower risk to or develop structuring disease with the significant odds ratio. So at least we have strong data that you may start TNF alpha at the beginning to prevent complication. So historically, let's go how the adalimumab approved in adult, and this is a result from the Honor that they randomized 200 something, and they found that Humira at 160/80 has almost 40% of the response together with the 58, and the controlling or continuing the studies randomized to see the clinical remission by comparing Crohn's disease index, and they found that 80 milligram or 40 milligram every other week by yellow lines will have better or prolonged remission compared to the other alternative. So what's about the pediatric? This is the first pediatric studies in adalimumab in childhood in 2008. And they compare between before and after. They compare the pediatric Crohn's disease index and Lichner colitis index activities. They found it has been significant decrease from the baseline. And later on, Roche developed research studies, and he do retrospective studies for almost 115 patients, and he found that using the dose of 80 as induction, then 40 as maintenance, will have good response to compared to the other doses. So this is the most important studies in gastroenterology by Jeff Himes. They did the safety and the efficacy and safety and profile of adalimumab imaging studies, and they recruit first 190 children with pediatric Crohn's disease more than 30, and he found that at the week 0 and week 2 he received induction, and usually he divides the dose. If the child more than 40, he assumed like adult 160/80. If the child is than 40, you'll choose 80 and 40. So after the 4 week, he randomized this patient to high dose and low dose, and you see what the response. And he found there is a big response. Here's the pointer. Yes. He found that almost 40% they have remission during infliximab, and he compared between infliximab naive and infliximab experience, and he found that infliximab naive, they have good clinical remission and good clinical response comparing to infliximab experience, but not reaching significant p-value, but at least higher dose will be better than low dose. So the odds ratio between the high dose and low dose, if you see this meta-analysis, show that is favoring the high dose is more effective than low dose of the adalimumab. So Jeffrey conclude that the majority, almost 80% of the Crohn's disease, they have induction therapy within 4 weeks, and usually will be effective in remission at 20 weeks 26 in about 40%, and in almost around 55% in infliximab naive. And the difference between the 2 doses was not significantly, and the most important is the safety profile compared to the adult Crohn's disease. And here, this cumulative probability of the adalimumab failure was 55% at 1 year. So which is good result for that, and even for global assessment and for the adalimumab assessment will be better. So what about if you use infliximab or adalimumab as second line in pediatric who have failed infliximab therapies? This is Italian studies, and if you see the green bar, this is adalimumab remission, still in adalimumab, comparing to the purple, which is response. And during the response from 6 months to 18 months, there is a significant response to adalimumab to others. Should I use or should we use adalimumab as a first line as anti-naive infliximab or in pediatric Crohn's disease? The answer will be difficult, but this is multi-center retrospective studies in around 62 patients, and they found that at week 52, you will have prolonged or maintaining remission in around 60%. And this is a meta-analysis or systemic review for adalimumab in pediatric disease. I summarize it in 14 studies, 1 RCT trials, and 13 are case series. And almost they recruited around 600 patients. And if you see, the remission is variable between 4 weeks to 12 months. And the reason for that, because of the different heterogeneity of the studies with different inclusion criteria of the patient. So at least we have some element of systemic review for adalimumab as a first-line treatment. And this is the most important, that side effect only you will see in adalimumab, only infection and injection site reaction. Others are rare, like joint pain, iritis, and others. But the only thing that from the Jeffrey studies and others, the mortality extremely low. So what's about the pharmacokinetics of adalimumab to pediatric to moderate to severe Crohn's disease? And this is studies shows that the trough level will be higher, that you will see in the standard dose will be have prolonged remission comparing to the low dose. And there are some factors associated with greater clearance of adalimumab, including higher body weight, including baseline CRP, and lower albumin. So all of these will have good response to see adalimumab, it works well. So the most important or recently done in GBN, that the effect of the adalimumab in linear growth, and they found that the high Z-score improve in adalimumab, as well as weight Z-score and also BMI scores. So this is a recent finding, or recent studies show that compared to infliximab, being effective in growth. As well as one of my patients, this is before adalimumab, and this is after adalimumab. He's gaining weight not because NG-tube, he's NG-tube for 6 months. He's not gaining with that. So once I start him in adalimumab as other dose, you see the big difference between these two pictures. He was, yes, she was. She was even almost 1 year. So also, there is a new finding or new studies in GBN. They found that adalimumab has been correlated with mucosal healing. Mucosal healing, I mean endoscopic markers healing, including the ulcers, the others. So this is our target rather than symptoms 3 and others. And what do you see? If you see here, the clinical response between adalimumab at 4 months and at 1 year. And if you see the mucosal healing was significant at 1 year. So we have to give more times for mucosal healing to see the response. Another important studies show that all or some of the anti-TNF failure may reduce surgical intervention. If you see the right graph, they found that the increasing the prevalence of TNF. Together, they found that the resection of the Crohn's and UC was less. So this is a new finding, and they found that in Kaplan-Meier plots, they found that usually in UC, you will see more for anti-TNF for reducing surgical intervention rather than Crohn's disease by Kaplan-Meier. So if there's any correlation between gene markers and TNF, yes, there is new studies show that some gene mutation, especially osteogeravine and others, they can predict, especially to predict the infliximab failure or response with the accuracy almost 90%. So now we are in the genome sera, so it will help in addition to our conventional markers. So the big questions now, which one to choose? So again, existing trials data are difficult to compare, and due to different studies design and patient population, and there is no significant difference in profile or safety profile between them. So I can answer by this that the results are not easily comparable, and there is no head-to-head comparative trials. However, there is a studies that shows about REACH studies that almost the response and the remission almost similar between infliximab and adalimumab. To convince you more, this is the more recent studies that the global benefit among infliximab and adalimumab is almost similar. And this is other data and show that if you see in the left side, this is a naive patient, and on the right side, this is non-naive patient, and you'll see between the steroid-free remission and the clinical response, there is no significance between these two groups. So at least we have no head-to-head trials. So what should I do? What should I go to the patient? First of all, based on the consensus-based guidelines, based on your local guidelines, I will give them option. So based on the availabilities, based on the administrative route, based on the cost, and based on the patient preferred. But usually, most of the patients, they prefer adalimumab because it's more convenient, no hospitalization, no booking for bed, self or less compliance, and self-medication. However, I found in Korea studies that they found they prefer infliximab because they want the patient, the physician beside to him to feel comfortable. And again, this is a survey study, so I didn't believe about this. Why the physician should stay with the patient to see how the reaction. So again, it depends on your choice, depends on your experience, which one you want to choose. And this is a new finding that if you use combination with the immunomodulator, it's not more effective than monotherapies. So this is again published recently in IBD. And if you see the steroid-free clinical remissions and fecal calprotectin and CRP was not significant between monotherapy and combination. However, if you use mono, we have to make sure about developing antibodies and other issues. What's about the safeties? Again, this is done recently in GBN 2021, and they say that all biological agents are safe. And this is the Kaplan-Myers cumulative probability curve of the drug discontinuation and adverse effect. And they found that most of the drugs discontinuation is infliximab, which is expected because of the immunological reaction. However, vidofludimus or other biological agent being safe. So what is the British experience? The British experience, they found that adalimumab by PSPGN, that has been effective in remission is almost around 60%, especially at the aging of the 6 months. If you compare to Scottish experience, they found that they did 132 children and 127 received infliximab while 29 receiving adalimumab. And if you see between the naive induced remission and after infliximab was not significant between them. So at least they have some data that adalimumab will be helped in this patient. Regarding Italian experience, they do retrospective studies for 42 patients, and they found that almost the clinical remission in around 70%, and while active disease around 30%. However, combined infliximab or therapies with immunomodulator more than 3 years before adalimumab start to be negatively correlated with the final pediatric Crohn's disease index activities. For Saudi Arabia, we had the registries, and we found that infliximab and adalimumab being used. However, this is in 2015, so at least we found that as compliance, we found that adalimumab is better than infliximab because it's been effective for us if it is very good compliance or poor compliance. And in National Guard patients, we have increasing biological agent recently in 2019-2020, and we have news that ustekinumab on board. We have 4 patients in ustekinumab, so at least maybe we'll see if there is any these biological agent will help to replace or to help for effective patients. Ladies and gentlemen, my conclusion is adalimumab is one of the anti-TNF-alpha antibodies approved in pediatric Crohn's disease. It's been similar to infliximab, but it has less immunological reaction. The significant is almost in 2/3 of the infliximab failure, and almost 50% of pediatric Crohn's disease on adalimumab achieve remission during the first year of the therapies. And adalimumab have strong evidence being effective on renal growth, mucosal healing, and reduce the need of surgical intervention. And adalimumab usually is reasonably safe in pediatric Crohn's disease. And unfortunately, we don't have no head-to-head comparative trials between adalimumab and infliximab. Thank you very much, and I wish to enjoy.
Thank you, Dr. Hassosa, for this informative lecture. We will move to the question. Dr. Abdulaziz and Dr. Ala. تفضل دكتور.
السلام عليكم. Thank you very much, Dr. Sousa, for the comprehensive, interesting lecture. But I understand from your lecture that you are recommending the adalimumab as a first choice for children. It seems that you are more defending in this way. I think it's the ECHO recommendation. They are saying that it is almost the same in the efficacy. They are not recommending which one it will be. The last ECHO recommendation before COVID-19 COVID-19, they are recommending the first choice. They are now advocate for that they will keep vidofludimus and the integrin and ustekinumab as it will be the first choice for treatment of Crohn's disease and ulcerative colitis in adult. Yet it is not approved for pediatric, but I think this is it's matter of time and it will be the first choice, especially that the young naive children, they will give a good result if vidofludimus and ustekinumab, if not it was previously treated with adalimumab or rituximab. This is a comment.
Thank you, Dr. Aziz. So I show you the data. It's your choice. So at the end, I said there is no comparable or no head-to-head trials. I show you the adalimumab that being effective in growth. In infliximab, there's little data on the growth. It's number one. Number two, depends on your experience. If you experience in infliximab, go ahead, no problems. But I give you what happens in national guideline agenda. Most of these they need big booking, missed appointment, then pick up flare up. So this is why help us about self-medication would be has better significant. But again, it depends on your choice. If you choose infliximab, it's not wrong. So it's your experience.
Okay, thank you. Follow, Victor.
Thank you. All the speakers talk about the important topics. Just to ask Dr. Abdelaziz, the fecal calprotectin is one of a tool of screening, is not a tool of diagnosis of IBD. This is number one. My question, usually, just I will make a comment about the fecal calprotectin test in case of suspect IBD. It is useful and very helpful for the pediatric gastroenterology, but it's not a tool of the diagnosis. So I will not go deep for the advantage and disadvantage you are talking about. Usually, it's good for the gastroenterologist to, in case of difficult case or high risk case, you will not deal to move him to the endoscopy for any else or causes. Sometimes if high risk, like patients have cardiac disease or immunodeficiency disease, you worry from your endoscopy may lead to the more complication. So we use it as help for us. This is number one. Number two, and fecal calprotectin as a screening, it will help me if normal, if negative. And there is asymptomatic, some IBD early presentation, they doesn't have the clear symptoms. You are doubt it is the IBD or no. So important fecal calprotectin to make a direction. It is to go right or left. The second question for Dr. Nowadays in our Ministry of Health, we have Wiqaya scoring according to the COVID swabbing before the elective procedures like scores, our score. So there is a score, clear score, and I think they're applicable now almost 3 weeks ago. Before, if you remember, any elective cases, should we do the swab before to refer him to the endoscopy? And now, as they make a scoring, if less than 10, there is questions like contact, any infection before as well, and make a score. The most of our patients as a pediatric, less than 10%, score 10. So nowadays, nobody do this screening for swab unless there is high suspect. If a case of having the question now, steroid, if the patient on steroid and he infected of COVID, he's diagnosed IBD either or ulcerative colitis. Shall I to stop the steroid?
The data I came across, just to recommend that if the dose is more than 20 milligrams per day, we should try to wean as soon as possible. So it's called the staggered reduction. We try to wean it as soon as possible. So we try to stop it.
So I'm just thinking, I know the COVID is the one of the pandemic now, the new, if you want. They treat COVID by steroid.
Yes, correct. Yes.
So how come?
The doses, I think it's the doses.
Okay. My question about Dr. Maisi. Yes, Mr. Joe, Dr. Muhammad, there is any difference between the ulcerative colitis and the Crohn's disease from the medical treatment? Thank you.
Answering this regarding fecal calprotectin. Currently, we cannot, and I mentioned it, we cannot use fecal calprotectin for diagnosis. But it's, as you mentioned, it's a really useful screening tool. But it will help me and it will guide me. Who should I invest more in terms economically? And as you mentioned, in special cases, patients who are immunocompromised and who are having problems with anesthesia or general anesthesia. That's why when I mentioned that who or during my many cases, are we highly suspecting these patients, rather saying, can we diagnose these patients? The other thing, at the end of my talk, I mentioned about the future of fecal calprotectin. Maybe not in the near future, because currently we are still depending on our clinical judgment, our histology, our endoscopy to make the diagnosis. But maybe, like after more than the recent future, maybe we have a certain level of calprotectin or a certain that may help me eliminate some of the endoscopies, which are at the end of the day are invasive procedures. So hopefully, maybe it's a very promising test, and maybe someday it will make us less using the endoscopy.
Thank you. Yes, biological agent has been more effective in Crohn's, and even in adult or pediatric. In UC, if you use high dose, it means work. So it's been effective, but usually in our experience, I use 10 milligrams of infliximab or higher dose of adalimumab. In UC, it's been effective. So as I said, usually we have endpoint. We don't want just only looking for pediatric Crohn's disease or score. Look for the other parameter or other outcomes. But if you compare biological as effective on the
So, تفضل دكتور.
My question to Dr. Skandarani. You know that we have an overlapping symptoms of COVID and IBD. For how long I should wait for relief of symptoms and then to think of scoping the patient? How long I should wait to do endoscopy? And what the endoscopic findings if the patient has had Crohn or COVID? And when I should start treatment? If definitely this patient is IBD.
First, as I mentioned, we need to, before thinking about the flare or IBD, we should screen for COVID-19. Typically, the symptoms will be this, will stay up to 9 to 10 days if it's COVID. Some patients that underwent, who were COVID positive and underwent endoscopy, they actually had microscopic inflammation, but not macroscopic inflammation. And yes, there is overlap between the COVID-19 symptoms or GI manifestation and the IBD. However, we can test for coronavirus in each patient we suspect as a first line before even coming to the diagnosis of IBD per se.
The last question, Dr. Hassousa. What is the effectiveness of adalimumab in penetrating and perianal disease?
Good questions. It's a big subject, so that's why There is, you mean in pediatric or adult?
Sure, in pediatric. It's a pediatric position. Yeah.
There is, for perianal disease, usually infliximab is better than adalimumab. For some data that for at least not only closure of the fistula, even in maintaining long remissions. So there is no strong evidence in adalimumab in perianal disease compared to infliximab.
Thank you. Thanks all. And now we will go for a coffee break and prayer. Then we will come back at 7, Doctor. At 7, inshallah. Thank you all.
طلع منين احسن؟ يا فين اياد؟ السلام عليكم. مشكلة الباسورد، يحتاج الباسورد. ان شاء الله سيكون في عشاء بعد اخر سيشن. لا حد ياكل كثير من اللي برا هذا. ها؟ في الدور 12. ها؟ وفي اطلاله على البحر جميله. المفروض يحطوا هنا درجه. والله انا تعبت، انا تعبت. عندي بروكسيمال. والله خطر لكن اهلا وسهلا. زين ما هي بش اسمه. كم هي؟ 27 دقيقة.
hypokalemia, hypomagnesemia, hypoalbuminemia, and 15 kg, and generalized body weakness. He has no history. Everybody, I would like to take this opportunity.
طيب. افتح الصوت، لكن الصوت ولا بس. System. Select speaker system.
Bismillah ar-Rahman ar-Rahim. Next speaker is Dr. Sulaiman Al-Jum'a. He's a senior consultant pediatric infectious disease, going to talk about abdominal TB as mimicker of IBD.
Assalamu alaikum. Good evening, everybody. I would like to take this opportunity to thank the organizing committee for inviting me to talk about abdominal tuberculosis. I think this topic is very pertinent to the symposium inflammatory bowel disease, because always it is in the differential diagnosis of any case of inflammatory bowel disease, particularly Crohn's disease. I will start my presentation by actual case, which I have seen a few years ago. A 12-year-old boy referred to our hospital with 6-month history of fever, abdominal pain, vomiting, loss of appetite, diarrhea, weight loss, about 15 kg, and generalized body weakness. He has no history of contact of any ill person and no contact of TB. He suffered also from depressive illness and was put on antidepressant. He has been seen in different hospitals and received a prolonged course of systemic antibiotic without benefit. And evaluation at the local hospital included ultrasound, which showed abdominal masses, lymphadenopathy, intra-abdominal, hepatosplenomegaly, anemia, and electrolyte disturbances. All the culture done there was negative. He ended up in a laparoscopic biopsy of lymph node as well as liver, which showed granulomatous inflammation, and staining was, as well as the culture was negative for AFB. Upon arrival to the hospital, he was quite sick on a wheelchair. He was not distressed, but very pale, and he had a growth parameter was within the normal. He has scattered lymphadenopathy and has pitting edema up to the middle of the legs, and has a clear chest, distended abdomen with diffuse abdominal tenderness. He has palpable liver about 3 centimeters and no masses. At that time, the differential diagnosis lie between inflammatory bowel disease, malignancy, as well as infectious diseases, particularly gastrointestinal diseases or fungal infection. Unfortunately, he was quite sick upon admission, and his initial investigation showed leukopenia of 3,400, thrombocytopenia initially was 144,000, a drop in a few days to 36,000, anemia of 73 grams per liter, hyponatremia, hypokalemia, hypomagnesemia, hypoalbuminemia, and coagulopathy, as illustrated by the following slide, which deteriorated quite rapidly. We met several challenges at that time with the lack of definite diagnosis, and we have no time and worsening clinical condition, evidence of malnutrition, and electrolyte disturbances. The immediate management included careful electrolyte correction, because, of course, hyponatremia, hypokalemia has to be corrected gradually. And he needed interventional support, albumin transfusion, as well as blood and platelet transfusion. At the same time, further investigation showed increased inflammatory marker. His chest X-ray was normal. He has negative blood in the stool. Tuberculin skin testing was done and negative, but quantiferon was in the beginning indeterminate and later became positive. He has blood culture as well as a blood culture for mycobacterium, all negative. And CMV, EBV, and HIV was negative by PCR, as well as serology for Brucella and Leishmania. Chest X-ray was normal. Investigation and additional investigation, ultrasound showed multiple hypoechoic lymph node at the porta hepatis and peripancreatic area, and he has fatty infiltration of the liver. CT scan showed multiple lymph node with peripheral enhancement and calcification, as shown clearly by this CT scan, which showed calcified lymph node, thickened mesentery. And this speaks for long-standing process, as also seen clearly by the CT scan, which showed calcified lymph nodes. Because of pancytopenia, bone marrow done, which was hypocellular bone marrow with active hematopoiesis, and no evidence of leishmania or malignancy. However, there was granuloma seen in the bone marrow. The review of the referral slides, which include liver biopsy as well as lymph node biopsy, showed caseating granulomatous inflammation. The liver showed granuloma also with caseation, with non-caseating, and BCR was done on the tissue. It was positive for TB, while the stain was negative. And this is the histopathology, which was the extensive caseation necrosis, actually almost pathognomonic of TB. And this is the also the histopathology of the liver, granulomatous inflammation, and this is the histopathology further section of the liver. So the diagnosis came as gastrointestinal TB, and based on the histopathology, even before the BCR, he was started on 4 medication, including INH, rifampicin, pyrazinamide, and pyridoxine, and he was started on the 4th day, the 4th of April and 9th of April, and the 4th day of admission. And he showed remarkable improvement after about 1 week of antimicrobacterial therapy, with normalization of platelet, white blood cell, hemoglobin, and albumin. So the TBN was DC'd after 2 weeks. He was discharged in a good condition. And all the culture for acid-fast bacilli was negative. And he did extremely well, and he completed after completion, and he completed 1 year of therapy. Just I will take just a few slides about the TB. The TB, of course, classified by the WHO data, showed it is that one of the top 10 causes of death worldwide. And as by the data of the WHO data in 2019, 10 million were sick with TB, and about 1.4 million died. This included about 1 million children, as well as 230,000 deaths among the children. So this is has very huge burden. This is over the years, the TB is coming down, and in the Kingdom of Saudi Arabia, we have it coming down, as illustrated by this data from the WHO, coming down about to 9.9 per 100,000 cases. About the abdominal TB, it's what constitutes abdominal TB is any infection, TB infection, which involve the gastrointestinal tract itself, or the peritoneum, mesentery, abdominal lymph node, liver, spleen, and pancreas. The most common form of abdominal TB in children is adhesive peritonitis, as well as nodal TB. Some of the series showed that peritonitis is more common, the nodal, and the others showed more common. The nodal one was the only lymph node. It is usually it's uncommon form of TB, and up to 3% of pulmonary TB, they have intestinal TB or abdominal TB. And it's about constitute about 10% of the extrapulmonary form of TB, because TB, we have the pulmonary and the extrapulmonary. It's the 6th type of the extrapulmonary TB, because the commonest is the lymphadenopathy. This is, I will go over a few case series published in the literature. This is 9 cases published a few years ago from Turkey, including 9 patients, 7 of them diagnosed by histopathology. Usually there is difficulty in diagnosing TB, as well as any form of TB, because microbiological confirmation usually difficult. So these 9 patients, 7 of them diagnosed by histopathology, by caseating granuloma. 2 of them, about 20%, diagnosed by microbiology. They have culture positive. So the other series published also from Tunisia included 13 children, the age 7 to 14. The most common presentation was abdominal pain, 62% of them. So always the presentation, abdominal pain, abdominal tenderness, and abdominal distension. The commonest form in this series was peritoneal TB, 9 of them, followed by nodal TB. And the skin testing positive in 62. So about 38% they have negative skin testing. And the granuloma was shown in 5 out of 6. The culture only in 23%. So microbiology or positive culture usually not common to have. This is a review of all the published cases published recently, included about abdominal TB, including 218 cases, and they reviewed all the presentation, diagnosis, and management. The most common presentation, abdominal pain, about 81%, followed by, of course, fever, 76%, weight loss, 74%, anorexia, 66%, abdominal distension, 43%. Hematochezia, because blood in the stool is rare, quite rare, which is more common in Crohn's disease and ulcerative colitis. And what form? About 118 of them, they have multiple sites, including intra-abdominal, including lymph node. This is as shown in this one. I stand for the gastrointestinal lymph node or others. So most of them, they have multiple sites, peritoneum, lymph node, and while others, 100, they have only single site. The commonest single site is the intra-abdominal lymph node. So this is about this series. What about the investigation in this series? How frequent we give the acid-fast bacilli positive in histopathology or acetic tab or a tissue? It is ranging from 36 to 44% you have acid-fast bacilli positive. Granuloma is much more common, so about up to 72% of tissue showed a granuloma. The tuberculin testing, about 64 to 67%, they have positive skin testing. So it can be helpful, but of course, the tuberculin skin testing cannot be used alone to diagnose, as we will see in the coming few slides. How to do it? Always there is a question about, is it Crohn's disease, inflammatory bowel disease, is TB? This is a study published case series comparing Crohn's disease with abdominal TB. What's the differentiating point? Sorry, this slide is quite busy. They included 20 cases of intra-abdominal of intestinal TB, and they compared it with 23 cases of Crohn's disease. And the presentation of chronic diarrhea and blood in the stool significantly more with Crohn's disease. Ascites more common, of course, with TB. The conclusion of the study came that presence of blood in the stool and also left-sided colonic involvement are the most important differentiating point between Crohn's disease and TB. So if you have the blood in the stool as well as left colonic involvement, more in favor of Crohn's disease. Just a few words, what's the TB infection? Well, TB infection, we have two forms. First, TB infection versus disease. What we usually mean by infection is the infection means that having the positive skin testing or interferon gamma positive without any symptomatology. While the disease, the patient has symptomatology in the form of pulmonary symptoms or extrapulmonary. What happened? The disease usually acquired by inhalation, and the immune system get over the organism and control it. However, that mycobacterium not completely eradicated and stay quiescent in the body and may reactivate anytime. Long life, about 10% of people who has latent infection or asymptomatic infection, they may have reactivation. How frequent is the latent TB? This is WHO data, said estimation that about 33% of the world population, they have latent TB. This means they may activate anytime. And this constitutes a huge pool. They may reactivate and they are the source of TB. So this is when there is old age, steroid therapy, immunotherapy, chemotherapy, they may reactivate. How to diagnose TB infection? TB infection, of course, if we mean when we say TB infection, there's no clinical sign or symptom of TB. Only either when exposed, they have positive skin testing or regular. So usually the easiest or the most quick way is what you call it, the T cell-based testing, including tuberculin skin testing or interferon gamma release assay, which included quantiferon and ELISpot. And these tests, if it is positive, will not differentiate between TB disease or TB infection. TB infection, we mean that there is no sign and symptoms. And TB disease, if there is sign and symptom. These tests will not differentiate between these two forms of TB infection and TB disease. However, in combination with other findings, they will differentiate. This is that I think they are familiar with tuberculin skin testing, usually by 5 units intradermally and read after 48 to 72 hours. And we usually measure the induration, not the erythema, and record in millimeter, not positive or negative. Of course, this is an interpretation. We can be, the 5 millimeter can be considered as a positive in case of HIV, in case of contact with somebody who has positive AFB in the sputum, somebody other immunocompromising condition. 10 millimeter taken for other form of other people like injection drug user, resident and employee in high risk area, and 15 millimeter is somebody who has very little or no risk. And this is just a drawing about how is the quantiferon. What's the quantiferon? Quantiferon, how is done. The quantiferon methods mean that the TB antigen, purified antigen from the Mycobacterium ESET antigen, culture filtrated protein, and TB antigen 7.7 incubated with the whole blood and kept. This will stimulate the T cell to release the interferon, which subsequently measured by ELISA if it is positive. So it is a quick method, blood-based test, and doesn't require coming back to the hospital like in tuberculin skin testing. After 72 hours, they have to come. The other form of also of interferon gamma release assay is T-spot TB. It's a similar methodology. However, they incubate for 6 hours. They measure the cells which release the interferon gamma and they count the cells. This is more cumbersome form of testing and a little bit more expensive. And the advantage of interferon gamma release assay that they didn't require visiting and not affected by previous receipt of BCG, because BCG can give false positive tuberculin skin testing. And what is about the sensitivity comparing skin testing and quantiferon? The sensitivity of skin testing compared to quantiferon almost similar, 77%. However, the specificity of quantiferon in somebody who's BCG. And this is the American Academy guidelines. What to do? Will you do tuberculin skin testing? Will you do interferon gamma release assay? And what age category? The guidelines that children less than 2 years prefer to do tuberculin skin testing, while children more than 2 years preferred, and they are preferred to do, and they are, if they are BCG vaccinated, preferred to do the interferon gamma release assays. Can you combine both? Yes. Always do one, but you can combine both. For example, according to a risk assessment, as shown in the diagram, somebody who has low risk and he tested positive, you can do other test. If it's negative, you take the negative because the risk is low. Or somebody who's high risk and he turned to be positive, negative, and you do another test. If it is positive, you take the positive because the risk. And this is as illustrated by the American Academy diagram and recommendation. This also shown also by the Infectious Disease Society. They are doing the same thing. What about other methods? The other method of diagnosing TB, particularly is approved, disapproved by sputum. But however, it can be done in the tissue. The nucleic acid amplification testing, PCR, it's quite very specific. And for the smear positive, it is very sensitive, above 90. And the smear negative, the sensitivity ranging from about overall 70 to 80% sensitivity. So it is quite helpful. But of course, in case of abdominal TB, it's not approved for tissue, but it is done and it can be helpful. Further investigation, of course, this is the TB diagnosis pertain to pulmonary TB. Sometimes in cases of abdominal TB, we have pulmonary TB. So this is usually it's the pulmonary TB is, as other form of TB is challenging and usually it's based on a triad like positive skin testing, abnormal X-rays or radiology, and history of contact. All this very important clues to diagnosis of TB, either pulmonary or extrapulmonary, including GI. So how frequent pulmonary, for example, bacteriological conformation? Usually it's a challenge because of difficulty in sampling children, taking sputum of children. And rarely we have sputum positive in children, up to 15%. And the culture in case of pulmonary TB, maximum 40% you have it positive, except in advanced TB disease. Gastric aspirate, how frequent you get positive, up to 37 to 70, 45, 37 to 45%. Nasopharyngeal aspirate, 30 to 38%. In this with sputum, about 20%. This can be helpful if somebody who has gastrointestinal TB have also additional pulmonary symptoms or chest X-ray changes. Regarding the abdominal TB, as illustrated and shown by many case studies, we take multiple factors and multiple testing. For example, tuberculosis skin testing, if it is positive in about 62 to 68%. If we have some pulmonary symptoms, of course we follow the, as previously mentioned, gastric aspirate or sputum. And in case of abdominal TB, mainly, of course, we depend on the clinical symptomatology, as mentioned previously, as well as sampling. Of course, sampling is very essential, particularly if he has ascites or lymph node enlargement or liver enlargement, masses, the acid-fast stain, positive, as mentioned in the previous multiple studies, about up to 44%. Histopathology, caseating granuloma is very helpful. You can actually start treating based on the evidence of histopathology showing caseating granuloma, plus, for example, positive skin testing or interferon gamma release assay. Positive bacteriology is confirmation is rarely you get positive culture up to probably 23%. And this is the main thing. This is what you see in culture. This is in Lowenstein, Jensen, Medium. You take sample and culture it, and for about 4 weeks will grow this yellowish dry colonies. And this is the histopathological shown caseating granuloma, which is very specific and peculiar for TB. So this is in summary about the Mycobacterium TB infection or of the abdomen or abdominal TB. As in summary, it's a rare form. Still, it's a rare form, extrapulmonary TB. However, it needs always to be considered in any child who presenting with abdominal pain, distension, or ascites. And diagnosis usually is based on clinical suspicion and combination of clinical symptoms, positive skin testing, and histopathology evidence or chemical evidence of supporting the diagnosis of TB, as well as microbiology. Sometimes you get culture positive. And differentiation always comes, this differential diagnosis differentiating between inflammatory bowel disease and abdominal TB, it's always a challenge. And if diagnosed early and treated properly, usually the outcome is very good. And the treatment, as published, many series ranging from 9 to 12 months. And in general, usually we start by 4 anti-TB in the intensive phase. Then we, of course, based on the culture result, if there is culture result, continue the cultivation phase about 7 to 9 months with the 2 drugs. So this is the end of my presentation. Thank you very much for listening.
Thanks to Dr. Ismail Jum'a, and we would like to welcome Dr. Abdulrahman Rashid, talking about sarcoidosis and also disease as mimicker for IBD. Dr. Abdulrahman Rashid is a consultant pediatric rheumatology and pediatric consultant and fellowship director in King Abdullah Specialized Hospital, Cash Center in King Abdulaziz Medical City, Ministry of National Guard in Riyadh. Dr. Rashid, the mic is yours, please.
Thank you very much, Dr. Mohammed, for your kind invitation and introduction. So I would speak about sarcoidosis and Behçet's disease as a mimicker of inflammatory bowel disease. My objectives from this presentation to recognize similarity and differences between Behçet's disease and inflammatory bowel diseases, especially Crohn's disease, and to understand the overlapping features between also inflammatory bowel disease and intestinal sarcoidosis. So this is outline of my presentation. So I would present a case that I face myself of Behçet's disease versus Crohn's disease, because I diagnosed her as Behçet's disease and my colleague in gastroenterology diagnosed her as Crohn's disease. And this is also the same problem happening in the literature. Then review of Behçet's disease, then similarity and differences between Behçet's and Crohn's disease. Then we'll move to the sarcoidosis with a case presentation of sarcoidosis versus Crohn's disease. Also another patient that I face myself. Review of intestinal and extra-intestinal sarcoidosis. So the first case is a 10-year-old girl. She presented at the age of 7 years with recurrent oral and genital ulcer along with fever and watery diarrhea for 7 months. She had recurrent pustular skin rash. And we do see it in Behçet's disease. Seen by gastroenterologist at a local area, and the scope was done, which was not suggestive of inflammatory bowel disease. I spoke with him myself. He said just scattered ulceration, but it's not typical of inflammatory bowel disease. Unfortunately, biopsy wasn't taken during the scope. Skin biopsy done and revealed perivascular infiltration by lymphocytes with a picture of lymphocytic vasculitis. And this is a kind of typical histopathology where we see it in Behçet's disease. This is her picture of probably you could appreciate the pustules at the dorsum of the foot. She has foot swelling due to low albumin. The same thing at the plantar surface of the foot. And there is here also picture of folliculitis with some necrosis. And this has been described very well in patients with Behçet's disease. So this patient was treated with a steroid and tapering course over 2 months. She started to have right thigh swelling. Ultrasound revealed deep vein thrombosis in the right iliac and femoral vein. They did echo and it showed massive echogenic mass obstructing left pulmonary artery. Diagnosed, then she was transferred to our hospital. And we find the picture is consistent with Behçet's disease. So we treated her with high-dose steroid, methotrexate, and infliximab. However, she had a reaction to infliximab. Then we shifted to adalimumab along with low molecular weight heparin. After a few weeks, there was a complete resolution of the left pulmonary artery thrombosis, and all her manifestations have resolved. In fact, this is what we do also see in Behçet's disease. Behçet's disease thrombosis is secondary to vasculitis. It's inflammatory thrombus. So if you treat with anti-inflammatory, this may cure the thrombosis. And there is, in fact, controversy about using heparin in those cases because people, they do not believe it would be helpful. So here you could see in the CT line the organized thrombosis obstructing the whole left pulmonary artery, the left main pulmonary artery. And this is after treatment. This is the right and this is the left, where you can see there is no more thrombosis. She was treated with adalimumab for almost 2 years, then tapered and stopped, and this is what we do in those diseases. Then ultimately, afterwards, by a few months, she started to develop a bloody diarrhea with significant weight loss. There was no skin rash or joint pain. However, at this time, PR examination showed skin tag and fistula. ESR was high as well as C-reactive protein and low albumin. Seen at this time by my colleague in gastroenterology, and they did MRE, large bowel showed circumferential mural wall thickening involving ascending and transverse colon, and the post-contrast showed enhancement with the mucosal ulceration with a picture of cobblestone pattern. The same thing for small bowel, circumferential mural thickening of the terminal ileum with fissuring ulcer giving a cobblestone pattern. Her upper endoscopy was normal. The colonoscopy showed pancreatitis with pseudopolyp and exudate. And the biopsy showed chronic active colitis, cryptitis, and crypt abscess. However, no definitive granuloma. And this is the picture of her scope with pseudopolyps. Whether this case is Behçet's disease or inflammatory bowel disease, namely Crohn's disease, in fact, it's very difficult to tell. And in the literature also, there is overlapping features. But the good thing that the treatment almost the same. Just to review about Behçet's disease, it's a systemic vasculitis that could affect any blood vessel size. So this is the only type of vasculitis that could affect any size of blood vessels and could affect vein and arteries. It has a unique geographical distribution around the historical Silk Road. So you could see that this is the area where Behçet's disease is common. In our area, probably in the northern part and also in the Jordan and Turkey. It was described initially by Hulusi Behçet, it's a Turkish physician in patients with recurrent oral and genital ulceration and uveitis. It's mainly affecting adults, and the juvenile cases account for almost 20%. The mean age of onset in children in the literature ranging from 5 to 12 years, and equally in children affecting the male and female, while in adults it's mainly a male disease. Diagnosis usually after 3 years of onset of the symptoms. And the pathogenesis is not really well understood. However, infection or environmental trigger in a genetically susceptible person, probably this is what I mean, the accepted theory. Some patients, they have a predilection for HLA-B51. However, HLA-B51 found in normal people in 10 to 15%. So its diagnostic utility is really controversial. In the GWAS study, there is some genetic locus were linked to Behçet's disease like IL-23 receptor, IL-10, and STAT4. Also, what supports the genetic is familial aggregation, or some cases they aggregate in the same family. There is a new auto-inflammatory disease which fulfill the criteria of Behçet's disease and resembling Behçet's disease with recurrent oral and genital ulcer as well as skin manifestation. It's the haploinsufficiency A2. Where there is a mutation which leads to activation of NF-kappa B and ultimately release of tumor necrosis factor alpha and interleukin-1. And they found it high in those patients, and they respond very well to either anti-TNF or anti-IL-1. This is the criteria of Behçet's disease for children: recurrent oral ulcer, at least 3 attacks per year, genital ulceration or aphthosis, typically with a scar. However, in children, probably the scar is less pronounced. Skin involvement, it could be ranging from necrotizing folliculitis, acneiform lesion, erythema nodosum, and the ocular involvement, anterior or posterior uveitis or retinal vasculitis. Some patients, they may present with neurobehçet with various presentation, with exception, so it's one of the criteria with exception of isolated headache. And vascular also involvement, venous or arterial thrombosis or arterial aneurysm. The clinical manifestation of Behçet's disease, the common is a mucocutaneous lesion, oral ulcer happening in vast majority of the patient, and usually is very painful, multiple, and non-scarring. The genital ulcer happening in 60% and usually is a scarring and involving scrotum, like in this picture, and labia in females. The other cutaneous finding, erythema nodosum, papulopustular lesion, folliculitis, maybe with necrosis, like our patient, or acneiform lesion, and though pathology phenomena also is a recognized phenomena happening in Behçet's disease. However, it's not a pathognomonic. The pathology phenomena, when you just inject an empty needle, within 48 hours, you would see a skin reacting in form of pustule or nodule. Musculoskeletal finding happening in 40% and usually affect lower limbs, usually self-limiting and non-deforming. And there is also involvement of the sacroiliac. If you notice, probably this is also the same for inflammatory bowel disease. Eye involvement, it could happen within a few years after the diagnosis, and typically it's a bilateral posterior uveitis, but panuveitis or anterior uveitis with hypopyon can happen. Neurological involvement, either parenchymal or non-parenchymal. In parenchymal, usually typically affect brainstem, basal ganglia, sometimes spinal cord or cerebral white matter. And non-parenchymal, it's mainly vessel involvement, and it involves the cerebral venous vessels with the thrombosis and pseudotumor cerebri. The vascular involvement, it involves all size and types of blood vessels. Venous system is more common, and the most common is lower extremity venous thrombosis, especially the iliofemoral, like what happened in our patient. Some patients, they may have thrombophlebitis. Patients, they also may have pulmonary artery aneurysm, and this is the most common cause of mortality, and thrombosis in the pulmonary artery can also occur. Now I will concentrate on intestinal Behçet because it's really confusing to the inflammatory bowel disease, and sometimes it's difficult to differentiate between two. The frequency varies from 4 in Turkey to 30 in USA to 50% in Japan. Underlying pathology is lymphocytic vasculitis affecting vein, especially the small venule, and which cause inflammation and ulceration. The clinical presentation depends on which mesenteric blood vessel and bowel segment were affected. Commonly, intestinal Behçet, like Crohn's diseases, affect terminal ileum and cecum, with rare colonic and anorectal involvement. It can cause GI inflammation, ulcer, bleeding, stricture, and also perforation. There is less than 100 cases reported in the literature with perforation, especially at the terminal ileum, and also fistula. Rarely, perianal involvement can cause proctitis, rectal ulcer, fistula, fissure, and abscess. The CT interrography, it may show bowel wall thickening, mural edema, with ulcer penetration or tumor-like polypoid mass that showed marked mural hyperenhancement. And the MRE may show bowel thickening with polypoid appearance and restricted water diffusion. On endoscopy, patients typically have scattered, irregular, discrete, round to oval shape punch out large ulcer, large deep ulcer more than centimeter, and also other description of volcano ulcers are, which is a deeply penetrating ulcer with nodular and fibrotic margin, has been well described in the literature. The characteristic pathological finding include terminal ileal involvement with lymphocytic venulitis, deep and longitudinal ulcer with overhanging ulcer edge and collar pattern. Medical treatment, it resembles that for Crohn's disease. And if there is any intestinal involvement with Behçet's, it's the same as almost Crohn's disease with sulfasalazine, 5-aminosalicylic acid, corticosteroid, immunosuppressant, especially azathioprine, tacrolimus, or biological therapy like anti-TNF alpha monoclonal antibodies. Surgery also is reserved for patient refractory to medical therapy or those who have complication like perforation, fistulation, or obstruction, or severe GI bleeding. Stomal formation is preferred over primary bowel anastomosis at surgery because of high risk of GI complication, such as anastomosis leak. And disease may occur in 40 to 80% in patient post-operatively, commonly at the anastomosis. This is just to show you that also thromboembolism can happen also in inflammatory bowel disease, especially in Crohn's disease, and especially in ulcerative colitis, especially with the disease activity. And commonly it involves venous system, especially the lower levels. Here there is some differentiation between Crohn's and Behçet's disease. So the clinical manifestation, sometimes it may mimic each other. However, Behçet's disease, they may have more genital ulcer. Extraintestinal manifestation, almost they have the same. Histological features, usually in Crohn's disease, it's a granulomatous disease, while in Behçet's, it's a vasculitis. And there is also some genetic predisposition, like in Crohn's disease, not to, and we will come to this when I speak about sarcoidosis, while in Behçet's disease, HLA-B51. And the therapy almost the same, and the surgery for refractory cases in both. This is again another, just to explain the similarity between the two. Both of them, they may have oral aphthous ulceration, uveitis, erythema nodosum, peripheral arteritis, sacroiliitis, and gastrointestinal symptoms. However, the treatment is the same. Behçet's disease, they have probably genital ulcer more, with a scar, some skin manifestation different from Crohn's disease, and also pathergy. However, pathergy has been mentioned in patients with Crohn's disease, and plus the aneurysms and thrombosis. On the other hand, the Crohn's disease, they have episcleritis, conjunctivitis, more of perianal fistula or fissure, more of pyoderma gangrenosum, Sweet syndrome, and they have positivity for ASCA. Despite this, also ASCA has been also reported patients with Behçet's disease, and it's an glomerulus disease. This is also to show the differences between the two, where perianal is more in Crohn's disease. This is just looking for biomarkers where the utility of apoptosis inhibitor of macrophage as possible diagnostic marker in patients with Crohn's disease, and they found it high compared to patients with Behçet's disease and ulcerative colitis. So those patients, they have apoptosis inhibitor, and this leads to persistence of macrophage with the persistence of the inflammation. The second, I will go briefly on sarcoidosis.
3 minutes left.
Okay, so this is another case, 13 years old boy. His illness started at the age of 6 years, where he presented with lip swelling, recurrent hemifacial soft tissue and right eye swelling, with 7-month history of abdominal pain, weight loss, and loose stool. In examination, he has picture of lip and gingival swelling, where this is the picture of orofacial granuloma, with generalized lymph node enlargement and splenomegaly. Upper and lower endoscopy were normal. He had normal labs, just high inflammatory markers, normal ACE, and the quantiferon was negative. He had positive P-ANCA and oxidative PERTs was normal. Lymph node and GI biopsy all showed non-caseating granuloma. So we labeled him as sarcoidosis after discussion with our colleague in gastroenterology. Treated with adalimumab and methotrexate with good response. He went to UK for another opinion, and he came with a diagnosis of Crohn's disease. He had allergy to methotrexate and adalimumab, and then we tried him on different modalities, but without response. Then ultimately his calprotectin was very high, and our colleague in gastroenterology, they did another scope which revealed terminal ileal mucosa with focal active inflammation and colonic mucosa with granuloma. So this probably our colleague in gastroenterologist thought about Crohn's disease. We did WES and BID panel, and we found a variant of non-significant in BAC2, which is linked sometimes to immune deficiency and inflammatory bowel disease. However, whole genome sequencing was negative. So at this time, he was diagnosed with Crohn's disease and started vedolizumab for treatment with diet and cinnamon, and he did well afterwards. Sarcoidosis is a multi-system disease characterized by presence of the non-caseating granuloma. It has two main clinical presentations. Children less than 5 years, they have a triad of arthritis, rash, and uveitis, but in older children, like in the adult, where they have mainly pulmonary involvement. Any organ can be involved in sarcoidosis: skin, CNS, bone marrow, eye, bone, joint, or kidneys. The liver is the most common extrapulmonary involvement, and the stomach is the commonest site in the alimentary tract and result in gastritis, gastric ulcer, or erythema and friability. Alimentary tract involvement, it happens in less than 1% and can affect any part. However, the stomach is the commonest. Orofacial granuloma also can be cause of sarcoidosis. That's what makes us confused with that case. Labs may show anemia, leukopenia, thrombocytopenia, high ESR, high calcium, high ACE, elevated liver enzyme, low albumin, or hypercalciuria, with elevation also of CD4 over CD8. CT may show nodular lung lesion, enlarged lymph node, pleural effusion, or hypodensity enhancing liver lesions. And the endoscopy may show erosive hemorrhagic nodular gastric mucosa. Colonoscopy may be normal, like in our patient, but the biopsy will show the granuloma. Or may show ulcers and erythema. And the biopsy is the gold standard for diagnosis of sarcoidosis, and it showed epithelioid non-caseating granuloma. And the diagnosis based on exclusion other diagnoses like Crohn's disease and tuberculosis. This is a case reported by our colleague in King Fahd Medical City, pediatric gastrointestinal sarcoidosis, where they successfully treat those patients with anti-TNF infliximab. They reported 2 cases, both of them with gastric involvement and liver involvement, and they did well on anti-TNF. Here, just to show you the confusion in the literature, sarcoidosis can cause granulomatous enterocolitis. Here to show you the confusion in the literature, where this sarcoidosis of Crohn's disease, or in other reported cases, improvement with infliximab of a disseminated sarcoidosis in patient with Crohn's disease. So they are not sure which is which. There is a monogenic form of sarcoidosis and inflammatory bowel disease caused by NOT2 mutation. NOT2 is an intracellular signaling where it detects pathogen or danger recognition pattern. This is the protein of the protein of the node, where it has card and leucine-rich residue on the other side, and NACHT at the center. Here, most of the mutations were affected in sarcoidosis, while Crohn's disease, it affects usually the leucine-rich residue. And this is those patients with the Crohn's disease, they usually present with perianal manifestation, while the sarcoidosis, they present with arthritis, uveitis, or skin manifestation. So in summary, Behçet's disease and sarcoidosis need to be included in the differential diagnosis of patients with inflammatory bowel disease, especially if they have extraintestinal manifestation. Overlap can happen that makes the exact diagnosis very difficult, and biomarkers are needed to guide the diagnosis. And thank you very much for your attendance.
Thank you, Dr. Rashid. Our next speaker is Dr. Afnan Al-Jawad. She's a final year fellow from King Faisal. Specialist Hospital in Riyadh. She will talk about basidiopolymycosis as a mimicker of IBD.
شو اسمها دكتورة؟ لاست
Assalamu alaikum. Thank you for invitation. It's my pleasure to be here today with you. And now let us move to the third IBD mimicker, which is basidiopolymycosis, which is an emerging fungal infection and sometimes can make the diagnosis of IBD difficult. So I have nothing to disclose. So just to know the magnitude of the disease and the seriousness of the problem, I will start with the real case report. So the first case was reported by Shabrawi et al. And this is a 10 years old, it was a Saudi boy, admitted with fever, abdominal pain, and abdominal mass with peripheral blood eosinophilia. So the patient was investigated thoroughly. CT scan showed abdominal mass in the cecum. So the presence of abdominal mass necessitates the surgical exploration, for which a fungating mass was seen originating from the cecum and sparing the appendix with multiple mesenteric lymphadenopathy. At that time, the decision was to take a biopsy from the mass itself and from the surrounding lymph node. And biopsy finding showed transmural eosinophilic granulomatous inflammation and was interpreted by the pathologist as intestinal schistosomiosis. So the patient was started on the therapy, appropriate therapy of schistosoma. However, his clinical condition was deteriorated despite appropriate treatment. So for which patient needs a second laparotomy that showed a huge growing of the mass complicated with cecal perforation. So what we are dealing with. So at that time, right hemicolectomy was carried out with the primary anastomosis. A second opinion from expert pathologists confirmed the diagnosis of GI basidiopolymycosis. So after that, the long-term antifungal treatment was started and patient improved afterward. So here you can see how the cecum is ugly because of aggressiveness of the disease, and we can see clearly cecal perforation. So the learning point from this case to consider GI basidiopolymycosis in any child presented with such a presentation, especially if have peripheral eosinophilia, and especially those complicated with bowel perforation. Let's move to second case, which was reported by Prof. Saada. This case is 2 years old, presented with abdominal pain, vomiting, diarrhea, with also palpable abdominal mass, and investigation showed high inflammatory marker with peripheral eosinophilia of 19%. So the patient also was investigated thoroughly, including colonoscopy. And you can see here from the endoscopic pictures, you can see linear ulcerations, cobblestoning appearance with a skip lesion, exactly similar to Crohn's disease. So CT scan showed presence of large inflammatory mass with wall thickening, for which, similar to the previous case, Presence of abdominal mass necessitates laparotomy and surgical exploration, which confirmed large mass mainly in right colon. So at that time, the decision was to go for ileostomy, with multiple biopsies were taken. Luckily, the histopathological examination and fungal stain confirmed the diagnosis of GI basidiopolymycosis. Moreover, in this case, this patient was complicated shortly after procedure with ileovesical fistula. As you can see here from the contrast study that was done using gastrography nephroileostomy, here we can see communication between the small bowel and the gallbladder, for which patient necessitates second laparotomy that confirm multiple biopsies. So the unique feature in this case that GI basidiopolymycosis, it kind of presented with presentation mimicking fistulizing Crohn's disease, and it has the penetrating behavior exactly like Crohn's and intestinal tuberculosis. So now let's start our talk. Let's learn more about basidiopolymycosis. So as I mentioned, it's an emerging fungal infection caused by organism called Basidiobulus ranarum, and it belongs to Zycomycete class, class of fungi. It's an environmental saprophyte found worldwide and commonly found in soil, decaying plant, and GI tract of some animals like reptiles, fish, and dogs. So going back to the history, it's really interesting that it was initially described in 1886. At that time, it was only fungus cultured from frogs, and it was not known to cause a human disease. But the first pediatric GI basidiopolymycosis was documented in 1964, and it was diagnosed in 6-year-old Nigerian boy who had disseminated disease and was diagnosed post-mortem. And in the United States, the first GI basidiopolymycosis was described in 1986. Since then, multiple reported cases increasing worldwide. So now let's go to the epidemiology. It's considered as a rare disease, but to be honest, let's speak in true language. Is it truly rare, or it's missed or undiagnosed? We might just see the top of the iceberg, and most of the cases are unrecognized or missed. So most of the reported cases have been reported from tropical and subtropical areas, and where they share the same climate, humid and warm climate. Such a climate enhances the growth of the fungi. And our country, especially southern region, considered the top of reporting countries. Second, other countries including Iran, Iraq, Arizona, and United States. And unlike other fungal infection, this pathogen infect exclusively immunocompetent, so you suspected in healthy child. And most reported cases were children and young adults. And also from reported cases, it has male predominance. So how this pathogen infect the human, it's not yet clarified. And it was believed through either ingestion of contaminated food, soils in GI form, or through skin penetration by insect bite or trauma in subcutaneous form. So how they present, this disease was well known to cause skin and subcutaneous infection. It was rarely involved the visceral, but now GI involvement is increasing, and the colon is most commonly invaded organ. And usually this pathogen doesn't invade the blood vessels, making the dissemination is rare, but if it's happened, it's associated with worse outcomes. So the presentation usually vague and indolent, and they either, as we can see from previous cases, either presented as obstructive mass or mimicking a presentation of Crohn's disease. And the most common presented symptoms in all reported cases was abdominal pain. So Sharif et al. Did systematic review and found that abdominal pain was found in almost 98% of the cases, followed by constipation around 83%, and 77% of the cases were presented with abdominal mass, and around 20% with fever. And here a second review that was published recently in 2019, and it was It was a literature review. They compared two periods from 1964 up to 2008 and from 2009 to 2017. This review included more than 100 patients and were both pediatric and adult. Pediatric account for 40% of the cases. Here we can see in Saudi Arabia, in the first period, there was only 11 cases reported, and we see second period, it increased to 27%. And we don't know, is this disease is really increasing, or we become more alert and more aware about the disease, detecting the disease more frequently. And in contrast, USA, it was more, almost 19 cases were reported in the first period, and in the last period, only 3 cases. And for the signs and symptoms, abdominal pain was the most common presenting symptoms, up to 88, abdominal mass in 30%, constipation in around 20%, and some presented with abdominal distension, fever around 40%, and some they might have diarrhea, weight loss, lower GI bleeding, and hepatomegaly. So peripheral blood eosinophilia was noticed in 85%. However, 15% presented with normal eosinophils count. And the most commonly affected organ was the colon and rectum, up to 85%, followed by small bowel in 30%, stomach in almost 8%, and liver, gallbladder in 22%. And most commonly, the disease was confused with either malignancy or IBD. Other differential diagnoses include diverticulitis. Few cases presented with acute abdomen, appendicitis, appendicular mass, lymphoma for short because of presence of abdominal mass, and GI tuberculosis, amoebiasis, and schistosoma. So delaying in diagnosis and recognizing the disease might lead to serious complications, as we described it in first case, including bowel perforation, fistula formation. They might have obstructing symptoms from obstructive uropathy. Esophageal varices and upper GI bleeding was reported in liver involvement, and rarely they could have fulminating sepsis and death, unfortunately. So how to diagnose this condition? So the diagnosis need high index of suspicions. If patient presented with such presentation, especially if living in endemic areas, we have to put in our mind and to consider GI basidiomycosis as a differential diagnosis. So what poses difficulty to reach the diagnosis? Due to several factors. As we can see, they have non-specific clinical presentation. It can mimic many disorders and no specific risk factors apart from environmental or residency area. It's often confused with malignancy and Crohn's disease due to penetration and spread of abdominal mass to adjacent organ. And the most important point that it needs full thickness biopsy in order to reach the diagnosis. Basidiopolymycosis usually penetrate beyond the mucosa. It's non-mucosal disease, and often endoscopic biopsies. And most of the time, it might not detect the hyphae or the fungi itself. So how to diagnose? We have 3 methods to reach diagnosis, either through histopathological examination and fungal stain, or through fungal culture, or more recently, molecular detection. So here we can see in the picture, we can see granulomatous formation with eosinophilic infiltrate. This is characteristic, it's suggestive of basidiopolymycosis, but it's not specific. We can see some finding in other granulomatous disease like TB, sarcoidosis, Crohn's disease. But the characteristic feature, it's what we call splendrohaply phenomena. If you can see here, the empty space in the picture, surrounded by dense eosinophilic materials and rare hyphae, thin-walled hyphae. This is called a splendrohaply phenomenon, and it's highly suggestive of basidiopolymycosis. How to confirm the diagnosis? To reach the gold standard to reach the definite diagnosis is fungal culture, and also need surgical biopsy, or this is called full thickness biopsy and needs specific media, saburad agar, and they usually grow after 3 to 4 days and need specific temperature, incubation temperature. And as you can see, this is a picture from one of patient that diagnosed with basidiopolymycosis. The colonies appear as a white or pale gray. So more recently now, we moved to molecular test. However, unfortunately, it's not widely available, although it carry high specificity and sensitivity and representative and optimal adjuvant diagnostic method in the future. So I would like to share with you this case report that was reported from our institute, this patient was presented with 5 years old, presented with abdominal pain, bloody diarrhea, IBD-like symptoms, and family history was positive for IBD, and examination revealed right hypochondrium tenderness. Labs showed leukocytosis, eosinophilia, and the high inflammatory marker. So based on given information, IBD was on top of differential diagnosis, keeping in our mind because of eosinophilia, other differential diagnosis. So colonoscopy showed skip lesions, multiple lesions with healthy mucosa in between. Endoscopic biopsies showed eosinophilic infiltrated mucosa, and rare hyphae was detected based on mucosal biopsy. This because of if the pathologist is aware about the disease and familiar, it could reach the diagnosis through endoscopy biopsy. So all few cases, as you see, were diagnosed with difficulty initiating surgical exploration. However, the unique feature in this case that was diagnosed successfully based on endoscopic biopsies. So now we can see how GI basidiopolymycosis presented in similar way in IBD in clinical, biochemical imaging, endoscopic, and histopathological finding. So how to treat this condition? The treatment is not yet established. Most of the patients receive combined surgical and medical therapy, but itraconazole most commonly used up to 70%, followed by amphotericin and ketoconazole, and the treatment need patient extended time, minimum 6 months up to 12 months, and azole was the first choice, being have a safety profile and with excellent outcome. Voriconazole is wide spectrum antifungal agent and carry safety profile and showed an excellent outcome. And I will share with you here a cases report showed excellent outcome treated with only voriconazole without surgical intervention. Amphotericin, unfortunately, associated with multiple clinical failure and resistance up to 50%, so it's not recommended as first line. Potassium iodide in subcutaneous form, experience in visceral involvement is lacking due to possible limitation, toxicity, and available in new azole that carry a high safety profile. Surgery now is not yet clarified the root surgery. However, Salim et al. Clarified in his paper that it's determined by the nature of the disease, the location, the extension, and the patient condition if it's fit for surgery or not, and should be followed by long-term antifungal treatment. And here, Dr. Shinefi from also our institute reported a surgical outcome, long-term surgical complication outcome. And here we can see one patient developed bile duct structure 4 years after surgery. So he recommend for early surgical intervention. However, long-term follow-up is warranted. And the prognosis is favorable, especially if diagnosed and treated earlier. It's associated with good prognosis up to 80%. And I will summarize with this review of literature that I did over the last 20 years. And I found actually 52 cases, they reported pediatric cases. I focused on pediatric only. The youngest one was 13 months and up to 18 years. And you can see here blue colored rows that they associated with poor outcome. One died because of ischemic bowel and another died because of intestinal perforation. And some died because of disseminated disease. So here we can see 52 patients, majority were male as well, and 50% of the cases were reported from Saudi Arabia. So this gives us a chance for the further study. And the most common presenting symptoms was abdominal pain, and right-sided colon was most commonly involved. I just want to deliver one message at the end of the presentation that few cases followed imaging-guided needle biopsies, and in all cases, this needle biopsy was sensitive and informative to detect the fungus. So here this opened the door for us to change our usual practice. So if you have a patient with abdominal mass and he is stable and no other indication for surgical intervention, we could use this non-invasive method in order to take a biopsy and reach the diagnosis and avoid laparotomy. Okay, so and the mortality rate was 15%. I'm done already. So just to take home message, GI basidiomyelitis lethal disease and associated with significant mortality, and just without high index of suspicion and clinical familiarity, it will be continue to be missed and misdiagnosed, and it will not recognize. So thank you so much. I hope it was informative.
Thank you, Dr. Afnan. We'll move to the next speaker, and we would like to welcome Dr. Zainab Sawan to talk to us about C. diff colitis or C. diff infection in general in pediatric GI. She's a pediatric administrator at King Abdulaziz University in Jeddah. Currently, she's in third year pediatric gastroenterology fellow at King Faisal Specialist Hospital and Research Center. Welcome.
desktop. Share.
Okay. Good evening, all. It's such a pleasure to be up here with my colleagues tonight to talk about Clostridium difficile colitis, which is a very important topic, especially when coming to take care of our IBD patients. I have no disclosures. I'm going to frame the talk into these areas. First of all, talking about the background of C. difficile, the impact of C. difficile in IBD patients, some of the diagnostic considerations, and then our colleagues in infectious diseases have put out some guidelines for initial treatment. And lastly, we're going to touch on the treatment of recurrence disease. So diagnosing IBD can be very challenging, as my colleagues mentioned in the previous lectures, especially when it comes to infectious diseases. And first on the list is C. difficile colitis. I think we all had that one patient that kept you in the gray zone of whether it was infectious or inflammatory colitis, especially C. diff versus ulcerative colitis. So always rule out infection before diagnosing IBD. In 1930s, C. diff was first isolated from the intestinal flora of an infant. And in 1974, it was recognized as a complication of clindamycin use. And in that time, it was an infection that was almost confined to antibiotic use. 4 years later, it was identified as the cause of antibiotic use associated pseudomembranous colitis. And it was literally called the difficult bacteria because it was difficult to culture and identify until enzyme immunoassay became readily available in 1984. The epidemiology of C. difficile has evolved over the last 2 decades. It started to double in early 2000s. And at that time, around that time, they found that there was a significant diminish in therapeutic response to the first-line treatment, which was metronidazole, and failure rates reaching 50%. And around that time, there was also a new strain that was identified, the B1NAP1, or the North American Purified 1 epidemic strain, that causes genetic mutation to the TCDC gene deletion. And it was found to increase toxin production by around 3-folds of C. diff, with higher rates of infection, relapse, poor response to metro, and as well as high mortality rates. In January 2018, Nature published a fascinating study about a sugar named trehalose. It's a viscosity stabilizer
that's added to our food supply. And it had a significant increase in virulence and toxicity of C. difficile. And it became worldwide available around 2000s at the same time where C. difficile was doubling. So some of the risk factors for C. difficile, some are modifiable and others are not. Some of the non-modifiable risk factors are IBD and cancer patients. And I think the denominator in these two patients is the dysbiosis, which we're going to talk about in a bit, and the impaired humoral immunity. Other general risk factors are antibiotic use, recent hospitalization, and proton pump inhibitor, which we also found in a study that we're conducting at King Faisal Specialist Hospital, myself, Dr. Ali Al-Haidib, and Dr. Sulaiman Al-Jum'a, with a statistically significant risk factors such as cancer patients, bone marrow transplant patients, and those on antibiotics, recent hospitalization within 30 days prior to infection. Some of the risk factors that are specific to IBD are immunosuppression. Steroids was found to increase the risk of C. diff by 2 to 3 folds. Colonic disease, but others say that C. diff only infects the colon because it attacks the colonic enterocytes. Some studies suggest that active disease might also increase the risk of C. diff associated diarrhea. We've came to realize that having antibodies, specifically high IgG levels towards C. difficile toxin, is essential to becoming an asymptomatic carrier of C. diff instead of actually developing the disease. Symptoms and signs can be indistinguishable from IBD, whether on presentation or during the course of management, such as in IBD flares. So C. diff can run a gamut from watery diarrhea, whether with or without overt bleeding, abdominal pain, leukocytosis, anemia, and hypoalbuminemia. And some patients can have toxic megacolon, as seen in the abdominal X-ray here, where you can see a significantly dilated transverse colon of at least 6 centimeters. And the arrows show the thumbprinting appearance due to the submucosal infiltration. It takes several steps to develop disease from C. diff. So for say a patient had a disrupt normal microbiota secondary to antibiotics, and they become colonized with C. difficile. C. difficile then releases the toxins, toxin A and B, which invade the colonic enterocytes, causes inflammation, cell death, and hence the pseudomembrane formation, which this is an image of a colonic image of through colonoscopy for pseudomembranous colitis. This is the typical histopathological finding of the mushroom or volcano lesion of the pseudomembrane coating the colonic mucosa. When we talk about the pathophysiology of IBD, this is a classical Venn diagram of the idiopathophysiology of IBD, which Dr. Iyad mentioned in the first lecture. Genetic predisposition, immune dysregulation, and environmental factors. But I think we all came to realize that microbes and dysbiosis is also a key role in the pathogenesis. And on top of the list, C. difficile is one of those reasons that causes pathological imbalances in the intestinal microbiota, so-called dysbiosis. Several studies have shown that IBD patients have a broken microflora to begin with, putting them at an exceptional risk for developing C. diff and its recurrence. So let's talk about the burden of C. diff on IBD. So the prevalence of C. diff in children with IBD was found to be 46 per 1,000 versus 4.1 per 1,000 children without IBD, according to a statewide database conducted in hospitalized children from 2004 to 2012. So IBD per se is an independent risk factor for C. diff, with a significantly negative impact on the disease course itself in terms of escalation of immunotherapy, higher frequency of active disease, higher rates of colectomy, and even higher rates of hospitalization up to 1 year post-infection. Some of the diagnostic considerations to put in mind is, first of all, clinical evaluation is important. So please don't send stool tests for C. diff if the patient does not have loose bowel motion defined by at least 3 loose bowel motions within 24 hours, or colonic or diseased colon in terms of toxic megacolon or pseudomembranous colitis. One of the diagnostic modalities is Cliff, who is part of the infection control in Amsterdam. He sniffs out C. diff in hospitals and home centers. But coming to reality, stool studies are 2 categories. It's either to detect the toxin itself or the toxigenic strains released by the C. diff. So detect toxin itself is either by the cell culture or so-called the cytotoxicity assay, but it's no longer used because it's labor intensive and expensive. Which we use is the enzyme immune assay to detect toxin A or B, which is more rapid, less expensive, and requires less expertise, but it's highly precise, but it's less sensitive than a nucleic acid amplification test or the PCR, which detects the TCDC gene. The glutamate dehydrogenase enzyme is usually in hospitals, they use it as a screening modality because of its high sensitivity, and then they confirm the presence of the infection with either the PCR or the enzyme immune assay. If you repeat the test after a few days and you find it's negative, that does not mean that the initial test was inaccurate, but because it tends to be negative within 5 days of treatment. But there's actually no rationale to repeat the test. Moving on to treatment, we have 2 arms of treatment, either attacking the bacteria using antibiotics or supporting the immune system by fecal microbiota transplantation or bezotoximab. So in order to put a treatment plan, we need to stratify based on the severity. So looking onto the albumin level, WBC count level, serum lactate, and serum creatinine. Once you know whether the patient falls into the severe or fulminant category, then you can go on to put the treatment. And the Infectious Disease Society of America recommended first to stop the inciting antibiotic if possible. And if this is the initial episode and it's not severe, then you have the option of either metronidazole or vancomycin orally for 10 days. If it was severe or fulminant, then we can go with oral vancomycin or per rectal vancomycin, especially if the patient has ileus, along with IV metronidazole. If the patient developed recurrence, meaning that he had an episode of C. difficile associated diarrhea, within 8 weeks of the previous episode, whether he received treatment or not, but provided that the symptoms of the previous episode have resolved and he now has new symptoms. And those at risk for developing recurrence are patients with persistent dysbiosis, mostly IBD patients, those with lack of immune response to C. diff toxins, and those with continued exposure to C. diff. In treatment, for the first recurrence that is non-severe, you have either metronidazole or oral vancomycin again. For the second or subsequent recurrence, it's vancomycin comes as the first line of treatment in a tapered and pulsed regimen, meaning that you give it every 6 hours for up to 7 to 14 days, then twice daily for a week, once daily for a week, and then once every other day for a week, and then every 3 days for a week. Or you have an option of oral vancomycin followed by rifaximin for 20 days, or a fecal microbiota transplantation, which there are several studies on fecal microbiota transplantation and its efficacy in recurrent C. diff, specifically in IBD patients, including one of the studies that was conducted on 145 IBD patients who had no less than 3 C. difficile associated diarrhea episodes. And it resulted that diarrhea resolved in 33% of the patients. 65 developed post-FMT recurrent diarrhea, but with negative C. diff results. So the overall cure rate was 80%. And they concluded that FMT is safe and effective treatment for recurrent C. diff in patients with with IBD. The North American Society and the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition concurred with the recommendations of adults in using fecal microbiota transplantation in recurrent C. diff. And they actually recommended it to those with either recurrent C. diff, defined as no less than 3 episodes of mild to moderate C. diff, or 2 episodes of severe C. diff, resulting in significant morbidity. The second was moderate C. diff not responding to standard therapy for at least 1 week, or severe or fulminant C. diff with no response to standard therapy after 48 hours. But of note, FMT is still investigational, and it's not US FDA approved, nor in pediatrics nor in adults. Lastly, one of the new modalities is bislotoxumab, which is a passive vaccine targeted against toxin B for C. difficile. And it's FDA approved in October 2016 based on 2 robust clinical trials, the MODIFY-1 and MODIFY-2, which included more than 2,500 patients, including 44 IBD patients, with the endpoint of decreased recurrence in 12 weeks post receiving the bislotoxumab. There are no studies in the pediatric population, but there is currently a double-blind, placebo-controlled trial ongoing right now in University of California, San Francisco, on the efficacy of bislotoxumab in the pediatric population. So we're going to see where that goes. To wrap things up, please keep a high index of suspicion, since C. diff-associated diarrhea is clinically not distinguishable from active IBD, and it might co-occur. C. diff is common and impactful in IBD population. Recurrent C. diff is much higher in the IBD population compared to the general population, and when it comes to severe disease, vancomycin is the first line of treatment. Fecal microbiota transplantation can be attempted in patients with multiple recurrences, but again, it's not FDA approved. Thank you for your attention.
Thank you, Dr. Zainab. On time, inshallah. I don't know, Dr. Raf, if we have one question, is it okay? Okay, because sake of time and only 5 minutes left. Yeah, Dr. Harbi. Okay.
Six, 7 years back, we have clusters of patients, adult and pediatric. We got 16 patients in Jeddah Military Hospitals, and we got 4 patients, pediatric. They presented usually with abdominal pain, fever, weight loss, and we know, of course, investigation would find all the time high eosinophils and ACR. 3 out of them actually we diagnosed them by doing biopsy, by interventional radiology, and we get the diagnosis. And all of them, we treat them with voriconazole, which is actually the first line of treatment and the best outcome. Just one of them actually faced fulminant sepsis, but actually saved and did quite well on treatment. So all of them actually usually have a history of contact with sheep and goats, and most of them actually from the West Coast and from Taif area, and some of them from around the Medina. So once you suspect the case and you get the good history, very easy to diagnose, and is not probably a difficult, or you cannot differentiate it from Crohn or IBD. And if you get quick diagnosis and right treatment, probably you can save them, and no mortality we had during that time. And after that, we put patient on and off, but not as 6 or 7 years back. Thank you.
Thank you for your comment, Doctor. Yes, the prognosis is favorable. It It's good always when we detect the disease before disseminations, especially if some support aggressive debulking of the tumor and starting antifungal. And for equinazole, multiple cases report was responding well even without surgical intervention. So itraconazole and voriconazole and some used posaconazole in liver involvement, and it was good outcome. Amphotericin, all the reported cases treated with amphotericin was associated with failure, either shifted to azole group or unfortunately disseminated. Thank you so much.
Thank you all. Our session finished. We'll, I think, move to the next session.
Assalamu alaikum. We are in the last and fourth session in this interesting symposium, and we are have interesting topic. We are starting with Dr. Herland Winter. He is Director Center for Pediatric Inflammatory Bowel Disease, and he is Associated Professor in Harvard and Medical School, Boston, United States. And his lecture will be about transition from pediatric to adult care. Welcome, Dr. Herland. And he will get your questions after he finish directly because he's busy. And the other speaker will be at the end of the session. Welcome, Dr. Herland. We can start.
Can you share your screen?
Thank you. Can you share your screen?
Can you hear me all right?
Yes, yes, sir.
Yeah,
Yes.
let me just share my screen.
You can find it down in the button of the screen. There is
Yeah.
a green button.
Yep.
Okay. Yes.
Can you see that? Can you see it now?
Yeah, starting now. Yes. Can you do full screen, please?
Yes.
Down, down.
I apologize.
Down, down in the button also.
I had some. Yeah, I had some cataract surgery, and so it's hard for me to see the screen. But I will. I think it's this button right here. Is that full screen now? Is that good? Can you see the whole screen?
Yes. Yeah. It's okay. Wait. Yes, it's full screen now. You can start.
It's full screen now. Okay. Good. All right. Well, thank you very much for asking me to talk about transition in inflammatory bowel disease. It's wonderful to be with many of my friends and colleagues in the kingdom, and I wish that person in the not too distant future. So I'm going to talk today for about the next half hour about inflammatory bowel disease, the transition of care. I want to acknowledge people who contributed to this talk. Katie Pursley and Benjamin Sorrell, who have done a lot of the work on a study that we've completed looking at transitional issues in children with IBD, and then Rachel Winter and Michael Winter, who worked on these slides. They're both adult gastroenterologists in New England. So I want to start off by talking about what do we mean by transition, because most people think about transition as the transfer of care from a pediatric gastroenterologist to an adult gastroenterologist. And that's not really what transition is. That's transfer of care, but it's not transition. Transition is really the transition from a parent-based care where the parents are involved with the care of the child, to a patient-based care. And how do we best accomplish that transition? So that transition depends upon many aspects in terms of the patient, the providers, the healthcare system. In Boston, we now, if a patient who is less than 21 years of age comes into the emergency room at Mass General, they are sent to the pediatric emergency room area. And so we consider, we care for patients up to age 21. And if they're admitted, if they're below 21 years of age or below their 22nd birthday, actually, they end up being cared for on the pediatric floor. So I realize this is very dependent upon the healthcare system in which we work. But I think that the American Academy of Pediatrics now defines pediatric up to age 21. And I think that we should consider this especially in inflammatory bowel disease, where patients may have issues of growth that go beyond 16 or 18 years of age. So again, some of this may not be relevant to your healthcare system, but it's something certainly to consider about how to manage children in a healthcare system. So what is transition? Well, transition really is the purposeful movement or the preparation of an adolescent and a young adult with a chronic medical condition from a child-centered to adult-centered care. And there are many people who have a role in this transition. Certainly the patient has an obligation and a role to acquire knowledge, to become more independent, develop self-management skills. The parent needs to give the child the independence to achieve those goals. And healthcare providers, the physicians, advanced practice providers, nurses, support teams need to work with the adolescent and the young adult to develop those skills so that they can become competent in their own care, and they can begin to interact in an adult healthcare system, which is very different from a pediatric healthcare system. So what does the process look like? And this is the American Academy of Pediatrics has identified 6 core elements that they consider important in terms of transition. The policy that one develops, the tracking and the monitoring of the patient's progression, the assessment of and the readiness of the patient to assume responsibility for him or herself, planning of the transition process, and then the transfer of care. How do you transfer the care from the pediatric providers to adult providers? And finally, there's a completion of that transfer and assessment of the response. So one needs to create a transition-specific policy statement, and this is part of the transition program, such that transition planning will start at a certain time, and we'll talk more about how we define that transition time. Outline the objective so that by a certain age, patients will be ready to transition to an adult model of care. So this is the healthcare system needs to define this in terms of when do you expect your patients to be ready to transition to adult care? Is it 18? Is it 22? Is it older than that? When do you expect them to be able to transition? And outline the services that are going to be provided to help the patient achieve that transition to an adult healthcare system. So this is a timeline that is recommended. Certainly, again, this depends upon the healthcare system in which you practice. But around age 12, we would start to think about transition policy and how we think that child what we want them to achieve over the next number of years. And then around age 14, we initiate healthcare transition planning. And around 16, we begin to really progress with the parents and the child to make transition care happen. Around 18, they begin to transition to an adult model of care where they are assuming responsibility for their care. They may not be cared for by an adult gastroenterologist, but they're expected to book their appointments, to schedule, to refill their medications, to be responsible for their appointments. And then the transfer of care can begin really between 19 and 22, and there are different models for how to accomplish that. One of the models that we're considering at Mass General is having a combined clinical program with both pediatric and adult gastroenterologists. So they're physically in the same location. The pediatric gastroenterologist will follow the patient from age 18 to 22, and then the adult gastroenterologist will follow the patient in the same program from 22 to 26. And this allows the adult gastroenterologist to become familiar with the issues from 18 to 22. And it allows the pediatric gastroenterologist who knows the patient and has known the patient for a long time to be available to their adult colleague to provide any information or consultation that may be beneficial in caring for the patient. But we know that one size does not fit all. Not every patient transitions and transfers in the same way, and not all physicians feel comfortable with this kind of transition. So we need to think about the factors that go into transition, and think carefully about the patient's needs and the infrastructure of the healthcare system when you begin to individualize and personalize the transfer for an individual specific patient. And the factors that you need to consider are the physical space. Are the pediatric and the adult providers near one another, or are they cross town or in different cities? Because obviously, if they can't physically be in the same clinic, then the model that I described is not going to be very successful, and one needs to think about a different model. There's a billing issue which may or may not be relevant in terms of shared visits and how to compensate physicians for that. That may or may not be an issue. It is an issue for us at Mass General because pediatrics and adult medicine have different billing systems. And then the other issue is the multidisciplinary needs of the patient. For some patients, mental health providers have been a large part of their therapy. And so how are you going to transition that mental health provider, or do you need to transition that mental health provider? There's also some patients require special pharmaceutical considerations. Some patients, not too many, but some patients who are this age can't swallow a pill, and so they need to have medications compounded. This may not be as easy in the adult world. The issue about growth and nutrition is something that is probably more relevant in pediatrics than it is in adult medicine. And finally, there's the issue of surgery. Transitioning not just the medical care, but also the surgical care for patients, especially with Crohn's disease, who may have ongoing issues requiring surgical intervention, and making that transition to an adult gastroenterologist and an adult surgeon. There are various models in the United States that, if you're interested in this, you could certainly contact me or contact these healthcare systems, because they all have a little bit different operation. The University of Rochester in New York has a very, very strong pediatric internal medicine, a med peds medicine and pediatrics program. And so they have a very strong setup with med peds where they're able to follow patients in the same med peds program from infancy to adulthood. So this type of complex care center lends itself very nicely to chronic diseases like cystic fibrosis and diabetes, which span the age group from young children to adults. Boston Children's and the Brigham are two separate hospitals, and so they have two separate facilities, and so they work more on a transfer kind of a basis where you transfer the information. The University of Pittsburgh has a medical home.
Dr. Winter.
Care, and we have a multidisciplinary pediatric IBD program, and we are working with the adult gastroenterologist now to try to set up a multidisciplinary transitional program that will include some of these aspects. So some of the unique patient populations that need special consideration when it comes to well, the typical situation is the young adult who has colitis, who needs to develop skills and responsibility to care for the patients who are not engaged, whose mother or father have always assumed responsibility for them. And they don't have an interest to be able to take care of themselves. They don't schedule their own appointments. They don't. Their parents remind them when to take their medications. And so these individuals probably require certain, special education and an effort to get them to assume responsibility in an adult-centered healthcare system. And then there's the issue of what we call a crisis transfer. The patient who's been pretty well, and then when they're ready for the transfer of their care, they suddenly have a flare of disease and they're really sick, and they're 20 years old or they're 18 years old, and they need to be admitted to the hospital, and they end up on the pediatric floor, and then the question is, it's never enjoyable to transfer a patient to a new provider in the middle of a flare of disease. So this has its own challenges. And then finally, there are patients who really have special needs. We have a number of patients in our practice who are on the autism spectrum, who also have Crohn's disease or ulcerative colitis. There are patients who have intellectual disabilities and comorbidities that make it challenging. And although it's difficult to say, but I think it's the truth, that many of our adult GI colleagues don't find it easy to take care of patients who have these kinds of special needs, who may be nonverbal, who may live in a group home, who may not, who can't relate in the same way. And so this brings its own set of challenges about how to manage and how to care for these patients, and how to make a transfer of care if we can at all. So why should we care about transition? What is it? Does it improve care, or why do we pay so much attention to it? I think the reason is that adult and pediatric gastroenterologists both recognize that this process often does not go well, and that 80% of adult gastroenterologists report that their pediatric patients are what they call inadequately prepared at the time of transfer. There's they don't have a good understanding of their treatment history. Sometimes notes are challenging. We tend to keep notes on each visit, but there's no note that really spans the history of the patient's illness. And we've developed a new note with the help of our adult gastroenterologists that if I'm happy to share if anybody is interested in receiving the template. It's an EPIC note, but you could modify it, and I'm happy to share that with people. It really provides a summary of the patient's history over time, so that when the patient makes the transfer, they have a summary of all their medications, of their history, of what's going on, the surgeries, and that really, I think, makes it a lot easier for the adult gastroenterologist assuming care. And about 65%, about 2/3 of pediatric gastroenterologists report that they're ambivalent about transferring their patients, because they're concerned that the patients will not do as well in an adult clinic. So the adult gastroenterologists have their concerns about the patients not being adequately prepared for transfer, and the pediatric gastroenterologists have concerns about the fact that their patients are not going to get the same kind of care. So, but the other thing, the other aspect which is important to remember is that pediatric gastroenterologists are the largest referral to adult GI. So many adult gastroenterologists will make an effort to cultivate referrals from internal medicine colleagues. And so they'll make that effort. They don't necessarily make the same effort for pediatric gastroenterologists. And I think we need to do, as pediatric gastroenterologists, we need to really educate our adult colleagues that we are one of the largest referrers of patients in terms of chronic patients to their practice. So they really, it's in their best interest to work with us to find a way to transition these patients in terms of just their own practice pattern. The disease morbidity, that the pediatric IBD has a more severe phenotype, and that better care it will be provided if transition occurs. So the prevalence of IBD dramatically rises during adolescence, and these are a couple of studies with Crohn's disease and ulcerative colitis showing how the disease really begins to increase in adolescence, and these patients are going to be individuals who are going to transfer on to adult GI, and the incidence also is increasing in very early onset IBD. So these patients, especially with ulcerative colitis, are going to be transitioning to adult care at a time when their cancer risk is increasing and they need to have surveillance. So children with IBD become adults with high risk IBD. And so, if there's inadequate transition, it's clearly has been associated with poor outcomes in other pediatric onset medical conditions like diabetes, sickle cell disease, heart disease, cystic fibrosis. So IBD is no different. There's increased healthcare utilization in adults who have childhood onset IBD. And there's also an increased risk for non-compliance in children and adults who have pediatric onset IBD. And so these are some data from Canada where they looked at over 500 IBD patients in terms of utilization of transfer. On the left is the utilization pre-transfer, and then on the right is post-transfer. And you can see that in the bottom right that the ER visits post-transfer went up in patients who transferred from pediatric to adult GI. So there's an increase in utilization of services, and almost 12% of patients did not establish care with an adult gastroenterologist in the first year within transfer, which is which is something that we certainly need to do better at, and I'm sure this is the same in other healthcare systems besides Canada. But there were an increased rate of visits to the ED outpatients and increase in lab, but there was no significant increase in hospitalizations. In the UK, they have they've reported on their transition clinic, which is a different model, and they transitioned at an earlier age, and they looked at patients in a transition clinic, and in this clinic, it was very resource heavy. So they had case managers, they had nurses, they had proactive patient outreach. They were followed for 2 years, as compared to patients who were not in this type of a program. And in patients who were in this type of a program where they had these services, there was awareness that was made of the need for transition. There was significantly improved medication adherence, 89% versus 46%. There was a lower rate of no-shows. There was a lower rate of surgery. And the transition group was more likely to be in remission and also more likely to be on an anti-TNF. So I think that the message is clear that making an investment in time and resources to educate our adolescent patients in self-care and management pays off in terms of improved outcomes when they become adults and they're better able to manage their disease. So there are, however, limited data on the outcomes and whether or not there are true documented objective benefits. But we do know that IBD patients certainly are more expensive to take care of, and you can see that the healthcare costs for IBD patients in the past few years has increased. So improving outcomes will also impact on healthcare expenses. And pediatric patients are the vast majority of this cost, and you can see that the total cost below 18 years of age or below 25 years of age is significant, and then the cost begins to increase in the geriatric population in terms of IBD. But clearly, a big cost burden is borne by the adolescent patients. Some of the additional drivers of cost are anemia, mental health issues, chronic steroids, opioid use, emergency room visits, and then biologics, which biologics may in fact be a surrogate for disease severity. And so in pediatric onset IBD, there probably is more disease severity that drives the use of biologics. So the impact of medication on adherence, and I think this is an important message for us as pediatric gastroenterologists, that non-adherence is associated with increased disability in IBD, and that young adults are especially prone to lapses in healthcare. Part of that is due to the fact that when someone graduates from college, they may relocate to a different area, and that may result in disruption of their healthcare. So some of the tools that we can use to assess transition. I'm going to mention these and go through these quickly, but they're all available online. There are different assessment tools. There's the TRACK assessment tools, which is the Transition Readiness Assessment Questionnaire. We use that in our program. There's the IBD Self-Efficacy Scale for adolescents. NASPGHAN has an IBD transition checklist, and the National Healthcare Transition Center has a program. So the TRACK Readiness Assessment is a 20-item measure. It uses a Likert scale, and there are 5 subcategories. And this information is very useful to the healthcare provider in assessing where an individual patient might have deficiencies and need special assistance in terms of gaining the skills to transition. There were this is a survey of a little under 200 patients, and there did not seem to be a correlation between the scores and the duration of disease or the physician global assessment, but older children and girls scored better, which is not a surprise. These are some of the scores that you can look at in TRACK, and some of the questions that assess transition readiness, and also some of the scores that people did worse on, like calling the doctor was, it was not as strong as if you look at, answering questions asked by the doctor. Most people could do that. People had a harder time with applying for health insurance coverage when they were adolescents. And if you look at there really was no correlation when you look for age between TRACK scores between adults and children, but older age seemed to be a better predictor of a higher TRACK score. But there was no difference in hospitalizations based upon the TRACK score within 6 months. The IBD self-assessment is a 13-question survey, which is also a Likert scale. It's disease specific. It's validated in adults. Younger children, it didn't do as well. You can see that these are some of the questions that are asked about knowledge about the disease. And then the NASPGHAN transition checklist is a checklist that we can use as clinicians for different age children, for early adolescents, for middle adolescents, late adolescents. So you can this is all available online, and you can go through this checklist with patients, and then you can identify where their deficiencies are. And the National Healthcare Transition Center, again, has a transition policy. There's an assessment for transition readiness, and these are resources that are available online that you can use for families and the patients in terms of discussing transition. And there are also information for patients about what they can do for transition. And then, one of the questions is, how do you find an adult gastroenterologist who feels comfortable seeing patients who have childhood onset IBD? Not all adult gastroenterologists feel as comfortable with this. And so NASPGHAN, our society, has prepared a list of doctors, adult gastroenterologists, who are comfortable seeing children. And this is available online. So that it's called Docs for Me. And so to take care of your patient who's moving to Chicago, you have some resources that you can look at. And I would encourage you to do the same thing in the Kingdom, because there may, as you make this transition, there may be physicians who are more interested in seeing patients who have childhood onset. And this is, again, it's a web-based system. So what endpoints are meaningful? So hospital and surgical, healthcare utilization, medication adherence, patient satisfaction, parent satisfaction, physician satisfaction. These are all endpoints that are relevant. But the ECHO group identified outcome measures to define a successful transition in IBD, and this was also done by a Delphi methodology in the Netherlands. And the endpoints that I think that seem to be relevant are that they mostly pertain to self-management and autonomy. No specific IBD marker was felt to be relevant. It was all related to self-management, independent decision-making, independent communication, and patient satisfaction. These are the issues that we need to work on. And there's a variety of interventions. There are programs, there are structured focus transition online opportunities. And then there are joint pediatric adult clinics that may be beneficial. But several studies point that these interventions result in in improvements in self-efficacy, patient satisfaction, self-reported health outcome independence, and medication adherence. So intervening does make a difference. It's the, Peter Pan, famously, I don't want to grow up. And this is a hesitancy that really involves many parties. So parents, patients, healthcare providers all need to be involved to help the adolescent and the young adult with IBD to grow up and assume responsibility. And the other part of this for our job is the transfer of medical records, which is often deficient, and this really falls on us. And I would encourage you all, if you're interested, to think about making a flow sheet that captures this information. So patients and parents have shared concerns. They're concerned about whether the quality of their care is going to be as good with an adult gastroenterologist. Pediatric gastroenterologists often have a long-standing relationship with their patients. They've been through, many different, flares and crises and concerns about educating parents about a chronic illness. And so there's always a concern: is their care going to be as good? And then the issue about parent involvement may inhibit the development of the patient's self-engagement skills. So how can we improve this this process? So we need to recognize that pediatric IBD patients are at high risk for gaps in care and increased disease morbidity as they transition and transfer to adult-centered care. That the formal transition, a formal transition program will help to improve the continuity of the care and will mitigate risk during this transition in care. So formal programs with defined objectives and measurement tools, using the track and the different school tools to assess development, involving multidisciplinary care. There's no perfect model. There are limited data on what is successful and what works. And I would encourage all of you to begin this process of looking at your own healthcare system to find out what works in the kingdom, and be innovative. Gather data. It's the old plan, do, study, act. Look at the data and then make an intervention to see if you can improve on the outcome, because it is really a critical part of caring for our patients. And then there's this famous saying, give a man a fish, feed him for a day, teach a man to fish, feed him for a lifetime. And that really is our goal as pediatric gastroenterologists. Thank you very much.
Thanks a lot for Dr. Herland. And now we start questions.
Let me see.
Thank you very much, Professor Harlan. The question now in Saudi Arabia, the age limit is 14.
Yes.
Transfer surface from pediatric to adults. And most of the time in our experience, we don't have data, but in our experience, parents are hesitant because still these are young children, 14 years of age. They are hesitant to go to adult surface because we claim that we are treating patients better than adult physicians. So how would you think in solving such an issue?
Well, when do you transfer patients? As I recall, it was at a younger age. When do you transition to adult GI?
14.
14. Well, I think you need to talk to the government about that, because 14-year-old to an is not optimal. I don't think
The sound is interrupted. من عنده هو.
Dr. Winter, the sound is not clear. I think you have problem in the connection. ايه بوقف الكاميرا عنده علشان
نقدر نفتح السيشن اللي بعده الان قبل.
اي ممكن
نفتح اللي بعده. الدكتور مالك.
طلع قطع عندك.
قطع خلاص.
اوكي دخل مرة ثانية. إيه. دكتور وينتر, I think you have problem. Can you unmute yourself? طلع مرة. طيب.
Can you hear me now? Can you hear me?
Yeah, it's good now. Can you repeat the answer,
It's good
please?
now. Okay, I think we lost. Yeah, so let me. I know we lost the connection during the answer. So I was saying, I think transitioning a 14-year-old to an adult gastroenterologist is not optimal. And I think that you need to, if you can involve the families, your Academy of Pediatrics, government officials to say it's that patients with inflammatory bowel disease or diabetics or cystic fibrosis patients but especially IBD patients, that they should be followed by a pediatric gastroenterologist until I would say 21, and then maybe you can compromise on 18, but I would say 21, and then people will not necessarily accept that, and then you can compromise and say 18. Most children who are 18 are done growing. Not all of them are, but most of them are, and I think that then you for setting up a transition program with the adult gastroenterologists for patients who are 14 or 16 to 18, where you follow them together. But I think transitioning a 14-year-old to an adult gastroenterologist, at least to the adult gastroenterologist in our program, would not be very well liked by the patient or by the adult gastroenterologist.
Thanks a lot, Professor Herland, for your elaborate and useful lecture. And
can you hear me all right?
Yes.
Yes. Yes. Thank you.
Okay. First, can you introduce the second speaker?
Okay. The second speaker will be.
Okay. Thank you, Professor Herland.
Thank you. Thank you.
Thank you.
Thank you.
Introduce the second speaker. دكتور بدر.
ايوه بروفيسور.
دكتور بدر السليم.
Second speaker will be Dr. Badr Salim. He is associated professor in pediatric gastroenterology and is in King Fahd Medical City, Riyadh. His talk will be about nutritional management, different approach. Welcome, Dr. Badr.
بسم الله الرحمن الرحيم. أولا شكرا على الدعوة، جزاكم الله خير. بسم الله الرحمن الرحيم. So we'll talk about nutrition, and as you know, nutrition is involve all the stage of management of child and with IBD. So since afternoon we are talking about different stage in management or different period in management of IBD. As you can see, in nutrition management, it's involved from the beginning up to the end of the management of child with IBD. So I'm going to talk about the prevention, nutrition and prevention for IBD, and then during the involvement of the IBD and about general aspect and for nutrition for IBD, and during the active stage and what's about during remission and what's the better management and regarding the nutrition status. As you notice, malnutrition is a common problem, and a lot of factors involved in the malnutrition, which is difficult to manage. Some of them related to the medication, and which lead to abdominal pain and nausea, and or reduce the food intake secondary to the prolonged restriction with diet or hospitalization, and impaired also with the epithelial transport, and also related to the malabsorption, which is reduced secondary to bacterial for growth and other factors. So there is a lot of factors which is lead to more challenges to control the malnutrition in child and with IBD. And this is one of our my patient and with Crohn's disease, and you can appreciate how much he was malnourished, and she was 12 years old. And so it is malnutrition is a big problem, and it is a challenging problem in management of IBD, especially of Crohn's disease, which is involved a lot of part of the GI tract. Malnutrition, it is increase the risk of emergency visits, increase the risk of hospitalization, and increase the risk of emergency surgery, and increase the risk of length stay in the hospital, increase also the venous thrombosis. So it is malnutrition is something is very important, and management in the child with IBD, and because a lot of problem, plus it is also our patient, it is children, and they need to grow, and you should optimize the growth for them. So malnutrition should be, the screening for malnutrition should be part of our management, and clearly, and it should be also improve the treatment of IBD. And you should look during the nutrition screening, and you should look to the malnutrition and try to prevent and also treat the malnutrition deficiency, osteoporosis, or other problem, control or look for the micronutrients deficiency, and also control, look for the growth and short stature. Is another child and with Crohn's disease, and you can see how much it is in the height of near to the chair, which is also, she is another 12 years old. So there is a lot of theory about nutrition and IBD. The two famous theory, which is the microbiota, and the other it is involved the host of immune system. So it is through the microbiota, which is change and lead to epidemiogenic modification, and through change the microbiota of the GI, or through the immune host, and which lead to increase the intestinal permeability and decrease the thickness of the mucosa, and lead to the change in the immune system, which lead to increase the regulatory T cells, and increase the immune and the pro-inflammation marker, plus increase the TN factors. Food with like Western diet and given to mice and show it is lead to this change and of the mucosa. First, so what's about prevention? Is there any food which can prevent the IBD? Unfortunately, there is no food that can prevent IBD. There is a lot of study done on the nutrition and risk factor of IBD. There is a lot of study. I will discuss 3 famous studies and done on this issue, which is the first one, which is this study, which is discuss or evaluate they did systemic review of dietary intake, and they looking for nutrients as nutrients and lipid, protein, and carbohydrate, and look as also fat food groups like fat, fruit, vegetable, and meat. And this is the number of the patients included in this study, and with control about 4,000. And they review all the risk factors, and they reach with the conclusion of that increase the risk of ulcerative colitis and Crohn's disease was associated with increase of omega-6 and meat, and also decrease the risk of the inflammatory bowel disease, but especially Crohn's disease and ulcerative colitis by the increase the fruit and fiber. Another famous study, which is the EPIC study, which is involved 229,000 children and patients, and they looking for especially the fat, and looking for especially the omega-6 and omega-3, and then they do control and of the children and develop ulcerative colitis and with the control, and they found that highest quality of intake of linoleic acid associated and with increased risk of ulcerative colitis. Also, they notice also that food with rich of omega-3 and low in omega-6 associated with decreased risk of Crohn's disease and ulcerative colitis. The third famous study, this is the famous study, the fiber and fruit and vegetable, and they noticed that the ulcerative colitis, the increased risk of ulcerative, decreased risk of ulcerative colitis associated with increased the vegetable, and Crohn's disease associated decrease with increased intake of the fruit and fiber. Definitely breastfeed, it will decrease the risk of IBD, alhamdulillah, and there is a lot of studies show this conclusion and the relation between the breastfeed and the risk of the IBD. So in conclusion, regarding the prevention, there is no diet that can prevent the disease. So what's about if the child develop IBD? If he develops IBD and he need general nutrition management, and include, you should look for the energy. So usually the energy it need similar to the other healthy patient, but protein they need and during the active disease and higher, but during the remission state they need like the healthy children. You should try to prevent the dehydration of the children and with IBD, because it is increase the risk of venous thrombosis. You should look for the micronutrients and deficiency, and you should consider that some of the nutrients deficiency, it may affected and by inflammatory like this ferritin and copper, or it may decrease and like folate or selenium and zinc, and so it may give false positive or false negative result. But you should look for those, because it is very important and for growth and also for immunity. One of the most common problem, and especially the micronutrients, it is the anemia, especially iron deficiency anemia, which is common in children and with IBD. You should look for the anemia, and there is a good guideline from the ECHO regarding how to manage a patient and with iron deficiency anemia and IBD. And this is the stage, and if the ferritin is less than 30, definitely this is iron deficiency anemia. If the patient has high and active disease and the ferritin between 30 to 100 plus saturation is less than 20, this is diagnosed. But if it is more than 100, so most likely the patient have combined iron deficiency anemia and chronic anemia. So you should manage them with iron intravenously, better than iron orally, especially if the patient have active disease or iron below the 10 or 100. And if the patient need erythropoiesis. You should look for the B12, which is this another common micro deficiency in children and with IBD, especially if they cut more than 30 centimeters from the ileum, and you should monitoring the B12, and if it is determined he need it for FR. So what's about what's about the management, exactly not general, the specific management and for patient and with active inflammatory disease. What shall we do for him? You should consider him as any other patient and with malnutrition, and you should look for concentrated first on oral nutrition support. And if it is failed, then you should change the diet to enteral nutrition or enteral feed, especially if the patient had not enteral feed orally, it is not possible, or if there is any obstruction in the bowel, or when there is complications such as leakage. So you should shift him from enteral feed to parenteral nutrition. So, or if the patient is going for emergency surgery, so we should start him in parenteral nutrition. No need to use MBO, and also no need to use any specific additives like glutamine or omega-3. What's about there is two methodology, which is elimination of the food and exclusion, which is exclusive and elimination, or there is exclusion food. So exclusion food, there is no recommendation about this, or there's a lot of study, but regarding from the guideline from SBGN and NSBGN and from ISBN, there is no recommendation, and so there is a lot of study done on exclusion diet, and include the special carbohydrate and fructose oligosaccharides, gluten-free diet, and food map and omega-3. So still there is no clear evidence that it will lead to induce the remission of children with active IBD. So exclusion, so there is no IBD diet and can be used and to induce the remission and for patient and with IBD. And exclusion, it should be only for problem or to relieve specific symptoms which is associated and with specific problem in the child with IBD. There is a lot of exclusion diet, like this called Crohn's disease trait, and there is another one which is called SCD, which is exclude the specific carbohydrate, and there is another one which is called Crohn's disease exclusion diet, and which they exclude meat and saturated fat, gluten, and a lot of food. But still, there is no recommendation. But this diet, especially, there is a lot of study, and most of them in their favor of induce remission and for patient. So this, especially this diet, it may replace exclusive enteral feed. So now the recommendation, and up to now, it is exclusive enteral nutrition. It's not partial enteral nutrition. And this is very important because most of our children under nutrition, they're going to use steroid. So now the recommendation to use exclusive enteral nutrition, and which better to be used orally. But if the patient is unable to take it orally, you can use enteral and nutrition and with nasogastric tube, and better to go slowly and by bump. And there is no difference between elemental food and non-elemental, so you can use non-elemental, which is more taste and for children. So also no need for any additives and to use it with enteral nutrition. And the study show that even the growth factors, it's not to change anything with enteral nutrition. It is not approved until now and for patients with active ulcerative colitis. Probiotic can be used and in the mild to moderate ulcerative colitis, and but not to patients with severe active ulcerative colitis, and can be used as treatment and preventions and for bronchitis. If the patient then have fistula, and so if the fistula with high output, or especially if it is proximal, then you can use MBO and TBN, and which it will solve the problem. Surgery and malnutrition. Surgical and malnutrition is also emergency. If the patient going for emergency, you should use enteral nutrition. But if it is going for elective surgery, you can delay the process as much as possible, because there is a lot of risk, increased risk of factor, increased risk of fistula with patient with malnutrition. So what about if the patient and now in the remission, is there any diet? It is the same. There is no specific diet that can be used, and for patient on in remission, and which it will prolong the period of remission. And so also there is no approved and that any supplement and can be used, and when in the food during the remission, it will prolong the stage of remission state period for the patient and with IBD. And so you can treat him and as any other child, and with standard diet or oral nutrition support. Thank you.
Thank you, Dr. Badr. It's very interesting and useful lecture. We go to Dr. Amira Al-Qahtani. She is Fellow 3 in King Faisal Specialist Hospital in Riyadh, and her talk about IBD and congenital chloride losing diarrhea. Welcome, Dr. Amira.
لا ايه عادي.
بسم الله الرحمن الرحيم. Good evening, everyone. And I want to thank organizing committee in SESPIGAN for their great effort. Today, inshallah, I will talk about inflammatory bowel disease and congenital chloride diarrhea. I will start with a real case which was seen in our hospital. He is a male infant, was born at 37 weeks to related parents. There is history of maternal polyhydramnios was noted on prenatal ultrasound. After history of failure to thrive, chronic diarrhea from birth, unchanged by feeding adjustment, and multiple admission with dehydration and electrolyte imbalance, in first week of life, the patient was diagnosed with congenital chloride diarrhea based on genetic tests, which showed common mutation was detected in both copy of the salt carrier 26 gene member A. The patient was managed with potassium and sodium supplementation. After that, at age of 10 years, he developed intermittent fresh red blood with his stool. His routine blood work showed anemia with thrombocytosis and low albumin with high inflammatory marker. So we decided to admit this patient to our department for further investigation. In the next day, the patient underwent for upper endoscopy. It was normal. Colonoscopy, which showed aphthous ulceration in the rectum and sigmoid with no pre-anal disease. Histopathology showed active colitis within sigmoid, colon, and rectum. As you can see here, there is crypt abscess with crypt distortion and infiltration of the inflammatory cell with the granulation tissue. So the patient was treated with sulfasalazine for 1 year and he improved. The child had good clinical response with resolution of blood and mucus in his stool and good weight gain. He is off treatment since then. At age of 14 years, a repeated colonoscopy assessment showed normal mucosa with result histological change in large bowel. Now he is currently 23 years of age, remain well and never developed clinical signs suggestive of inflammation of the bowel. He is on sodium chloride and potassium chloride. So I will talk in brief about congenital chloride diarrhea. It is rare autosomal recessive condition caused by mutation in the salt carrier family 26 member 3 gene on chromosome 7. Incidence is highest in Finland, Poland, Saudi Arabia, and Kuwait, with more than 250 reported cases worldwide. The pathophysiology of congenital chloride diarrhea involves the chloride bicarbonate and sodium hydrogen exchange within the distal ileum and colon. The result is impaired absorption of fluid, chloride, and sodium impaired excretion of bicarbonate. That's why it will activate the renin-angiotensin system and increase sodium reabsorption in the distal colon and consequent hypokalemia. The presentation it can cause large volume chloride-rich diarrhea of a prenatal onset, resulting in polyhydramnios, dilated intestinal loop on prenatal ultrasound and prematurity. Postnatally, congenital chloride diarrhea may present like obstruction with abdominal distension and lack of meconium. Congenital chloride diarrhea is considered a medical emergency. It is usually lethal with the first months of life if left untreated. I will ask you a question. Is there any association between congenital chloride diarrhea and inflammatory bowel disease? The answer it will be yes. Intestinal inflammation has only been reported in few cases. The chronic intestinal inflammation seen in IBD is thought to be multifactorial and complex. A genetic predisposition, environmental factor, immune dysregulation with intestinal mucosa, and dysbiosis are all held responsible. The primary genetic defect in congenital chloride diarrhea may affect the individual with more risk to development of inflammation. This is regarding the effect of acid-base status on development of inflammation. The chloride, as you know, rich stool in congenital chloride diarrhea has low pH. A complex association between change in acid-base status and inflammation has been seen in critically ill patients. A similar mechanism may contribute to the inflammation seen in the colon of the patient with congenital chloride diarrhea. Based on that, we did our literature review, and I found this case report was published in UK by Dr. Harris. He described a case of patient with congenital chloride diarrhea who was diagnosed with Crohn's disease after persistent anemia and rectal bleeding. Here, this is article was published in 2018 of March. It showed there's association between tumor necrosis factor. It acts on the same time with the salt carrier family 26 member, and it reduced its expression, leading to the intestinal inflammation. So, in inflamed chronic mucosa, salt carrier 26 family member A3 is now regulated. Diarrhea-induced cell stress at epithelial level may also contribute to the development of inflammation. This is retrospective analysis of 36 Finnish patients with congenital chloride diarrhea. They describe one patient with a Crohn's disease and another with unspecific colitis. This is nice paper was published from Great Ormond Street Hospital in UK. In July 2020, it is reported 4 cases of patients with genetically confirmed congenital chloride diarrhea. The first girl had granulomatous colitis with ulceration. She went to remission with combination of steroid and azathioprine. Immune suppression was subsequently discontinued without a further flare-up of colitis. A second girl was found to have patchy inflammation change in the small bowel and focal active colitis. A third patient, his boy, demonstrated mild inflammatory change in the small bowel with apoptotic debris and mild inflammation of the colon. A fourth patient did not develop any intestinal inflammation. This another paper look for incidence of inflammatory bowel disease in the patient with congenital chloride diarrhea. The total of the patient was 72 patients with congenital chloride diarrhea. 12 patients, around 16%, demonstrated chronic inflammation. 9 of patients with Crohn's disease, 2 with ulcerative colitis, and 1 with IBD-like colitis. Among the 12 patients of IBD, 5 of them were on biologic treatment, another 5 on immune suppression medication. The last 2 patients, 1 of them on 5-aminosalicylic acid, and the last patient was off of a treatment like in our patient. So my home message to you are: IBD associated with congenital chloride diarrhea present a diagnostic and therapeutic challenge. The clinician should be aware of bowel inflammation as potential cause of failure of congenital chloride therapy to control bowel symptoms and the need for immune suppression. The etiology for bowel inflammation in this group of the patient is likely multifactorial, and further insight is needed to understand the underlying pathomechanism to allow timely diagnosis and targeted therapy in this already challenged group of the patients. Thank you.
Thank you, Amira, for this good presentation. We will go to Dr. Hiba bin Omar. She's assistant consultant in pediatric transplant hepatology in King Faisal Specialist Hospital, and her talk about how to monitor biological therapy. Welcome, Dr.
Ladies and gentlemen, good evening. Thank you for the organizing committee for this opportunity. The last topic of today will be about how to monitor biologic therapy. In the area of step-down approach, I chose this topic. I have nothing to disclose. My outline today will be about pharmacokinetics definitions. We need to know some definitions to know the management algorithm, primary non-response, secondary non-response, mechanism underlying non-response, therapeutic drug monitoring, include reactive and proactive approach, dose optimization, combination therapy, and when to switch to other classes. Antibodies to infliximab are associated with decreased drug level, higher risk of infusion reaction, and shorter duration of response. Although adalimumab is a fully humanized anti-TNF drug, it's still susceptible to development of anti-drug antibodies. It's worth to mention that infliximab monitoring should be as a trough level 24 hours before the next scheduled dose, whereas adalimumab may be monitored at any time of drug cycle due to more instability and steady level of the sub-Q administration. This nice systemic review was published in 2020 in the Journal of Pediatric JPGN. As we know, the standard definition of infliximab treatment is 5 mg per kg at 0, 2, and 6, and then every 8 weeks as a maintenance therapy. They recommended to have a higher dose in a young age group, more than 5 mg per kg, or dosing interval shorter than 8 weeks, aim to reach and maintain adequate infliximab level, trough level, which is more than microgram per ml. The gray area represent the trough level, the appropriate one between 3 and 7 microgram per ml. And in the other two graphs, we can see that infliximab level less than 3 microgram per ml associated with poor response with high disease score activity and higher C-reactive protein, while C-reactive protein more than 3 microgram per ml associated with decrease in the activity score and decrease in the risk of treatment failure. Therapeutic drug monitoring is defined as an evaluation of drug concentration and anti-drug antibody level. Optimal serum concentration results in improving availability of the drug to reach their target and improve effectiveness. It's a promising tool in clinical practice, especially in pediatric patients who have pronounced fluctuation in their pharmacokinetics of the drug. How about reactive and proactive approach? Reactive means when we measure therapeutic drug monitoring while the patient have active disease. While proactive is the it's a very optimistic strategies and novel strategies when we measure trough level while the patient in remission. And this is specifically important when we treat patients with high risk and poor outcome. These are two proposed management algorithm in pediatric IBD on anti-TNF treatment. When you have active disease, you should look for the TDM and the antibodies. And then I will talk briefly about the 3 definitions of pharmacodynamic failure when we have a therapeutic level. At this time, you need to switch to non-anti-TNF agent. If you have pharmacokinetic failure, that means you have subtherapeutic trough level, but no antibodies. So you need to escalate your dose. Immunogenic failure, when you have subtherapeutic level and positive antibodies, it's dependent on the antibodies. If it's moderate antibodies, you need to optimize the dose or consider immune combined therapy with immune modulator. If the antibodies are high, just switch to another anti-TNF out of class, like ustekinumab or vedolizumab. Primary non-response defined as a lack of response to the induction phase of therapy. Excluding the acute severe colitis, primary non-response should not be defined before 14 weeks following initial induction with infliximab and 12 weeks for adalimumab. There are several factors relate to the primary non-response include high body mass index, severe disease, presence of antibodies, absence of immunomodulator, patient with UC with no serum albumin and hemoglobin level at initiation of the anti-TNF, or Crohn's disease with fibrostenotic disease, previous surgery, or longer disease duration. Secondary loss of response, when you have previously responded to biologic and they developed a deterioration in the disease despite the scheduled therapy with the biologic. Estrogen proposed cutoff value for when approaching loss of response for infliximab trough level between 4 to 5 microgram per ml and the high antibody titer more than 9 microgram per ml. For the adalimumab trough level of between 5 to 8 and antibodies more than 4. 10 to 30%, they do have primary non-response. Up to 50%, they will develop secondary loss of response, and 2/3 of them usually in the first year of treatment. The estimated annual risk of loss of response of infliximab, about 13% per patient per year, and 20% for adalimumab. Mechanism underlying non-response, drug characteristic include phenotype, location, and severity of the disease, treatment strategies, and drug-related factors that I mentioned, pharmacokinetics, dynamic, or immunogenicity. Always remember to exclude other causes before you label patient as loss of response. Non-inflammatory mechanism like strictures, IBS, bile salt diarrhea, or cancer, non-IBD related inflammation as infections or vasculitis, or if you have adequate level but uncontrolled IBD disease, that means the disease shift of its pathway, or you have severely damaged bowel segment. I will skip this because I have been talked about them. So here, this is a very good proposed treatment algorithm for induction therapy with anti-TNF. First of all, post-induction scenarios, you have to stratify your high-risk patient, Crohn's disease with perianal fistula, deep ulceration, or a deep perianal fistula or deep ulceration, UC with high inflammatory marker, high CRP, or no albumin. Then you have this is a persistent active disease. When we say that it's persistent, if we pass the 14 weeks of infliximab or 6 weeks of adalimumab, it's basically the induction phase. So you call them primary non-responder, and then you should assess the trough level and antibodies, and then accordingly you will adjust your medication either to switch dose escalation or switch to another anti-TNF class, as I mentioned earlier. Maintenance therapy, again, I will skip the active disease because it will be the same. In remission patient, you have to continue with the same dose. Consider stop the combo therapy within 6 to 24 months. I mean immune modulator. So do the trough level antibodies every 6 to 12 months to guide you to maintenance therapy in a high-risk patient. If you have supra-therapeutic trough level, just consider to do de-escalating and stop the immunomodulator if they are on combo therapy. If you have therapeutic trough level, again, stop the immunomodulator and continue on monotherapy with the same dose. And if you have sub-therapeutic trough level, just follow up them closely, biochemically, endoscopically, and then you can consider send the antibodies again to escalate your dose. Few studies. This study was published in Korea by Choi and his group. This blind management algorithm, I think most of the center use it when we don't have a trough level or antibodies. When we start our patient on standard infliximab treatment, and you have a poor response, usually we shorten the interval to Q6, and then if there is no response, Q4, or just to increase the dose blindly by 10 to 10 milligram per kg. If all of the previous intensification method failed, at that time, most of us we will switch to adalimumab. They found that in group A, In Group A, they have good trough level in Group A, which is the remission group, compared to the Group B with the poor response. And even they have better response after dose intensification. Another studies showed the mean, they measured the mean trough level, serum level. It was higher, around 7.2 in a remission group, and lower, about 4.5 microgram per milliliter in active disease. So again, it supports that the higher trough level showed correlate with clinical response. The same study, they showed negative correlation with C-reactive protein ESR and the activity score, but positive correlation with albumin. Another prospective studies showed here they showed positive correlation with CRP, fecal calprotectin, although there is not correlated with the clinical response. In this study, this is a very nice study. They assessed the causes of treatment failure in 49 patients with IBD, 37 of them with Crohn's disease and 15 with ulcerative colitis. They measured the infliximab trough level before induction, 6 weeks, 14, 22, and 54. And as we can see, if you have a good trough level and at the end of the induction, that will correlate well with the long-term sustained response. This study was mentioned earlier by Dr. Hassoufa. It's an Imagine study. It's a 52 weeks blind randomized trial, phase 3, to assess the efficacy and the safety of adalimumab in patients between 6 and 17 years old with Crohn's disease. They found that the patient on low-dose adalimumab, they have good remission and response, about 18.8% and 47%, while the patient on higher adalimumab, they have higher response and remission rate at 31% and 57% respectively. The same study talking about high, so they found there is a good correlation between the high dose adalimumab and a good trough level before and after escalation. This numerical difference was not seen in the low dose adalimumab. Here, this is an RTC showed the superiority of proactive monitoring of adalimumab trough level on rather than the reactive monitoring. It showed correlation with corticosteroid-free remission, fecal calprotectin, and C-reactive protein. So talking about dose optimization, recently ASPEGAN guideline expert group concluded that infliximab regimen up to 10 milligram per kg per dose may be considered and may be given more frequently than usual. For example, 0, 1, and then 4 and 5 weeks. Of course, we'll have trough level monitoring. This prospective cohort study about intensified infliximab induction, it showed it's associated with improved clinical response in steroid refractory pediatric with ulcerative colitis, and decrease the need of colectomy in the same age group, while there is no comparable data in the steroid dependent or steroid responsive group. Combination therapy, combo therapy with the infliximab should be considered in most patients, especially with patients with poor outcome risk factors, as I mentioned earlier, and usually within the first 6 to 24 months of treatment. And adalimumab should be prescribed as monotherapy. This, I mean, will open area of questions if we, and I would like to ask maybe Dr. Hassoufa, he presented earlier. Most of the adult and pediatric data showed recommended to not to use combination therapy when we use adalimumab. Maintaining TDM monitoring after withdrawing is very important, and the detectable trough level at time of immunomodulated withdrawal should be kept above 5 microgram per ml. Switch of therapeutic classes, therapeutic option for pediatric IBD who have failed anti-TNF therapy are limited, as we know, and novel out-of-class options like vedolizumab or ustekinumab are off-label drugs and increasingly used in pediatric age group. TDM in actual clinical practice, during induction, infliximab trough level of 15 micromole per ml at week 6, and adalimumab trough level of 7.5 at week 4, best predicted likelihood of short-term mucosal healing. Trough level of infliximab of 29 microgram per milliliter at week 2 and 18 at week 6 associated with early clinical response and then and higher first maintenance dose level. Now they start to do it earlier in the first induction, 2 and 3 induction doses, and this is what we call windows of opportunity to plan your future maintenance doses. In Pediatric study, adalimumab trough level of more than 6.7 microgram per ml was significantly associated with clinical remission at week 14. This is the same. So again, should we do TDM when we do de-escalation? The answer is yes. When you have lower trough level and incomplete mucosal healing, that's still you don't de-escalate your biologic. Last few slides, this study showed higher the cutoff for infliximab of more than 5 microgram per milliliter for infliximab and for more than 5.9 microgram per milliliter for adalimumab was associated with perianal fistula closure. Interesting study in pediatric early onset IBD. They reported 4 case series, and they used accelerated high dose infliximab, reached to 22 milligram per kg in order to maintain good remission in those pediatric age group. Their age were between one of them was 2-month-old and the other 2 was 12-month-old. And it showed good clinical remission. Last things worth to mention before going to my take-home message, that now they create point-of-care device to detect infliximab concentration. This was published in October 2020. It will give you the result in 15 minutes. And the previous method that we use is ELISA. And this is what we use in our hospital, but all are sent out. So my take-home message for today is loss of response of anti-TNF agent emergent as a clinically important problem, especially among pediatric patients where treatment options are more limited. In clinical practice, we should focus on optimization of primary response and prevention of secondary loss of response. Exclude other causes of treatment failure is always mandatory before change your treatment. It's time for personalized biologic therapy. One size does not fit all. And the concept of treat to target and tight control and step down to step down. It's redefined treatment efficacy, reinforcing the importance of adequate use of these drugs. Taken together, therapeutic drug monitoring must be seen as a tool aiming to define personalized dosing scheme rather than the conventional weight-based dosing in pediatric age group. So I recommend to do anti-TNF11 and antibody routinely in IBD patient to optimize your maintenance dose. For the new beginner, pilot study showed dosing and proactive TDM was associated with higher remission rate. If you have unsatisfactory response, to escalate or switch. And finally, if you have high-risk patient like Crohn's disease with severe preanal disease, and there is excellent pediatric studies showed higher trough level associated with preanal disease healing. Thank you so much.
Thank you, Dr. Anibal Khtama, Miss Mashallah, it's very nice. So we will go to questions, please, Dr. Badr and Dr. Hiba and Dr. Amir. No. طيب اوكي خلاص.
واشتغل على السايت.
Closing.
طيب اولا نشكركم جميعا على البقاء حتى هذا الوقت، صراحه برنامج دسم وجدتنا بعض المعارضه لدسامه البرنامج والوقت الطويل، لكن هذه تجربه اعتقد انها تحتاج تقييم. اشكركم جميعا، اشكر جميع المتحدثين، جميع المودريترز، ولا ننسى ان نشكر الدكتور ظافر الشهري، فهو الجندي المجهول والمعلوم في نفس الوقت، قام بجهود جبارة جدا من أجل إخراج هذا اللقاء سواء هنا أو على الفيرتشوال فيرتشوال شو يسمونها فيرتشوال ايش؟ كونفرنس ويبينار. وأيضا الدكتور معاذ التركي أيضا هو الجندي المجهول الآخر. طبعا هذا العمل كان يعني قرابة 3 شهور الماضية في اتصالات يومية ومراسلات وإلى ذلك. جزاهم الله خير ونشكركم. وأيضا من الأشياء الجميلة إحنا we have seen new stars. They are the future of the specialty in the kingdom as well as the future of the society. And I encourage all young pediatric gastroenterologists to participate actively in the future meetings. You can communicate مع الدكتور ظافر أو معي أو مع الدكتور معاذ أو أي أحد في مجلس الإدارة. نرحب بالجميع. طبعا احنا حاولنا إشراك جهات متعددة وكان في اعتذارات كثيرة، لذلك يمكن بعض الناس يقولون ليش الشباب كلهم من كينج فيصل أو كذا، لكن في ناس شاركوا من غير كينج فيصل والدعوة مفتوحة للجميع، بس كان الوقت ضيق جدا عشان نقدم على السيمي أورز ونحصل على السيمي أورز. أشكركم جميعا. بس ملاحظتين، الأولى بكرة سيكون فيه إن شاء الله 2 workshops، حنبدأ 9:30 في نفس المكان هذا، فيه يعني قهوة وكذا، بعدين الساعة 10 endoscopy workshop والساعة 11 nutrition workshop. And I urge all fellows and especially junior staff to come and attend. والثاني الإعلان الثاني العشاء، تفضلوا في الدور 12. حياكم الله، سامحونا على أي تقصير.
جزاكم الله خير.